ऐसे रहेगा पोडियम वोडियम पे कि बढ़ाना बढ़ा लीजिए। वी आर लाइव, हम लोग सिर्फ ये स्क्रीन से लाइव हो गए हैं। आवाज साइलेंट होगा, ये रहेगा, ठीक है, ठीक है, ये सही है, सफिशिएंट से ज़्यादा आ जाएगा अच्छी वीडियो। ठीक है, वहाँ का आप कैसे करने वाले हैं? कुछ ऊपर से देने की लाइव कर दिया है स्क्रीन पे, ये स्क्रीन दिख रहा है। नहीं नहीं, 9 उनको 9 दिया था टाइम, लाइव तो पहले से पड़ेगा नहीं तो ऑडियंस देखने लगता है। लाइव का आवाज म्यूट करो सर सर, तो ये ऐसी की आवाज़ है। नहीं नहीं, लाइव में जो आवाज़ है
हेलो 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 हेलो।
Hello, hello. Am I audible, Santosh? So, good morning, everyone. On the behalf of Association of Colorectal Surgeons of India Central Zone, as an executive member, as a president of Academy of Critical Care Medicine Bhopal, as a coordinator of Bhopal Surgical Society, as well as vice chairman of MP, Association of Surgeons of India, I welcome all the distinguished guests, those who have come today, the city of Lakes and Garden, Bhopal, beautiful city of Madhya Pradesh, the capital, heart of India. And I welcome all the delegates for this workshop as well as hands-on training program. I also like to welcome all our chairpersons, all our media partners, as well as the speakers. For today's workshop, we have invited Dr. Shekhar Suratkar. Dr. Shekhar Suratkar is one of the senior most coloproctologist of India, and he was the past president of ACRSI. So I welcome Dr. Shekhar Suratkar. Thanks, sir, coming all the way from Mumbai to Bhopal. I will like to, Dr. Shekhar Suratkar, sir, please come forward, and will like to welcome him with a bouquet. I will request Dr. K.K. Thakur, Dr. Deependra, as well as Dr. Santosh Bhaskar from the Academy of Critical Care Medicine Bhopal. Please welcome Dr. Shekhar, sir. Shekhar, sir, please. Thank you, Shekhar, sir. This, welcome. It is on. So, welcome all of you once again. And today's theme is Beyond the Scalpel, focusing on the ultrasonography. So I have prepared one slide, that is surgeon in OT theatre, past, present and future. What was the past, how our surgeons were doing the surgery. And you can see our father of medicine of India, Shushruta, he was doing the surgery in these conditions. He was using the hand to repair the wound. He was using the various instruments prepared by the stones, because that time technology was not there. And in spite of that, he was performing the surgeries. And what we see today, surgeon in OT theatre, we can see that the surgeon is surrounding with all the latest gadgets. He is utilizing the 3D laparoscopic surgery. He is utilizing the ultrasound machine. He is utilizing the robotic machines, all newer gadgets to make our surgery much easier, much comfortable. And in this way, we are getting the 100% results nowadays. I can surely say that we are getting excellent results by using these gadgets. So ultrasound has revolutionized the patient care, providing surgeons with real-time, non-invasive insight into the human body. And what we are going to see in the future, not in the future, within 3 to 5 years of coming years, when surgeon is going to use these Google lenses, surgeon is going to use these virtual images, there will be no real-time these machines in front of you. Rather than there will be a virtual image in front of the surgeons, and he will be operating by seeing all these thing in front of the virtual images. So this is going to be the future of surgeon in OT theatre. So why ultrasound is critical for surgeons? This is very important, because our today's theme, as I have already informed you, is that beyond the scalpel and focusing on the ultrasound. First of all, hemodynamic instability. because we have to assess the patient in emergency hours at the midnight when nobody is there, and if the ultrasound machine is there, we can assess the patient's conditions, we can assess the vitals by seeing the hemodynamically instability. We can do the fast examination, that is focused abdominal sonography, and we can really at that time we can assess any intra-abdominal injuries, hemoperitoneum collection in all the quadrants immediately. It helps in doing the minimally invasive procedures. We can do thoracocentesis. It can guide you how we can treat the sepsis, follow-up of the patient of septicemia. We can assess in trauma, as I have already told you. And in this way, it helps us to improve the patient outcome. And most of important thing is that ultrasound is easily available, it is very cheap and cost effective. For the colorectal surgeons, why the ultrasound is important? If we can do the transperineal ultrasound, we can get a lot of information regarding the various benign proctology problems like fistula, tract, where is the internal opening, where is the external opening, length of the tract, how much sphincter is involvement. We can do the hypogastric nerve block, we can do the pudendal nerve block through USG guided. It is 100% safe and effective. All these things, transperineal ultrasound, hypogastric nerve block and pudendal nerve block, we are going to cover today in our today's workshop as well as in hands-on training program. So this is the stethoscope, and within 2 to 3 years we are going to see this stethoscope is just like this. There will be ultrasound probe at the tip of the stethoscope. So nowadays this USG probe has replaced our stethoscope. So I welcome once again all of you. I would like to welcome all the delegates, those who are watching entire proceeding through live streaming through the YouTube as well as the other social media. And today I have asked our speakers that they should be tried to straightforward. All the presentation will be case based and it should be crisp and straightforward presentation. So thank you very much. And with this thing, I would like to start our scientific event with the first presentation of knobology. Knobology is very important before starting the ultrasound procedures. And Dr. Santosh Bhaskar, he is going to cover this presentation. Dr. Santosh doesn't require in the, so we'll take it later on, sir, after somewhere between 11 to 11:30 am. So Dr. Santosh Bhaskar is going to take the presentation on knobology. He doesn't require any and he is the Vice President of Academy of Critical Care Medicine, Bhopal. And for his presentation, I would like to invite Dr. Jayant Yadav, one of the senior most radiologists of our city as well as Madhya Pradesh, Central India, and Dr. Supriya Maheshwari. I think Dr. Pankaj has arrived and Dr. Aman has arrived. Yes. So I will request Dr. Aman and Dr. Pankaj, they have arrived to chair the session. And Dr. Aman as well as Dr. Pankaj, both are interventional radiologists and doing a lot of work in the field of radiology. Welcome Dr. Aman, Dr. Pankaj. And now it's time to invite Dr. Santosh Bhaskar. Santosh, please.
किसमें करना है सर?
उसमें होगा एक लाइव नेट है, उसमें नेट कनेक्ट है LAN के बस
लिया
LAN पे।
मैं लॉगिन कर रहा हूँ, उसके बाद डिस्प्ले वो उससे नहीं हुआ, कर देते हैं. Of you. Welcome you all for this course, which was a brainchild of Dr. Sharda to have something for surgeon and specifically for colorectal surgeon. So this was entirely and in totality designed by him. We were having our U-Care where we were talking about use of ultrasound in critical care. Now we have modified it for introducing few topics and introducing few concepts of coloproctology into it and then molded into Colocare, which is this first time we are doing this course for coloproctologists. Earlier we were doing it for critical care experts. So what I have done is I made this presentation on knobology to make you acquainted with the use of ultrasound, how to use it, what not to do, and what should be focused. So before I go, I would like to, we have a pre-test which is online as well. So I'd like all of you to scan this once it comes. Yeah. The barcode over there, you scan it with your mobile phone with active internet. Once you are done, let me know. This we are doing live as well, so even live audience can vote. This is a sort of pre-test which I thought would be pivotal in your knowledge about ultrasound. It must be known to you. So my focus is just to answer those questions which I have included in my pre-test. So that would be, so are you taken to some pages once you are logged in? No, I have not. Have you reached the destination page? Yes. So, if not done, do it. I think there are 16% who have enrolled to this, so that is shown out here, and one have voted as well. 18. So that is most of the online users are login. $22. No, voting I have not yet started since the slide is moved away forward. Okay. So my first question is, which control is used to increase the brightness of the entire image? Options are depth control, gain control, freeze button, or focus control. What is, so you just put your votes. Thank you. 12 have put in the votes, and that shows gain control. 75% of our users know it, that it is gain control, which increases the brightness of the image. Okay, let's see. Yes, the answer is the green colored. And who has done it the fastest is, this will show the leaderboard. We'll move on. Since we have 11 questions, it will change. The second question is, what is the primary use of B mode image in ultrasound scanning? Options are displayed on your mobiles. Four seconds more. Okay. So 92% of the voters have voted correctly. That is to generate a reliable image. It's still Lokesh Vijay. Is he here? Okay. What does the color mode primarily display? Options on your screen or on your mobile phone. Who will be the fast will be marked more. Fastest also counts here. Oh, it's the, no question about this question. All of them has answered it correctly. Next question is, which tool allows you to measure distances on a frozen ultrasound image? Tool. Once you have frozen your image, what tool would you like to use to measure? Some doubt. So the answer is caliper tool. In M mode, what does the display diagram represent? So I just couldn't put the lines. But if you know M mode, what does it tell? M mode ultrasound, if you know. If you have any idea about it, you will answer it. Mostly correct. Thank you. What is the purpose of depth setting in ultrasound imaging? To adjust the brightness or to ensure structures of interest are fully visualized, or to amplify ultrasound signals, or to set the resolution of the image? Okay, some doubts. So I'll clarify through my presentation whatever doubts. Most of the person are correct. Which movement is described as changing the angle of the transducer along its main axis? Main axis. Or the long axis, if I say. Or head to toe. Most of telling it, it's Shilpi has overtaken Lokesh just because of time. Let's see. What does the gain adjustment affect in an ultrasound image? Signal to noise, or the overall brightness, the focal depth, or the transducer frequency? What does the gain adjustment affect? Okay. How does the probe marker assist in imaging? Is there any role? 4 options are: it adjusts the resolution automatically, it controls the penetration depth, it ensures correct orientation during image acquisition, or it adjusts the frequency of the transducer. Okay. Good to know that most of you are correct. So my job would be easier. What does compression achieve during transducer manipulation? Okay. What is attenuation in the context of ultrasound imaging? What do you mean by it? Okay. And when we are trading off between depth and structures view, what is the trade-off when using a high frequency transducer? Okay. What does TGC achieve? Time gain compensation or depth compensation? This is repetition. So probably just answer it. What is the significance of probe marker? Thank you. My God, the chairperson is getting deeply involved. He has overtaken all. Amit Gupta, is he here? No. Shilpi is third who is here. Okay. Thank you. It makes my job easier. And this pretest was designed to just align you to what we are going to talk next. Just aligning you to what ultrasound actually we will be talking about. So now I'll try to answer those directly or indirectly through my presentation. Oh, sorry. So my topic is knobology, physics and instrumentation. So knobology is nothing but just a study of knobs. Whatever knobs we are having on our ultrasound machine, just to get acquainted to you that what knob is for what and what basic knobology you must have to either acquire an image or have some ultrasound use in your practice. A very basic, very bit of physics. I'll not involve much into physics because that will complicate the things further. And instrumentation, how we are going to utilize these knowledge and acquire an image with the use. I have several videos in my presentation since there is no workstation on it. So I'll try to show the videos to make you learn what I'm actually talking about. The basic objectives what I have covered is understanding the basics of knobology, principle of physics, ultrasound physics, whatever is required for instrumentation, and how to practically apply those knowledge. So how sound waves are generated? Any idea about it? So we have something called as piezoelectric crystals, and those are utilized. What is being done is, once piezoelectric crystals are electrified, once you power on, then there is just transformation of energy from one to other. Electrical energy is transformed to mechanical energy, vibration of crystal occurs, and then it produces a sound waves. Those sound waves are transmitted through the body, and once it gets reflected back to the same probe, then the image is acquired. So I'll show how it is actually happening. Once you power on your ultrasound machine, piezoelectric crystals vibrate. It produces sound waves which is transmitted forward through like this way. Then one basic information is, once these waves are generated, they travel the tissue and gets reflected back and again comes back to the probe, and the probe finally digitize the image basis the time the sound wave took from the release to absorption. So I'll show it pictorially in a videographic way, and most of the time ultrasound machine listens. It doesn't produce sound much. It produces sound only for 1% of the time, and 99% of the time it is just listening to the reflected waves, and that helps acquire an image. So like this, once you produce a sound wave, it goes back, and then whatever is reflected back, it listens to those, and that helps acquire an image of interest. So I think this is clear. Then will come about frequency. Deeper tissues are only negotiated using low frequency ultrasound probe, because in your practice, when you come to practice, you will be asked which frequency probe would you like to use for what. So you need to know that if you have organ of interest which is deeper, you'll try to use lower frequency so that it penetrates deep, but the image quality won't be that good as compared to high resolution or higher frequency probe. So this is a trade-off which we always do while picking up the probe. What probe should I pick? And can I do some maneuver to increase or decrease my frequency? Because whatever probes we do have a range of frequency 2 to 4. So there are machines usually allow you to use 2 frequency as well as 4, and generally they are standard set as something between 3. So this is what I try to make you understand. Then this is what I have talked of, how the image is being formed. Once you power on your ultrasound machine, it sends sound waves to the area of interest. Those sound waves which are reflected comes back to the same, and then it is digitized and you are seeing an echo image like this. And it's now a bit of physics. I'll not delve deeper into it to confuse it. Rather, I'll help you go through the slides. This is what we all know. Sound wave have a speed which is constant in a media and which is about 15-40 milliseconds in a soft tissue. So if you remember this formula, speed is frequency multiplied by wavelength. Okay, so that means once frequency is higher, your wavelength is lower because speed is constant. Okay, so that is what is being reflected here. Lower frequency, that means wavelength is more. Higher the frequency, smaller the wavelength. Nothing more than that. Then how you are practically going to use, if you know these three concepts, you'll probably acquire good image and probably try to use it, because this will help you understand how the sound waves actually is working and how it is helping acquire an image. The first is, whatever sound waves we are giving, most of those waves are attenuated. Attenuated is that they are lost, they are reduced, they are lost in so they are not coming back to the probe again. Most of they are attenuated. I'll tell you how they happens. The second is a trade-off between frequency, probe, whatever. If you are trying to acquire a high resolution, then you need to give your frequency, because higher frequency will acquire a good high resolution image. So you always keep in mind that what I am trying to do. If I am trying to have a very, very sharp image, then I'll focus and superficial structures like vein, arteries, nerves, then probably your higher resolution, higher frequency probe will work. So this you always keep in mind. And a word about time gain compensation I'll talk of in my presentation. These are the three things which you need to know. What attenuation is and how it is happening is, either it will be reflected or refracted, or it will be scattered, or it will be absorbed. Absorption usually happens the higher frequency probes we are using in physiotherapy for ultrasound. So there it happens, the ultrasound beams are just being absorbed as a heat energy and helps relieve pain. Scatter and reflection, we know that whatever is reflected, the concept of reflection, and refraction is change in angle of sound waves and going somewhere else. But difference between reflection or scatter is when your sound waves are of wavelength which is higher than the structure of interest. For example, structure is small, like you could see, and your wavelength is more, it will be scattered. Scattered is like reflected everywhere. It's not this way. And so these three things actually attenuate your image. How refraction occurs? When a sound wave travels from one media to other, it gets diverted at an angle, law of physics. About acoustic impedance, impedance is resistance. So whatever sound waves we are giving, how they are resisted by tissue structures. So bone is the highly acoustic impedant, high acoustic impedance, which just reflects back, and the lung also does it, but it is scattering, more of a scattered. About gray white toning, what we get. So whatever image we get on ultrasound is either shades of gray. They are always in the shades of gray. So what deeper shades means, what brighter shade mean is, if you have something called as bright image, that is hyperechoic, then the interface would be very strong and it reflects back directly to your probe. So those are like bone or a stone, calculus. If it is anechoic, no echo, the sound wave just travels through. That is a pure fluid, like water or any serous fluid in your, the sound wave just travels through. Echo is like whatever we heard after reflection, right? Echoes. So hypoechoic is lesser shades of, or and isoechoic is the same shade. What the most of, so it depends on the tissue and its ability to echo, generate echo. So as I talked of attenuation, if you just focus on this formula will help you understand that it is dependent on the tissue coefficient, the distance from the ultrasound probe, and the frequency of probe what we are using. So higher the frequency, higher is the attenuation. These are the coefficient of. Now I was talking about this trade-off between when to use high resolution, when to use low resolution. So I have an example. When we have a structure of superficial structures which are like arteries, veins, nerves, like we anesthesiologists are using it for procedures and nerve blocks. So there we are using superficial probe like this, a linear probe with a high frequency. So as the frequency is high, as you could see from top, what happens is there is a less of scatter, good image, more of absorption as attenuation coefficient increases with frequency, and resolution would be very high. But if the object of interest is something like heart, when we are using a phased array probe, then resolution is not as much as the previous one. It goes down because frequency is low, absorption would be lesser, and scatter would be more. So this is just to tell you, if you forget all the formulas, you have to remember simply that one thing, that higher resolution images, superficial structure, high frequency probe. Okay? If you remember this, the other you can just remind yourself that higher is for higher frequency, then what would be the other. Now I'll come to the final part of my presentation where I'll be talking about probe and its various movements. I have one pretest question based on this. So these are the 5 possible movement what you can do with your ultrasound probe. Those are either you slide, or you rotate the probe at the same position and you are rotating either a clockwise or anti-clockwise. Tilting and rocking. Tilting and rocking are like once you have fixed the probe to the skin, now if this is the long axis of the probe, like a superficial high frequency probe, then this becomes the axis. So head to toe movement of the probe is rocking. Head to toe movement is rocking. Side by tilt is tilting. And compression is when you try to push and when you try to focus and remove whatever in between gels and hard application, and compression ultrasound for our deep vein thrombosis are usually done by compressing. So these are the 5 movements, possible movements of a probe which you are going to do. You must know that tilting and rocking is about the axis of the, either head to toe is rocking, side is tilting, where you are not lifting up the probe, putting at the same point and then tilting, angulating. Angulating this side is tilting, angulating head to toe is rocking. About probe orientation. If you see on any ultrasound probe, it has a marker. And what does it signify? I'll try to show. This is the marker. So what you need to do is, you try to match this marker with the marker on the image of your ultrasound, like this. This is apical 4-chamber view of cardiac echo. And as you see, the marker is here, and as a convention for cardiologist or whosoever is doing echo, this is apical 4-chamber view. If the marker is on this side, what you see the difference. If the marker is on this side, this is left. And if the marker shifts to other, the left will be shown opposite. So you need to be acquainted with the marker probe and position it in alignment with the marker on the image what you are getting. Like as you can see here, this is the probe orientation where the marker is on the left side as well as the probe is oriented. This is conventionally used in cardiology and ICU practice. Whoever is doing ICU echocardiography is doing this way. When you are using convex probe, at times in emergency people are being trained with the use of convex probe and acquiring an image and doing e-fast and all. So at times convex image, convex probe does have the orientation fixed on this side. And if you are not acquainted that, oh my, I am probing like an phased array probe and with a cardiac setting at the back, wherever the setting at the back is abdominal ultrasound and you are utilizing this image, you are probing, then you will get the entire, what you could see is when you are matching the probe with the marker on the image, this is left, this is right. Whereas if you are not matching it, this is left, this is right. This is just a mirroring of the image. So you need to know this, that your probe marker should be matching with the image marker, what you acquire on your image. Moving on. Now few maneuvers what you need to do and learn is, I talked about gain, most of you have answered correctly, how to set up the gain. So I'll show by one video. For example, we are using abdominal ultrasound and this is convex probe, abdominal ultrasound, this is being put out here. The image acquired is this. It's a live image, I have just stopped it. So to label it, since it's at the center looking just directly back, this is the vertebra. Above it is some anechoic shadows like this, fluid filled. This is aorta, this is IVC. So now I'll show the image. Curvilinear probe was used. So now you see this entire portion, what is happening? Darker shades, no information. What is happening out here in the deeper? No information. So if you want, if your desired interest is here, you are getting nothing, no echoes. At those times, you will increase the gain, which is a general gain, top to bottom. It may increase the noise as well. But now what you see, with the increase of the gain, the area of interest is. So with the use of gain, you just get the information simply. That's the simplest knob you use on your machine. Use the gain knob quite often. The drawback is it increases gain everywhere. No dependence on depth. So it will increase the noise as well. So you need to keep in mind, if my area of interest is not visualized, then utilize it. Or you can have another option of TGC. We'll talk later. And if you have done it more, for example, if you have used gain, which is a bladder, if you have used it more, you see the hyper bright images. So that will add to the fallacy if you are not knowing it. The TGC is time gain compensation. How it is different is, it can increase the gain at your desired level. If you desire it at the bottom, you just increase the TGC of the bottom, as you could see. I'll show the image. See the image. TGC it's one of the ultrasound we are using. Many machines have different TGCs. And what you do is, the most superficial is for superficial structure, deeper structure, and then you increase gain accordingly. For example, here you need lesser gain because the whatever sound waves are sent are reflected in a short time and they are forming a good image. It happens usually with the deeper structure or the area of interest is deep. Then you need to increase time gain compensation according to your visualization and area of interest. This is the same 2D echo. What you could see is, this is the point. If if decrease in this TGC gain from structure to deep, you are losing image quality over here, and if you are increasing it, then you are getting more brighter fluids in chambers. So you need to make yourself acquainted with this concept of time gain compensation. Now the third is depth. Knob of depth or a button of depth you need to adjust. So this is the same abdominal ultrasound what we have acquired prior. Now if you look at the image, if my area of interest is this much, so I am looking at this part and actually wasting my sound waves and not helping me acquire a good image. So I'll try to decrease the depth to those area of interest and cut off the uninterest area, so that you get a better or the area of interest at the center of the image. The center of the image are the most desired area where you need to keep your area of interest while imaging. Fourth one is focus. We have focus either as a switch or a knob, and how you focus is, this is the switch focus or the marker of focus. It's moving away. So the area of interest should be at the level of the focus marker. If you are interested in this particular area, the focus switch should be appropriately placed, because once you place the focus at there, from there on the beams become divergent. So it is optical capacity of ultrasound machine to focus according to area of interest. Then is the frequency. I talked of frequency, what frequency for what. So higher frequency for higher resolution and superficial structures, lower frequency for deeper structures. Then comes, if you know all the movements, if you know how to utilize 4 or 5 knobs of an ultrasound machine, then you are, with practice you can acquire a good image, and at least being a clinician you can appreciate it better, because now you know what my pathology is actually am I going to do something good or bad, or how. It even tells you the how to go about. Then is the important concept of documentation. Like I'll talk of 2 things. Freezing an image, you must know it. Freezing an image is helping you to the same old abdominal ultrasound, aorta, vena cava, this is vertebra. Now since I need to measure the IVC, so you can just freeze your image. Freezing is just stopping, and it has some frames which they have kept as a mark. You can move one frame up and down to look at which is the better image, and then put your calipers. So performing a measurement is like, once you have frozen your images, this is caliper in this ultrasound may be differently named in your ultrasound machine. So you must get acquainted to what is it written on your ultrasound. Once you have frozen the image, you have to set 2 points what you desire to measure, top to bottom, and then the ultrasound will reflect what is the distance in centimeters. few words about M mode and B mode. M is for motion. It is to the same ultrasound image. If I apply M mode and put the cursor here, it will just do the imaging of the same line and move away from other things of interest, uninterest. So it is be just looking at one line, and it is giving you over time. The image is built over time. X-axis is time, and now you are getting this image with the ultrasound M mode marker here. What you are acquiring is this M mode. So this is usually done for our practice. In clinical practice, we do for measuring inferior vena cava variability with respiration as a marker of volume. So this is what you acquire, an image on time axis, and you can measure according to the variation. Word about color Doppler mod, which you don't use quite often. As you know that Doppler, like this image, the same image, just switch on the color Doppler mod. It can be either a CDI, like this machine has CDI, color Doppler imaging. You can have different names to the same thing. Color flow is another name for some machines. So you just acquire an image, switch on Doppler, you get an image of this sort. Blue is movement away from the probe, and red is movement towards the probe. As you could see, red is towards the probe. Probe is here, so movement towards probe is red, away from probe is blue. That's the simple dictum. So you acquire such. So where you are usually using is deeper structure, where you are near, you are doing some procedure near nerve, artery, vein. Then you try to locate what is artery, what is vein, and be specific to your. So I'll come to summary. Setting up a B image is, you need to select your probe. You need to know what structure am I going to look, and what probe is better for that, higher frequency or lower frequency. Position your patient, that is one of the most important thing. Ensure patient comfort and optimize positioning for desired result. Use your knobs like gain setting, depth setting, and focus. Gain is to just brighten the image. It will just brighten the image overall. TGC, if you are using, is according to the depth. Gain according to depth. Then depth is what depth you should be. Actually, when you are imaging, there are a lot of structure which is of not of interest to you, and they are deeper to the structure of interest. At that time, if you just come up superficial, then you will acquire an image at the center of the image. So that will help you rule out many nuisance like. And focus adjustment is, once you are focusing, the area of interest should be at the focus level. Whatever focus marker should be at the level of interest, because after that the beam will be diffracted. So coming up to sum up my entire presentation. So knobology is, I have talked about basic settings and modes. And in basic settings, we have B mode, which is brightness mode, where you are acquiring image using all the knowledge what we have discussed, and try to optimize good image before you comment. Then utilize few knobs like gain, depth, and focus. How to do it we have talked of. Gain is for brightness control, depth is for target area focus, and focus is to resolution enhancement at the area of interest. Then modes of operation, we can use color Doppler mode when we are trying to look for vein, artery, nerve, and M mode when we are trying to look something against time plane, one single line, and based on x-axis. So this way we have come to an end. Hopefully I have answered all those queries which I have initiated with the pretest. If not, we'll talk anytime later because we'll be late if we discuss right now. So thank you very much.
Thank you. I think it was an excellent demonstration of all the basics of the knobology, and I have not seen such a simplified version and simple explanation of all the complicated aspects of the ultrasound machine.
Thank you.
I think we can take a couple of questions if we have any.
Anyone?
One thing.
If no question, then there is a problem. हाँ, आप बोले sir.
I just want to add one thing. There sir shows already whenever there are two closely placed structures like arteries and veins, and especially when we do central lines and all. So try to compress the closely placed structure. So whatever is compresses is the vein usually.
Yes.
So because there have been cases of inadvertent entry into the arteries
Arteries.
in central lines. So apart from color Doppler, you just check with the compression also that you are entering the right vessel.
Could you elaborate a bit more on the TGC mechanism? As I've understood from the presentation, gain will just increase the brightness of the image.
Overall,
Overall.
top to bottom.
Overall. So if I want to view only the deeper structure
Usually, हाँ,
a bit more brighter and I want to eliminate the superficial structure, should I use the TGC? Is that how?
I'll say.
Okay.
Superficial structures, since the sound waves are very near and getting reflected from a very short distance, they usually give you a good image. What happens is the attenuation coefficient as we go, distance, as we go the deeper structure, more of the sound waves are attenuated.
Okay.
It's not reflected back. Once they are attenuated, the image quality of the bottom of the image is not good.
Not good.
And if you are trying to focus on those particular depth area, then if you increase gain, what will happen is it will increase at the superficial structure as well, and it will do more harm than good because noise is also
Noise will
increasing
be-
as well as signals. So what you need to do is you can just have you have this option where you just increase the gain at the depth.
Okay.
So that is TGC. The other term is depth gain compensation. So you just do the brightness, increase the brightness from the bottom.
Okay.
So that will help you. Superficial structure will be as if in the prior thing, and the deeper structure will be amplifying.
Thank you.
Thank you. Move on to next.
So thanks Dr. Santosh for elaborating us regarding the basic concept of how to do ultrasound, how to use different buttons, knobs, and the basic concept of all the knobs. Thank you, Dr. Santosh. And I am thankful to Dr. Pankaj as well as Dr. Aman for sharing the time with us. I will request Dr. Shyamlal to please present a memento to our chairpersons. Dr. Pankaj, please. And Dr. Aman, please come forward, sir. Dr. Shyam is Professor, Department of Surgery, All India Institute of Medical Sciences. With a flower pot also. Yeah. Yes. Just one, please come forward to help Dr. Shyam. Thank you. Yeah, this one. Take it. Dr. Pankaj, please. Yes. Santosh, now Dr. Santosh, please. I will request Dr. Suratkar, sir, please come forward and present a memento to our speaker, Dr. Santosh, sir. थोड़ी सी बात अभी थोड़ा सा और एक दो लोग आ गए ये पकड़ साउंड का दिए देखो आ गया मेरा So as we are lagging behind the time and we have to cover so many things, what I can do is I am making my presentation very short and I am just giving you the overview of how transperineal ultrasound is important for all the colorectal as well as proctologists in their clinical practice, because this entire topic we are going to be covering with our radiologist friend Dr. Sumit Upreti. So transperineal ultrasound, a perfect tool in the hands of a surgeon. So what are the indication of this transperineal ultrasound for a surgeon? Definitely for assessment of the infective inflammatory pathology like perianal abscess, rectal abscess as well as fistula. To assess the sphincter complex, to know is there any defect in the sphincter, and most important thing is to assess the pelvic floor dysfunction. Although to assess the pelvic floor dysfunction, in my opinion, it is a domain of radiologist. Now, what are the techniques? And definitely we are going to cover this technique through Dr. Upreti's presentation, but I will give you just brief that there is no special probe is required to do the transperineal ultrasound. All the this conventional ultrasound machine is being supplied with the two probes, linear probe as well as this curvilinear probes. 3 to 5 hertz is the frequency of curvilinear probe and 3 to 12 frequency is for the linear probe. So linear probe is usually used for thin and for superficial objects, and curvilinear probe we are using for the bulky patients. If you have got the special probe that is called transvaginal probe or transrectal probe, transrectal probe is used for endocavitary ultrasound. It is very good technique, gives lot of information, but believe me, it is a very cumbersome exercise for the patient because we have to put the transrectal probe inside the rectum and patient won't allow you. That's why I think that the transperineal ultrasound is very good. And in fact, this transcavitary ports they are also costly also. So basically, this is the convex probe. This is the linear probe. So how to do it? Usually, this transperineal probe, this transperineal ultrasound can be done in lithotomy, as we do all our surgery in lithotomy position, or it can be done in left lateral position. We have to keep the probe over the below the symphysis pubis, and we have to try to focus urinary bladder as landmark. Sweep of probe is important. It has been already mentioned. How do we do sweeping in cases of doing the USG by Dr. Santosh. Now, before starting the transperineal ultrasound, one should try to assess what is the normal USG anatomy. Can I have pointer, please? So basically, 4 planes are very important. First is called transverse plane or axial plane, where we have, suppose this is called transverse or axial probe. It divides the human body into 2 parts, upper one as lower one, means cranial part as well as the caudal part. So this is called transverse, and we see the section through cranial part, or we can see through the caudal part. So this is called transverse axis, transverse or axial approach. Then through this plane, we can get lot of information regarding the sphincter. whether the fistula is intersphincteric, whether the fistula is transsphincteric. But if we want to know the length of the fistula tract, where it is going, we have to do the sagittal sectioning. Sagittal sectioning means it is a, we do the ultrasound through longitudinal axis. So this is sagittal sectioning, this is axial sectioning. In sagittal sectioning means we divide the human body in two parts, left part as well as right part. Next is called coronal plane. In coronal plane, we divide the human body into the upper part as well as in anterior part as well as the posterior part. So this is called coronal planes. But to get the lot of information, we have to use the combination of axial plane, we have to use the sagittal plane, as well as we have to use the coronal plane, as well as sometimes the to do the coronal means we have to take the oblique views. Something about the sphincter tear. Before that, this is the mucosa of the anal canal. These all hypoechoic structure is called internal sphincter. And now around this internal sphincter, this is this echogenicity because of the fat, and this line is called external sphincter in ultrasound imaging. So between this internal sphincter and this external sphincter, this space is called intersphincteric space. So this is 12 o'clock position, this is 3 o'clock position, this is 6 o'clock position, and this is 9 o'clock position. So here you can see that this integrity of the sphincter complex from somewhere 10 o'clock up to the 12 to 1 o'clock position has been lost. So this is the image of sphincteric tear from 10 o'clock position up to the 1 o'clock position. This was through the transperineal ultrasound. And how it looks like in transrectal ultrasound, how to identify this echogenicity means this ring is there, means endoscopic ultrasound has been done for us, and this is the endoanal ultrasound, sphincteric defect from 10 o'clock position up to the 1 o'clock position. Now how to do examination? Basic procedure, if the patient is suffering from perianal abscess or rectal abscess, this patient come with very agony, he was very much restless. There was no time to go for ultrasound by the radiologist, just I put my probe there, you can see this is hypoechoic area, means definitely some collection is there. I put the needle, and aspirated it. After confirmation with ultrasound, and then I have confirmed with the, after aspirating, first came out, it should be done as near towards the anal verge, so that if the fistula formation takes place, it should be a simple one. So there are different cases. What I have done, Dr. Sumit Upreti is going to give you different case scenario along with the external picture of the fistula, abscesses, along with these ultrasound images and operative photographs in his presentation. So I am skipping all these things, but definitely I will like to present two interesting cases. First, this lady, she was having abscess. She came to my OPD, and when we did this ultrasound of the perianal region through transperineal ultrasound, nowadays it is said that the one should always do the any radiological imaging, either ultrasound or MRI. Although MRI is very costly one, everybody cannot afford it. That's why the importance of ultrasound is increasing day by day. It is available everywhere. And so when we did the ultrasound, this lady, there was a fistula tract. This is hypoechoic collection, and this tract was going somewhere between 12 to 1 o'clock position. So the patient was having fistula along with the perianal abscess. यदि कोई सोचता है सिंपल पेरियनल एब्सेस है आईएनडी कर देता तो 100% देयर विल बी चांसेस ऑफ formation of fistula formation because it was already there. So this is dictum nowadays. If you are getting a patient of perianal abscess or rectal abscess, try to assess the integrity of the sphincter, try to assess the fistula tract, try to locate it, and the same sitting try to resolve the fistula in ano management. Don't go for simple IND of the patient. But if you are getting some problem, definitely you can do the incision and drainage, come out, and later on you can manage the fistula. So this was the connection. Can you see? Again, another lady. This time, labial abscess without fistula. Here you can see, this is the axial view, transverse view. This is collection, hypoic collection. But this integrity of this fistula, this sphincteric complex is maintained. There is no communication between this and this. So this lady was having only labial abscess. We can go for IND and it was done. Patient improved. So this was the case of labial abscess without fistula. I will just run this short video. You can see. Still images, how fistula look like in USG image. Tract going up, external opening somewhere here, and this is the tract opening into a lock position. So these are the advantages of doing transperineal ultrasound. This machine is available everywhere. One should have a basic knowledge of the anatomy of the anorectal regions. In case of emergency, if surgeon is not able to negotiate the fistula tract, he can instill the diluted hydrogen peroxide and he can assess the length of the fistula as well as the direction of the tract. But there are definitely some limitation of transperineal ultrasound. It is operator dependent. Depth penetration is limited. If the patient is fatty, you cannot assess the supralevator extension. Sometimes edema of the fat planes limits the visualization. And we know that the MRI is gold standard, but it is expensive and its availability is always sometimes limited. So this was just overview by surgeons for benign proctology by transperineal route. And I will like to invite, before Dr. Upriti goes for his presentation, it is going to be a detailed presentation of transperineal ultrasound. I will request Dr. Jayant Yadav and Dr. Supriya Maheshwari, please come forward for chairing the session, because Dr. Upriti is going to demonstrate how he is going to perform the transperineal ultrasound just after the lunch break, because we are having a workshop on hands-on training. And I would like to welcome Dr. Subodh Vaishne. He was past president of Association of Colorectal Surgeons of India. Sir, please come forward. The person who has started advanced GI surgery in central India. I will request Dr. Thakur, please welcome Dr. Subodh Vaishne, sir. Subodh, sir, please come forward. He is our guest of honors for today's scientific conclave. Thank you, Subodh, sir. We'll have a 5 minutes inauguration after the presentation of Dr. Sumit Upreti. Dr. Supriya Maheshwari is one of these senior leading sonologists, and her place is always as a tertiary sonologist. If somebody wants to take the opinion after taking the opinion from a primary sonologist, they like to take the opinion of Dr. Supriya Maheshwari and Dr. Jayant Yadav. He is one of the senior most radiologists of the central India. And in fact, Dr. Jayant Yadav has invented many procedures for the colorectal surgeons. And one of that is, he was performing the fistulogram. Apart from the conventional fistulogram, he was putting the catheter inside the rectum. And 5 to 10 years back, he was giving lot of information, the direction of the tract, length of the tract, where could be the internal opening. So the credit goes to Dr. Jayant Yadav for that. I think nowadays the number of fistulogram has been decreased, sir. Probably because of the invention of transperineal and MRI as well as transrectal ultrasound. So I will hand over the mic to Dr. Jayant Yadav and Dr. Supriya Maheshwari and request Dr. Sumi Tupriti please come forward for his presentation. बाद में करेंगे ना, अभी इसके बाद में करते हैं.
Everybody, I'm Dr. Sumit Tupriti. My today's topic is the transperineal ultrasound, how I do it. Before going to explain how I do it, I just want to mention what is the importance of transperineal ultrasound. First of all, as Dr. Sardas already told about the indications of transperineal ultrasound. First, in the case of perianal abscess or in case of fistula. Second, in pelvic floor disorder, cystocele and rectocele and other sort of pelvic floor disorders. Third is in the case of sphincter tear. It can also be in case of rectal malformation in the newborns to confirm whether it is high type of ARM or it is a low type of ARM. And also sometimes we, as a sonologist, we assess for the assessment of the calculus in the urethra. So technique, how I do it. First of important thing is the history and the external examination. So how I do it, in the history, we just ask the patient the brief history of any perianal pain or any painful swelling in the perianal area, and the external examination to assess for the site of tenderness, site of any external opening or any perianal nodule or any discharge per rectum. Second thing is the patient position. Normally, I do in the lithotomy position. In the lithotomy position not possible, we do in the left lateral position, particularly if the patient is obese and is not able to give the lithotomy position in ultrasound because we do not have any support on the ultrasound as per surgeon as in OT, we do in the left lateral position. And third, transducers and ultrasound the machine. Any sort of ultrasound machine is we can do the transperineal ultrasound, and the transducer is that TVS probe or the linear probe or the convex probe. I will explain the importance of each and every transducers in my next slide. And coming to the scanning technique, first of all in transverse plane and the second in the sagittal plane. These transverse and sagittal plane are usually the screening plane. We just find the where exactly, whether it is pathological or it is total normal scan. How do we do the transverse axial scan? It is just simply by applying our transducer in the transverse plane just below the symphysis pubis and sweeping our the transducer in anterior posterior direction. What happens in transverse scan, because the anal canal is obliquely directed and we just have our ultrasound beam is just have perpendicular to the anal canal, and we get the transverse scan in the whole area of the anal canal. We just cover whole of the anal canal by swiping it from the anterior to posterior direction. And importantly, what we have to see in the transverse scan. I'm just explaining everything in detail. So being a surgeon, you should know what plane is important for the what purpose. In transverse or axial plane, first of all, we would see the sphincter complex. The external sphincter, intersphincteric space, and internal sphincter. Any collection in the perianal area or any fistula in the transverse plane, and its fistula in context with the sphincter complex, whether it is intersphincteric fistula or it is a complex fistula or it is transsphincteric fistula. And importantly, internal opening at O-clock position, at exactly where is the internal opening. We see all these things in the axial plane or transverse plane. Second screening plane is the sagittal plane. Just what we do in the sagittal plane, we just rotate our transducer at 90 degree and swipe our transducer from side to side. Now comes the question, what we have to see in the sagittal plane. It is the same as in the axial plane, except for O-clock position we do not see in sagittal plane. But extra advantage of sagittal plane, we just have to measure the distance of the fistula from external to internal opening, and total fistula track, we have to follow this fistula track, and also we assess the distance of internal opening from the level of anal opening. And I would like to emphasize one important thing. We do not see any dentate line on ultrasound. We just divide the anal canal into the inferior third, medial third, and the upper third. And from there, we can see that whether the fistula is high type fistula or intermediate type fistula or low type of fistula. Again, one more point. Sometimes because anal canal course is quite oblique, we are not able to focus the true distance of the anal canal. We assume that normally in Indian population, the total length of anal canal is approximately 4.5 to 5 centimeter, and approximately 1.5 to 1.8 centimeter is the intermediate or the position of the dentate line. So we calculate such type of manner so that we can assess the fistula is high type or low type or intermediate type. An important thing in this thing, coronal and oblique plane. What is the how we do coronal plane? We just apply our transducer over the anal verge in the coronal plane to access the coronal images of the anal canal. What is the importance of this coronal plane? The side branching of any fistula or any ischiorectal or ischioanal abscess communicating with the fistula, or sometimes a complex fistula can be diagnosed on the coronal plane. And one more is the oblique plane. We cannot follow only these two planes, transverse or axial or sagittal. We have to follow the whole course of fistula by just rotating our transducer in different directions. Now coming from the what is the basic ultrasound machine requirement and what are the transducers we use. My personal preference is that this one is a transvaginal probe. Although it's a transvaginal probe, but we normally apply just over the skin. We do not insert it into the anal canal or the transvagina. We just apply over the transperineal area, perineal root, and just swipe our transducer. So this is a transvaginal probe. This is important for us as being a sonologist because we get very good quality images on the transvaginal probe and very good penetration. Also, sufficient amount of penetration can be achieved with this transvaginal probe. Its footprint is small, so it is easy to follow the path of a fistula. Second thing is that the high frequency probe or a linear probe. Linear probe is useful when you are suspecting very superficial pathology which is not seen on the transvaginal probe, or the exact delineation of the course of fistula is not possible by the transvaginal probe. We can use this high frequency probe. And third is the convex probe. It is also important, particularly if the patient is obese or there is so much inflammation in the perianal area and it is difficult to visualize the tract, then we use the convex probe. Now coming to my slide, how I do it. This is the normal position of the patient. Patient is in lithotomy position. This is my TVS probe. I had just applied the footprint transverse in this direction to at the level of symphysis pubis, and this is the anal opening. I apply my transducer of symphysis pubis. I am just swiping my transducer in the anterior posterior direction, in this direction. I will show in the next video. Here you can see I am doing this transperineal ultrasound by just swiping the transducer. I am not displacing my transducer towards the anal. I am just swiping at the same place in the anterior to posterior direction and just cutting this anal canal perpendicular to my beam, fan-shaped beam of my ultrasound. I am just cutting the perpendicular to the anal canal. So the images acquired will be the such type of this video. You can see this is my transducer, this is symphysis pubis, and this is the anal canal. This is the whole anal canal. I will describe the detailed anatomy of the anal canal in subsequent slides. Now in the sagittal plane. Sagittal plane, I did nothing but just I rotated my transducer in 90 degree and swiping my transducer side to side. You can see my hands. I am swiping from side to side. Same thing here, you can see simultaneously. This is the anal canal. I am swiping my transducer from side to side. I will do it, show it again so that you should learn very well. I am swiping my transducer at the same time. You can see the images also. I am just swiping my transducer, and this is the anal canal. You see the anal canal, this anal mucosal hyperechoic. This is in the coronal plane. This is in the coronal plane. I will show you detailed anatomy afterwards. This is transducer is directly applied over the anal opening, and this is in the coronal plane. This is anal canal, this is sphincter complex, this is perianal area, and this is some abscess there. I will tell you later on after this. Now once we had completed our scan in various planes, we should know the anatomy of the anal canal. As being a surgeon, I am not describing everybody the detailed anatomy of the sphincter complex, but just to summarize, basically we focus on the three things: internal anal sphincter, external anal sphincter, in between the intersphincteric space, and inside is the anal mucosa. This is the axial diagram or transverse section of the anal canal. You can see the whole continuity of the internal sphincter, which appears hypoechoic, or in simple language, it is more of the darker shade as compared to the external anal sphincter. Because of the compact smooth muscle fibers are there, so it appears hypoechoic. That already explained in the knobology section, that what is hypo, what is hyper, and what is iso. Hyper means something which is brighter or white. So this is the anatomy of the anal canal in transverse plane. This is the normal transverse plane pictorial diagram. This is the internal anal sphincter. This hypoechoic thing, this blackish thing is intersphincter. This corresponding image in axial section. This is the internal anal sphincter. In between the internal and external anal sphincter, this is the sphincter. This is the intersphincteric space filled with the fat, and because of this fat, this only thing is the intersphincteric space. Outside this small, thin, or incomplete like isoechoic structure is the external anal sphincter. So basically, one has to follow the golden rule. Anything abnormal coming in the intersphincteric space, anything abnormal which appears hypoechoic or anechoic in the intersphincteric space is always abnormal. It is not a normal pathology. So I am focusing this thing because I am in my subsequent presentation, I will show you all the pathology. Just you have to imagine this picture and remember this. You have to focus on intersphincteric space because 99% of pathologies are in the intersphincteric space. So this is all about the transverse anatomy of the anal canal. Now coming to the sagittal anatomy of the anal canal. On sagittal anatomy, here you can see the same thing. Internal anal sphincter appears hypoechoic anal canal because of the infolding of mucosa, hyperechoic, and this is outer one small thin layer is the external sphincteric space, and hyperechoic thing the intersphincteric space. Similarly, here you can see external anal sphincter, internal anal sphincter, intersphincteric space. Side is the ischioanal fossa, above one is the ischiorectal fossa, and this is the dentate line, what I already explained. Because we do not see dentate line, there is no such anatomical visualization of dentate line on ultrasound. Even on MRI, we are not able to locate the dentate line exactly, which is the anatomical description of any dentate line, because these are the mucosal foldings, not easy to see on the ultrasound or in MRI. We just assume that the inferior third is somewhat here is the dentate line. Now coming to the inference of the images of what exactly surgeon wanted to know from any image. First is the primary tract localization from external to internal opening, from where the tract is going and where it is opening. Second is the total length of the sphincter fistula tract, and third is the course of the tract. The course of tract oblique or it is downward, upward, whatever the tract. Second is relationship of the fistula tract to the sphincter complex, whether it is intersphincteric, transsphincteric, or a complex fistula. And distance of internal opening from the anal verge in sagittal or coronal plane, and O-clock in the axial plane, so that we can comment high type fistula, intermediate, or a low type fistula. Any secondary fistula tract which is communicating with the main fistula tract, or some sort of complex fistula, or any abscess associated with the fistula tract, or any systemic pathology. Sometimes we find SOL, but although very uncommon to find any SOL in transperineal ultrasound. And the important is the pictorial representation of fistula for a surgeon. As being a sonologist, we have to demonstrate all this, but I just wanted to emphasize on this thing. Once I complete my whole of topic, you should know what is the normal anatomy of the ultrasound anatomy of a anal canal. Now coming to my first case, you just see this is a patient having external opening at 11 o'clock position. Somewhat here is the 11 o'clock position opening is there. This is for your convenience. I have mentioned this is a total normal scan. You can see sphincter complex here. This is internal anal sphincter. This is internal anal sphincter. This is totally normal. This is intersphincteric space. This is normal intersphincteric. This is intersphincteric space is normal. You can see a hypoechoic thing is intersecting the intersphincteric space, and it's coming towards the anal verge. You can see this hypoechoic thing, and which is communicating at around 11 o'clock position with the anal canal. This is in the axial still images. Same thing if you see, this is in the sagittal plane. I will show in the, this is not easily visible on the sagittal plane on single scan. I will show in the next slide in form of a video. So again, with the demonstration of the same thing, that is the same patient. This is a transverse scan showing the internal opening. I just emphasized in my beginning that you have to follow that intersphincteric space. This hypoechoic thing is the fistula tract. Otherwise, everywhere you can see the intersphincteric space is totally clear, and it is opening around between 10 to 11 o'clock position. Here, between 9 to 10 o'clock position, this is the internal opening. This is the internal opening at 9 to 10 o'clock position. Now coming towards the video of this image, you can see this is the anal canal, this is the fistula tract, which is coming and angling into intersphincteric space, having internal opening between 9 to 10 o'clock position. Again, I am demonstrating the same video. You can see the anal canal, anal sphincter. This is the fistula tract in the intersphincteric space, entering into intersphincteric space with hypoechoic thing, and opening at between the 9 to 10 o'clock position. So this is the case of intersphincteric fistula. Again, in the sagittal plane here, because my fistula looks to be quite superficial, I am not able to focus on the transvaginal scan, my second previous thing, but I am not able to focus in the sagittal scan. Why? Because fistula is very small in its total depth. It is basically a superficial fistula. You can see here, Now I had applied my high frequency transducer to see the fistula tract. From here to here you can see this is the anal canal. This is in oblique plane. This is my fistula tract, and this is because of the course of the tract I am not able to focus it in the sagittal plane properly. Now in this you can see the total duration, fistula tract is approximately 3.2 centimeter long tract, and from here to here you can see the internal opening of the fistula. You can see the whole fistula. This is the anal canal, anal mucosal folding. Some acoustic come from anal canal because air is there. So you can see the internal opening of the fistula. We just measure the distance from here to here. It is approximately 1.4 centimeter or 1.5 centimeter. So nearly it looks like at the level of the entrate line. So this is the pictorial diagram of this fistula. This fistula is intersphincteric, is somewhat near the dentate line, opening between the 9 to 10 o'clock position. It is intersphincteric perianal fistula. If you classify the fistula, although still it is debatable, but which sort of the classification we have to follow, that 3 or 4 type of classification, but the simple rule above the dentate line and below the dentate line, the management of a fistula for surgeon changes. It depends upon the high or the low type. So imaging, ultrasound or MRI staging of the grading of fistula is not of so much use for a surgeon. Here you can see in my video the same course of the fistula. This is fistula which is opening here. I think starting images is important. This is the fistula and this is opening at the level of dentate line. So this is the intro finding of the same patient. Here is the external opening around 11 o'clock. Surgeon has excised this fistula. This picture courtesy from Dr. Rajiv Sharda sir. He has operated this patient, and this is the whole length of fistula has been excised, and this is the specimen of the excised fistula. Here you can see the whole length of audio not. I will just explain. Here is the external opening, and this whole fistula tract has been excised, and internal opening is located between the 9 to 10 o'clock position, somewhere around the dentate line. So this is another patient. This patient has complained of a painful nodule at 6 o'clock position. There is no obvious external opening seen in such patient. You can see this is again the same patient. I told you importance of swiping from anterior to posterior direction because you have to cut the whole anal canal in the multiple transverse section. You will find pathology at one section only, 1 or 2 sections. The fistula is small, you will find it in one section. Here it appears to be normal, but once I swipe my transducer more posteriorly, here I found the fistula tract with air in the tract and internal opening at around 6 o'clock position. Again, this is anal canal with a mucosa. This is the internal sphincter. This is the intersphincteric space. Here you can see some sort of abnormality in intersphincteric space, and this is air in the intersphincteric space. This hyperechoic thing you can see the air. This is somewhat different from normal fat of the intersphincteric space. I will show in the subsequent slide. Here you can see this is the internal anal sphincter. This is the intersphincteric space. Here you can see the fistula tract at 6 o'clock position. It is opening, and there is air in the fistula tract. You can see the air in this air appears hyperechoic or totally bright with posterior acoustic, some sort of cometal artifact. Here the posterior acoustic is occurring from the fistula opening at 6 o'clock position. Again here this is air and fistula opening at a 6 o'clock position. So this is in the transverse plane, and this is in the sagittal plane. What I focus the fistula tract. The total length of fistula is approximately 2.4 to 2.5 centimeter from external to the internal opening. Here also you can see from 2.2 to 2.5 centimeter total length of the fistula tract. We just like to give importance of this because we just measure the total fistula from here to here, from external to internal opening. But Importance of the surgeon for this, he wanted whether the fistula is high type or the fistula is intermediate or the low type fistula. For such, we have to measure the distance of internal opening from the anal verge. So this distance is important. It is approximately 1.15 or 1.2 centimeter, somewhere near the dentate line or inferior to the dentate line. It is somewhere inferior to dentate line because the fistula appears quite superficial. And this is my pictorial representation of the fistula. This is intersphincteric fistula, and it is opening below the dentate line at 6 o'clock position. So this is the video of this particular patient. You can see this is the internal opening, this air coming in the tract, and this is the internal opening and intersphincteric space. This is the anal canal, this is internal sphincter, this is the external sphincter, intersphincteric space, and followed by this is, last one is the air in the intersphincteric space, demonstrating that it is a fistula without having any external opening. So if you do not find any external opening, you should go for transperineal ultrasound, so that if there is any hidden fistula behind, you can see by the transperineal ultrasound before operating. You should know whether what type of fistula is that, so that you can counsel your patient so well. This is in the sagittal plane or oblique plane. You can see the air echoes coming and internal opening here. This is a fistula tract. This is the normal anal canal, and this is the whole course of fistula. Again,
Scarring mark
this is
or
the voice of Dr. Sharda.
tenderness is aware. Probably this is the tract, but at present there is no external opening. But we can see the internal opening at the dentate line. Here I have introduced my fistula probe and it is pointing out. So this is the entire fistula tract.
This is second side. This is the whole length of fistula tract having internal opening at 6 o'clock position, impending external opening also at 6 o'clock position, where the patient is complaining of tenderness and nodular swelling is there. This is again a patient having external opening at two places. First one is 1 o'clock position, and second having a nodule at 9 o'clock position. There is no such opening at 9 o'clock position, only opening there is at a 1 o'clock position. So this is the external examination part of my study. Now coming for the ultrasound. This is in the axial section, this is in sagittal section, this is again in axial, this is again in sagittal section. I have assessed in two different parts because patient is complaining of the external opening at 1 o'clock and one nodule at 9 o'clock position. So once I follow the course of the fistula, you can see again internal sphincter, intersphincteric space, external sphincter. You can see here at 12 o'clock position, there is one hypoechoic interruption of the normal intersphincteric space. This is the fistula tract. This is the internal opening of the fistula at 12 o'clock position. You can see here, this is the anal canal. This is somewhat oblique, little bit transverse oblique plane. This is the internal opening of the fistula. Here you just see one more thing. At around 9 o'clock position, there is something hypoechoic coming in the intersphincteric space, which is better seen on second slide. Here you can see this is the intersphincteric space, this bright thing. There is one hypo thing coming out. So this is the nodule which is palpable at 9 o'clock position, which is having intersphincteric communication. So it might be there is a separate opening of this fistula, or this fistula tract is communicating with the main fistula at 1 o'clock position. So this is again the main fistula tract. You can see the fistula tract here, and this is the nodule at 9 o'clock position. You can see the nodule at 9 o'clock position, which is coming towards the anal verge. Still I am not sure whether it is communicating or not communicating, but in subsequent video I will show where exactly it is communicating. So as per picture, there are two fistula. This is at 9 o'clock, and this is 1 o'clock position fistula having internal opening at 12 o'clock position. This is the intersphincteric, somewhat near about the dentate line. So coming to the video of fistula, I will first like to show this video. This is in the axial plane. You can see this fistula tract. This is easily accessible. You can everyone can see this internal opening at 12 o'clock position. But another fistula, if you follow this, it looks like communicating with the main fistula. This is a normal fistula tract in the intersphincteric plane, and I will show where here it is communicating with the fistula tract at 12 o'clock. You can see this thing. This thing is superficial and communicating 12 o'clock fistula. The same thing in the sagittal plane. In the sagittal plane, you can see the fistula at 12 o'clock position. Sorry, but opening at 12 o'clock position. Another one is not easily visible on the sagittal plane. It is more visible on the axial or transverse plane. Now coming to next slide, this is the intraoperative finding of this fistula. You can see the fistula tract at 12 o'clock position communicating with fistula at 9 o'clock position, and it's a very small fistula.
Can you appreciate it? Yes, this is the communication.
So I have few more cases. I don't have any surgical follow-up of such patient, but just to understand again, to appreciate the images, and before going for this followed by workshop, I just wanted everyone should know what we have to see during our subsequent direct demonstration on the workshop. So again, this is the intersphincteric space. This is intersphincteric fistula at 12 o'clock position in axial plane, sagittal plane. This is very superficial fistula opening at the level of anal verge, and 12 o'clock is the internal opening here in the pictorial diagram. This is 12 o'clock in the internal opening. This is again the video of the intersphincteric fistula. You can see this is the transverse plane. Now I'm rotating my transducer 90 degree. In the same plane, you can see the fistula opening near the anal verge. And this is the another transsphincteric intermediate fistula. Why transsphincteric? Because it is penetrating the external sphincter. I will show you. This is again the normal anatomy. Again intersphincteric space, something hypoechoic coming on, but it is coming from outside. You can see this thing. This is coming from outside the sphincter complex. So it is a transsphincteric. This is the external sphincter. It is pierced by this fistula, and there is internal opening at 6 o'clock position. It is very well seen in sagittal images or oblique sagittal images. You can see the course of fistula. This whole fistula is coming up to the here, and it is penetrating the sphincter. This is external sphincter. This small thin band is external sphincter. It is penetrating the sphincter complex and having internal opening at 6 o'clock position somewhere near the dentate line. So this is a transsphincteric fistula. Why transsphincteric? Because it has extrasphincteric course and again penetrating directly through the sphincter complex and opening into the anal canal. Not like intersphincteric, which is through and through the intersphincteric space. So again the same thing, transsphincteric fistula. This is the same patient. This is the video of this patient. Here you can see the fistula tract. This is anal canal. This is piercing the anal canal, and we just measure the distance from here to here to comment this is the intermediate sort of fistula. Again in the transverse plane, you can see internal opening. This is the external part. This whole thing is extrasphincteric. You can see behind this hypoechoic thing is going on. This hypoechoic thing is just follow this thing. This is going posteriorly. You can see this thing. It is going posteriorly. So it is a case of transsphincteric intermediate fistula. Now coming something which is not visible from outside, but patient is complaining of so much pain during defecation and tenderness in the anal area. So no external opening is seen. You just have to do a transperineal ultrasound. You will find the internal anal sphincter. There is some sort of collection or hypoechoic thing coming in the intersphincteric space. This is nothing but the internal abscess or intersphincteric abscess, which is not communicating with the anal canal, nor any internal opening, nor any external opening. Here we just measure the total size or volume of the abscess. In the subsequent, the video, you can see This is internal anal sphincter. This posterior thing is collection, which is in the intersphincteric space without any internal opening. I didn't find any internal opening in such patient, just localized abscess in the intersphincteric space only. Now coming to the sagittal scan, the same thing. This beautifully demonstrated abscess, you can see this is the anal canal, this acoustic coming from anal canal, this communicating with intersphincteric space. You can see the communication here. It is communicating with no obvious internal opening, although extending to intersphincteric space, but not communicating with the anal internal opening. No internal opening is there. So this is the case of sphincter tears postpartum history. The sphincter tears from 10 o'clock to 1 o'clock position. Again, you just focus on this thing. There is no continuity of the internal anal sphincter here, and somewhere they are the anal mucosa is just bulging through this defect, and there is thin outline of internal sphincter, which is probably atrophied or because of the sphincter tear. This torn fibers of the internal anal sphincter. Here you can see the total distance approximately 8 millimeter or 9 millimeter. This is another case which is having a sphincter tear posteriorly. You can see the posterior between the 4 o'clock to 8 o'clock position. There is large defect in the internal anal sphincter filled with somewhat intersphincteric fat is there. So it is a case of this is a case of sphincter tear in a postpartum in two separate patients. One is in anterior tear and second is in the posterior tear. Now coming to the perianal abscess, though surgeon can easily evaluate the perianal abscess by per-rectal digital examination, but importance is that if there is any underlying fistula, we have to counsel the patient that there is some sort of fistula or there is some evolving fistula or there is obvious communication of the perianal abscess with intersphincteric space. With time, it can develop into fistula. So it's better to always counsel the patient so that there is no blame to the surgeon that you are not operated it well. So this is again a case of perianal abscess, internal anal sphincter. Why I am focusing every time detailed anatomy? I just want this is basically for a surgeon. So surgeon should know what exactly how internal sphincter, external sphincter looks like on ultrasound. So this is again internal anal sphincter, intersphincteric space, external anal sphincter. There is some collection outside the external anal sphincter, but there is in the oblique transverse plane. You can see the communication of this perianal abscess with the intersphincteric space. Here it is entering into the intersphincteric space. And this is in the sagittal section. Posteriorly, you can see the whole of the abscess. This is again the abscess which is entering into the intersphincteric space, although no obvious internal opening seen right now. And this is the coronal scan of the patient. You can see anal canal. This abscess is extending up to the level of ischiorectal fossa. It is the top end of the anal canal, and there somewhere here is the supralevator muscle, or this whole extent of the abscess up to the ischiorectal fossa. In the pictorial diagram, you can see the whole extent of this abscess up to the ischiorectal fossa. And in the transverse plane, this is the direction. This is the o'clock position of somewhere down around 3 o'clock to 8 o'clock position. There is extent of this abscess. This is in the same patient. This is in the sagittal anatomy. You can see the anal canal. This is the abscess only. This whole thing is the abscess in the perianal area, which is communicating with the intersphincteric space. Again, in the transverse plane, this is communication. This whole hypoic thing with internal echos are the abscess, and it is communicating with the anal canal. So this is the operative finding of the patient.
Ultrasound finding. Now we are going to aspirate it, and now you can see that the pus is coming. We are nearer to the anal verge, so that if the fistula formation takes place in the future, it should be a lower one. This is, you can see that the pus is coming out after aspiration.
This is again the intro of findings of this perianal abscess patient. Now coming to the other patient. This patient has been operated for a perianal abscess 8-9 months back. Now patient has got external opening, at around 5 o'clock position with swelling around the perianal area. This is the normal lithotomy position, and this is the transverse scan. Here you didn't find so much abnormality there. You can see the internal sphincter, intersphincteric space. There is small thin fistular tract you can see here in the intersphincteric area, but if in subsequent slide it is not in continuation, so sometime you will find some sort of artifact. For that you have to scan it twice or thrice in the same swiping method in the axial plane, so that you should be confirmed it should not be any air-related artifact which is overlapped by your probe. So this is the coronal plane. This is the internal opening of the fistula. This again in the most posterior section you can see this fistula tract which is having internal opening at around 6 o'clock position, and the distance is approximately 1.5 centimeter from the anal verge. Here is the internal opening of the fistula. Always fistula not well seen on still images. It's better appreciated on the videos. So this is the fistula is having long extra sphincteric tract. You can see anal canal is somewhere here. I am just following my fistula tract. It's approximately 4 to 5 centimeter long fistula, which is in the extra sphincteric space, but the internal opening is approximately 1.4 centimeter at the level of anal verge. This whole extra sphincteric tract is long. Surgeon has put his surgical probe into this, and he says it's a long fistula, supposed to be very high sort of fistula, but this on measurement of internal opening of the fistula, it is approximately 1.4 centimeter near about the dentate line. So not to be get confused with the total total length of fistula, it can be only in the extra sphincteric space. So here transperineal ultrasound is important in such type of patients. Now this is the video of particular patient. You can see the fistula tract. This hypoechoic thing, this is well formed fistula tract which is going inside the anal canal. Here you can see this is anal canal, this is internal opening. You can see the internal opening here. This is in the axial plane. This posterior most thing is not well seen on, in particular this patient is little obese and has some scar or the past surgery. This scar has been some limitation on doing the transperineal ultrasound. Particularly scar is somewhat overlying over the fistula tract, and it's difficult to focus on single plane. But in oblique plane we can easily overcome the scar tissue. So this is in the oblique plane which I had overcome in the scar tissue, and see the whole length of fistula. It is going up to sternorectal fossa, again turning inferiorly and somewhat opening. You can see it going up to here and going inferiorly, and the hockey stick like appearance, and somewhat opening near the dentate line. So this is another a transsphincteric fistula with a long extra sphincteric course. Patient is having two external opening which are intercommunicating with each other at around 2 o'clock position. Here you can see the anal canal. Again, this is a normal anal canal, the same patient, but once we move our transducer posteriorly, we will be able to demonstrate the fistula tract opening into the anal canal at around 6 o'clock position. You can see the fistula here. This is internal opening, and this is intersphincteric space. Here the sphincter fat plane has been obliterated by the fistula course. You can see it here. Again, the fistula course is going like this and having internal opening of the fistula. So this is the whole extra sphincteric course of the fistula. This is another patient which I have demonstrated previously. It has got much more higher, and this is somewhat inferior to that previous fistula slide. So you can appreciate the whole length of fistula going, and this is in the oblique plane and having internal opening at 6 o'clock position. Here you can see the coronal, here you see the fistula. This is internal opening of the fistula. You can see the internal opening fistula. Elsewhere everything looks smooth, here also smooth, but here is the internal opening of the fistula, and total distance from here to here approximately 1.2 centimeter. So it is somewhat intermediate or the lower type of fistula. but extrasphincteric course is so long. Now, in the same patient, this is the internal opening of fistula, and this is the fistula tract. Here, and this is in the axial plane, you can see. This is the anal canal, this is the internal opening, and this whole thing is the fistula. And this is a pictorial diagram of such patient having long extrasphincteric course and having internal opening near the inferior to the entrate line. This is the intra-op photograph of the fistula, same patient, and two external opening communicating with each other. And the long fistula has been demonstrated by a surgeon. You can see the whole length of the fistula tract is long extrasphincteric fistula. This is another patient. He has got fissure in ano, but has some palpable swelling at around 9 o'clock position. Surgeon just wanted to confirm whether it is a normal or it is abnormal, because patient is having so much discomfort in this particular at 9 o'clock position. She felt like there is some SOL or mass going in the anal carrier. So ultrasound has been done. Ultrasound find totally normal. This small hypoechoic thing is because it is a female. Some sort of fibers near the perineal body is there. So you can see such type of finding in fistula, particularly anteriorly. This is the sagittal plane. Transperineal ultrasound is totally normal in this patient. Patient has been operated for fissure in ano, but patient insisted to operate this swelling also. So here comes the images of this patient. This is a normal transperineal ultrasound of the patient. You can see. Looks like perfectly normal. This is the sagittal patient, perfectly normal, and this is the intra-op patient. There's nothing at the site of swelling, just have empty cavity here. So this is a total normal transperineal ultrasound in a patient with palpable nodule with fissure in ano. And this is very interesting case. I was there during the surgery, so let me explain in detail of this patient. This patient is having external opening here between 1 and 2 o'clock position. There are two external openings. One is scar one, second is widely open. External opening is there. Once I perform the transperineal ultrasound, there looks like a long transsphincteric fistula having external opening there at the same position between the 1 or 2 o'clock position, and the long track of fistula with this is transsphincteric fistula. Why? Because this external sphincter has been pierced by the fistula, intersphincteric space has been pierced by fistula, and internal opening around 3 o'clock at the here is the 3 o'clock opening of this fistula. Importantly, you can see it here. Once I scan, this is just for the primary fistula tract. And second screening, I would like to emphasize, everyone should scan whole of the anal canal, not particulars for the site of fistula. And once I apply my high frequency probe in the transperineal area underlying the base of scrotum, I found a separate fistula tract which is around the 12 o'clock position near the base of the scrotum. It is somewhere merging with at the level of anal verge. Again here, there is doubt whether it is separate fistula or it is a communicating fistula with the main fistula tract at around 2 o'clock position. This is a 2 o'clock fistula. You can see this is a long fistula tract. This is a fistula tract around 12 o'clock position. Both this fistula tract we'll see on the next coming video. So this is in the 12 o'clock fistula tract. Some air is there. There are no obvious external opening at 12 o'clock position. And you can see it is extending up to the intersphincteric space, whether not sure whether it is communicating or not communicating with the main fistula. This is in the axial plane. You can see here. I will repeat this slide. Now you can see 12 o'clock opening. Oh, sorry. This is fistula 2 o'clock opening, and another one is at 12 o'clock. I will show you 12 o'clock fistula also. Here this air is coming to 12 o'clock, and there is intercommunication is there between, you can see. can see the communication here. Yes, this is the communication between the two fistula. You can see here, and this two are so this 12 o'clock fistula is not the original. This is not a complete fistula, but it is the communication with the main fistula tract. Again here, this is 12 o'clock fistula, which is communicating with 2 o'clock fistula and common internal opening at around 3 o'clock position. And this is my pictorial diagram. This one is 12 o'clock, no external opening, just incidental finding, which is communicating with this main fistula tract on 12 o'clock position. Here they are 12 o'clock position around 2 centimeter long, and 2 o'clock fistula internal opening at 3 o'clock around 5 centimeter long. So both are the intercommunicating transsphincteric low fistula, or you can say intermediate, somewhere near the dentate line. So this is the intro of photographs and video. I will demonstrate everything. Now this time I am doing directly by applying over the external opening, because the course of fistula tract is oblique. I am applying my transducer at this 2 o'clock external opening. There are two external opening, one is scarred, another is opened up. I am putting my transducer here, and now you can see on ultrasound, this is the external opening, and this is the fistula, and this whole fistula is coming in the extrasphincteric space. Now I am going towards the anal canal by focusing my whole fistula tract or the sinus tract, which is to around 12 o'clock position. Now you can see I am applying my transducer here away from the main fistula tract. And now on ultrasound, this thing is separate. This is a separate fistula, which is at the 12 o'clock position, and it is opening at 12 o'clock position at the level of anal opening. But unfortunately,
And
not
you
opening
can see
here,
that
exactly
on the
it's
tag.
communicating.
I will show the tag simultaneously. This is single sinus tract, and another one. This thing is the fistula tract. This thing is fistula tract. On applying the hardware, I don't know.
This is by the applying the surgical probe inserted into 2 o'clock position, and you can see the communication between these two tracts is there. Again, the probing has been done.
Now this is the
This probe is
direction
coming.
of towards the 12 o'clock fistula tract, which we have inserted a surgical probe there. Now again focusing on over the ultrasound. You can see this thing, this surgical probe in the 12 o'clock fistula tract. This bright hyperechoic thing going from the skin to the subcutaneous plane.
So both these tracts are intercommunicating with each other. So this is the final picture of this patient having external opening at 2 o'clock position. This is another fistula communication at the perineal region, at the base of scrotum, and here comes the video.
So there was a two tract, one is coming from the base of the scrotum, another one is from the 2 to 3 o'clock position. There was a one scarred tissue and one external opening, but in the scar tissue there was another opening was there, and we have started coring out the entire tract from the base of the scrotum as well as from 2 to 3 o'clock position up to the internal ring at somewhere between 2 to 3 o'clock position. From base of scrotum and from 2 to 3 o'clock position up to the anal verge, somewhere around 2 to 3 o'clock position, internal opening is at dentate line at 2 to 3 o'clock position.
So this comes the conclusion of this tract, that one should always see any accessory tract or branching which is not always seen on per rectal examination. You have to see it by the ultrasound also. So
From
this is the final specimen of the fistula tract.
fistulae nano, transeccentric fistula,
The demonstration by surgeon.
fistulectomy done along with the primary sphincteric repair of the sphincter. Infiltrated methylene blue surrounding this cut area for better post-operative analgesia. Thanks for watching.
Now coming to the advances of the transperineal ultrasound. Endonal ultrasound is very good, but it is very cumbersome to do, particularly in patient with perianal abscess. Patient will not even allow for digital examination. So it's very difficult to perform endonal ultrasound in patient of the fistula, but endonal ultrasound is much more useful. There is some staging of the carcinoma of the rectum or anal canal. It is much more useful than the perianal ultrasound, transperineal ultrasound. So coming to 3D and 4D ultrasound. 3D, 4D ultrasound in my experience is not so good for the demonstration of the fistula tract, because it all depends on the scanning plane, because it's not a straight line. An image quality is not so good to classify by the 3D or 4D scan, but it is useful in pelvic floor disorders because it is in a single line and the things is very easy to do on 3D and 4D ultrasound. Yes, MRI is the gold standard for the fistulogram, but it is not available everywhere. And second thing, in my practical experience, I am doing so many of the MRI from 10, 15, 20 years. So in my experience, superficial fistulas are not very well seen on MRI because it gets compressed, or external opening gets somewhat compressed, or the tract is inactive. Then it's difficult to see on MRI, but it can be seen on transperineal. In my personal opinion, there's single advantage of transperineal ultrasound is in the superficial fistulas, which are better seen on the transperineal ultrasound. What are the limitations of the transperineal ultrasound? It is total operator dependence. If you start practicing your transperineal ultrasound in every patient, you will get very well versed with the procedure, and you can easily follow the pathologies. If you are a surgeon, then definitely you can easily locate with your surgical probe and insert the probe, and you can see the course of the fistula also. It is depending on the machine, although it is not so much dependent, but a good quality machine is required for any imaging purpose. It is difficult to examine in obese patient. There is so much fat in this patient. On such patient, we use the curvilinear transducers with having the low frequencies. If there is any surgical, if there is an emphysema or there is abscess with air or too much subcutaneous edema or thick scar tissue of the past IND or any surgery which limits the visualization, and a supralevator extension of the tract is not easily visible, it is difficult to penetrate up to the supralevator or levator ani muscles. So it's all about the transperineal ultrasound, how I do it. Thank you. Any questions?
Dr. Sumit, excellent demonstration of the cases and excellent coordinated work with the surgeon.
Thank you, surgeon, sir.
Yeah, really. Very well done. Very well.
Thank you, sir.
Hello. We can invite few questions if time permits.
Your view regarding the transperineal ultrasound for a surgeon, for a proctologist, because you are doing so many conventional fistograms. How you compare conventional fistogram with the transperineal ultrasound?
Number one thing is that it is very convenient for surgeon to do the transperineal sonography at the time of examination. It will be an office procedure which will not require a second opinion, second consultation to somewhere else. Limitation is that the picture of conventional fistulogram is much more simpler picture. And in such a expertise situation, is there any particular patient which I would like to do conventional fistulogram instead of perineal sonography? Is a patient having 4 openings? If a patient has got 4 openings, then I can put 4 catheters, particularly balloon catheters, small HSG balloon catheters, and inject contrast one by one in 4 and get a dynamic whole panoramic picture. So there I can even demonstrate the things better than the MR.
Sir, I think if there's a combination approach of such type of thing, because in MRI once I started, so initially I used to put simple saline on MRI. I'm doing MRI for 15, 20 years. So on ultrasound also, sometimes I did not find any fistula. What I do, I simply insert a venflon and just follow the course of the venflon. And still I don't find that. I just inject saline into that and try to find out the internal opening. Because MRI is very difficult to find internal opening, particularly if there is some sort of fibrosis or some abscess has been become thick abscess, which is not allowing the saline to insert into anal canal. So if you are planning such type thing, then most welcome, sir, we can combine by transperineal and demonstrate it very well.
And second thing I would like to suggest the surgeons is to use more of the Teramo glide wire, which can easily negotiate through the track. And then you can feel it inside the anal canal, pull it down outside. So at times I used to put a feeding tube over the glide wire and tie it and send it back to the surgeon.
That is good approach.
You have done almost the set-on procedures.
It is
That I have not done because then I'll stop getting references.
It is very fortunate that we are having three most experienced endorectal radiologists with us, two as a chairperson, one as a speaker. My question to Dr. Sumit, you are doing a lot of MRI fistulogram as well as transperineal ultrasound. Suppose you did a ultrasound and some other surgeon asked you to do the MRI of the same patient. Did you find any difference in your reporting in the same case?
Sir, sometimes in the supralevator fistula or high type fistula, when there are limitation of the visualization of the whole tract, somewhere I assume in transperineal ultrasound it's not going upward because my transducer has fixed frequencies and I cannot see the higher fistulas. But actually it is higher. Then that case I can stuck up and MRI will find that supralevator and the under extents of the fistula.
My one suggestion is more, as you say that you are pushing the saline in the trach.
Yes, sir.
If you do, I have seen you are already wearing the gloves.
Yeah.
If you just put a gauge piece inside the anal canal and mark the external point with any marker pen on the gauge piece at the anal verge, and in place of putting only pure saline, you mix it some drops of hydrogen and methylene blue and push it. When you remove the gauge piece, you can see that there is an internal opening or not. And this will help you in reporting or assessing further in your MRI or ultrasound.
Yes,
This
sir.
is just my suggestion.
Yes, sir, thank
It
you.
is same
This
for
is good, it's
Jayant,
good,
you too.
yeah.
When you are doing
In
the
fact,
fistulogram,
Dr. Nigam,
you do the same
I
thing.
would like to say that the last 15 days we were recording so many cases, and he is one of the radiologists who has assisted so many times in OT because of his interest, and he knows what the surgeons want for this fistula in nano. And we have recorded some of the cases. I don't know why he has not put inside that how to give diluted hydrogen peroxide in the tract and how to visualize transperineally. It gives a beautiful picture for the surgeon, and he can delineate that entire tract. So definitely we'll like to put such type of images. Yes, it was there. Yes, yes. And in fact, we have recorded how to give pudendal knob block. In fact, Dr. K.K. Thakur is going to demonstrate how to do pudendal knob block, because being as a proctosurgeons and colorectal surgeons, all of us doing septa block and all these things blindly. In fact, gynecologists, they are also doing this pudendal knob block. We'll take all these issues in our upcoming presentations. But before that, I would like to start the inauguration procedures, because we'll take a couple of times, a couple of minutes, and in fact entire nation is watching all of us through online. Dr. Sudhakar is here. Hai na? So, thanks Dr. Sumit, and I will request Dr. Jyoti Jain, one of the senior radiologists of our town, to present a bouquet to Dr. Sumit Upriti. Dr. Jyoti, please. Jaswant, please. Thanks, Dr. Sumit. नहीं अभी बुके मोमेंट Yes. Now I will request. Hey, please. Dr. Bharti Pandya, please come forward and present a memento as well as the flower pots to our both the chairpersons. Dr. Bharti is professor in Department of Surgery, All India Institute of Medical Science. I will ask our team management to prepare for inauguration. Bharti, please. Dr. Supriya. Thank you, Dr. Supriya, for coming for this workshop. Dr. Jayant Yadav, please. Yes. Now this is the time for inauguration, and I will request Dr. Shekhar Suratkar, Dr. Subodh Vashne. I think he's here or he has gone. He has left. Okay. And I will request Dr. S.K. Nigam, please come forward for Saraswati Vanna. And I will request our management team, please come forward. Shekhar sir, please.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निशेषजाड्या शुक्लां ब्रह्मविचारसार परमामाद्यां जगद्व्यापिनीं
and we'll take a few words from Dr. Shekhar Suratkar. Thanks, sir, for coming from Mumbai to Bhopal. Shekhar, sir, please.
It is indeed an honor for me to attend this single theme event. I have been practicing coloproctology since last 3.5 decades. But every time I go for some program, I learn many things. It was really an eye-opener for me. I've got sonography machine at my hospital, but I never did it myself. But I'm sure that after going back, I will start doing all these cases, procedures in all my patients. Just a few words for young delegates, those who have come to attend this program. Before doing this procedure, you must know the anatomy of the perineum, the anatomy of the sphincters, levatina muscles, and all the spaces, which are very important because that is how you will master the technique of understanding the pathophysiology, spread, and how to manage the treatment of this condition. With this, I again thank and compliment the entire team of Bhopal Surgical Society and especially Dr. Rajiv for doing this. And I also would like to put on record Dr. Bharti and her brother, Dr. Vaishnav, for taking good care of me. Thank you very much.
शेखर सर, आपको भोपाल आने के लिए बहुत बहुत धन्यवाद. आज एकेडमी ऑफ क्रिटिकल केयर मेडिसिन भोपाल अलॉन्ग विथ सेंट्रल जोन एसोसिएशन ऑफ कोलोरेक्टल सर्जन्स ऑफ इंडिया, भोपाल सर्जिकल सोसाइटी और एमपीएसआई गौरवान्वित महसूस करती है आपको मोमेंटो देने के लिए. मैं एक बात अपने सभी डेलीगेट्स को कहना चाहूँगा कि डॉक्टर शेखर सुराटकर को इस साल प्रपोज किया गया है लाइफ टाइम अचीवमेंट अवार्ड देने के लिए एसोसिएशन ऑफ कोलोरेक्टल सर्जन्स ऑफ इंडिया के माध्यम से. मैं डॉक्टर संतोष भास्कर को बुलाना चाहूँगा कि प्लीज़ आगे आएँ और हमारी सोसाइटी के माध्यम से एक मोमेंटो दें. शेखर सर, प्लीज़. मैं बुलाना चाहूँगा जसवंत को और नव्या को, हमारी मैनेजमेंट टीम को, जो कि एक बहुत अहम पार्ट है हमारी पूरे ऑर्गेनाइजेशन का, कि कृपया एक मोमेंटो शेखर सर को दीजिए. साथ ही मैं बुलाना चाहूँगा डॉक्टर एसके निगम को. प्लीज़ कम फॉरवर्ड सर. निगम सर. Thank you, sir. Now this is the time to close this our inauguration ceremony, and we'll continue with our next presentation, which will be done by Dr. K.K. Thakur. Dr. K.K. Thakur is executive member of Association of Critical Care Medicine Bhopal, and he is going to cover a very interesting topic for all of us, that is the pudendal nerve block as well as hypogastric nerve block. For his presentation, I would like to invite Dr. Puneet Saxena. Dr. Puneet Saxena is one of the leading radiologists of our city. And Dr. Deepti. Dr. Deepti is one of the physician who is doing a lot of pain management services for our patients in Bhopal. Dr. Deepti, please, and Dr. Puneet, please. Now I would like to hand over the mic to Dr. Puneet as well as Dr. Deepti for starting the session. Dr. KK, please.
After having a wonderful feast from Sumit, I think it's time to invite Dr. KK Thakur for his deliberation on hypogastric and pudendal nerve block. Welcome.
Thank you. Good morning, everyone. Since we are already a little bit late as per our schedule, I will be starting our presentation quickly. Since today's whole conference is about perineal area issues related to perineum, so I would like to add on one more topic to this whole armamentarium, which is basics of superior hypogastric plexus and pudendal nerve block. We have chosen these topics to ensure that our delegates gets full complete overview of the various pathologies that we are dealing in this area, especially the pain part of the patient, which is now being in more focus. And with this technology, with our hand, with advanced tools with our hand, we can provide better care to the patients. So I have divided my presentation into two parts. The first half would be covering superior hypogastric plexus block, and the other part would be covering pudendal nerve blocks. What is superior hypogastric plexus block? It is an outpatient injection that may provide an excellent pain relief for numerous types of pelvic pain syndromes that we usually see. It is a bundle block. Basically, is a bundle. Plexus is bundle of nerve situated below area of the aortic bifurcation in the retroperitoneal space. Who does well with this block? The patients who have pain originating from bladder, uterus, vagina, urethra, perineum, prostate, penis, testis, rectum, descending colon, patients with gynecological pain syndromes like endometriosis, scar tissue in pelvis, radiation-induced injury, carcinoma of pelvic area including cervical, prostate, colorectal carcinoma, pain because of irritable bowel syndrome, and interstitial cystitis. This is group of patients who are going to benefit from this superior hypogastric plexus block. How is this block performed? It can be done by two approaches. One is with the help of ultrasound guided technique, which will be focus of today's presentation, and another which we pain physician mostly prefer is fluoroscopy or X-ray guided, which is a classical approach. Now, anatomical landmark that we use for superior hypogastric plexus blocks are very simple. The first and foremost important is umbilicus, which is present here at which you can see at the junction of L3 and L4. Umbilicus is here. Then second most important landmark that we use on anterior abdominal wall, lower pelvis is tubercular plane and anterior superior iliac spine. The plexus is present at the lower margin of L5 vertebra at the junction of L5 S1 vertebra, anterior to it and slightly towards the left side. This is the location of the plexus. So lower L5 and upper S1. Iliac vessels can be used as a definitive landmark by ultrasound, which we will be demonstrating on our workshop also. And we can also take help of fluoroscope to mark the level of L5 and S1 junction. Here you can see in this diagram that we have shown that this is L5 vertebra, lower margin, anterior side. These are common iliac vessels, and then there is this plexus which is present here. So this is our target where we have to inject our drug to provide pain relief to the patients. Landmark can be identified with the hybrid technique also, in which we use X-ray C-arm to mark the S1 vertebra. This is L5 vertebra, and our target can be marked with the help of this hybrid technique. Scanning protocol is very simple. We use curvilinear probe 2 to 5 megahertz, which is placed in the area between umbilicus and pubic symphysis. Patient is in supine position. We try to get some Trendelenburg reverse Trendelenburg position also to push the bowel backward so that it does not come in our way of the needle and the plexus. L5 vertebra is identified, which is approximately 3 to 4 centimeter below umbilicus. This is external landmark. Anatomical landmark for locating the plexus is the lower third of the L5 vertebra, just below the bifurcation of aorta. So we trace aorta and then we trace this bifurcation as we move downwards, and at the level of bifurcation we get L5 vertebra. We will be showing in a video and also demonstrating in volunteers also today. So this is the basic sonor anatomy view that we get. This is the anterior part, this is the posterior part, and then fifth lumbar vertebra is here as imparting its acoustic shadow and hyperechoic line with the acoustic shadow. As we all know that bone does not allow the penetration of the waves, so it will look like this hyperechoic line. And here we can appreciate the common the iliac vessels which are bifurcated. So our plexus is present somewhere here, and we have to inject our drug here. This is another view with the Doppler image that we put to identify vessels so that intra-arterial injection can be avoided. Also our landmark can be confirmed. So this is how it looks like in the Doppler. Superior hypogastric plexus block intervention, all the preparation that we need to do is pre-procedure preparation. Basic is ASA monitoring under all aseptic precaution. The needle that we usually use is 20 to 22 gauge spinal needle. In obese patient and in general cases, we usually use a longer spinal needle, not the standard conventional one, a longer 15 centimeter needle. And we use in-plane technique to see the tract of the spine needle also, to make sure that we are going in the right direction and not hitting any other vital structure nearby. Needle is and then we hit the vertebral the anterior margin of the vertebral body, and then we withdraw a little bit to avoid periosteal injection. First we give a diagnostic block for which we use 10 ml 0.25% bupivacaine, confirming the negative aspiration. If the patient reports that he or she has reported relief in the pain after diagnostic block, then we go for our confirmatory block, therapeutic block, for which we use chemical neurolysis via 15 to 20 ml of LA with 6 to 10% of phenol. Vital sign parameters post procedures are monitored. So this is how it looks like in ultrasound. It is a very short clip. So as you can very well see, this is L5 vertebra. These are vessels, and needle, although not very clearly visible, but the tract of the needle can be seen in between. And then we hit the body, and then we come back. I will repeat it once again for your convenience and to understand. And we will demonstrate the same on volunteers also, although not the needle insertion part, but how to identify these on our patients. So this is how it looks once again: L5 vertebra, iliac vessels, and our needle coming from this tract. Bowel usually do not come in our between, or if you think that bowel movement is there, much of the bowel is interfering, we usually tend to get tendon level position, head low position, 10 to 15 degree, which pushes the bowel backward, and our field is clear. Are there a risk with injection? Yes, since it is a intervention, there is always a risk. There is a risk of infection, there is a risk of vascular injury, ureteric injury, bowel and bladder injury theoretically happen, although this needle is very fine. So theoretically it can happen, but practically, as we already have discussed with many surgeons also, but it does not seems to be very clinically significant. But yes, theoretically it can happen. And hence an expert personnel should perform these blocks. How to prevent the risk? Pre-procedure bladder bowel preparation can help. Tendon level position, as I have already mentioned, can help. A small size needle, avoiding visceral injury, and use of color Doppler, avoid the complication related to inability to visualize the needle. These are the techniques that we can make it safer practice. What are the advantages over fluoroscopy? Although as a pain physician, fluoroscopic method is more advocated, because we are very sure, because we get a dye spread also, we are sure that we are at the right place. But yes, there are few advantages of sonography. First and foremost, it is safe, it is less time consuming, it is bedside and simple to perform, useful in patients who have difficulty in lying prone, avoids radiation exposure, and immediate airway management can always be done in case of any complication. So to finish this block, the most important part is you as a surgeon or as a physician, when you are seeing those patients who are suffering from pelvic pain syndrome because of the conditions we have already mentioned, quick, simple bedside diagnostic block can always be performed by you guys, which give you one insight that yes, this is the place which needs to be taken care of for the pain related complication or pain related issues of the patient. And if you find that the diagnostic block is patient is reporting pain relief in diagnostic block, yes, he or she can be referred for a therapeutic block to pain physician, and that is what is the whole crux of this presentation to be shared in this platform. The second part of this presentation would be pudendal nerve block. I have divided this presentation in relevant anatomy, the causes of pudendal nerve pain, the clinical presentation, how do we diagnose and management, and then block with the help of landmark and ultrasound guided technique. Well, we are, as physicians and surgeons, we all know that it is the pudendal nerve. It's a mixed nerve. It has both motor, sensory, and autonomic component. It originates from anterior EMI of H2, 3, 4 nerve. After its origin, it leaves the pelvic cavity by passing through greater sciatic foramen, and then it courses around sacrospinous and ischial spine to enter the perineum. It is at this level, at the level of obturator foramen, that the pudendal nerve gives its 3 terminal branches: inferior anal branch, perineal branch, and dorsal nerve of penis or clitoris in females. Anatomical relationship which are clear by this diagram, as as we can demonstrate that this is piriformis muscle. Nerves leaves beyond piriformis muscle. It runs in between sacrospinous and sacrotuberous ligament. From lateral, the relationship from sciatic nerve, then there is posterior femorocutaneous nerve, and then there is pudendal nerve. So these are the anatomical landmarks which we usually use to locate our nerve on ultrasound also. And its relationship with pudendal artery is very important because in ultrasound, to ensure most of the time it is very difficult to visualize the nerve per se, because it is very fine and small nerve. But yes, pudendal artery which runs, here you can appreciate that it is running medial to the nerve, pudendal nerve. So this artery can always be visualized and then can be used as a landmark for our injection. Here are the relationship with gluteal muscles. It runs below the piriformis muscles. This is important landmark which is we use for scanning, which I will be showing in next slides. And then the base is made by coccygeal muscles. The nerve runs inferior and then divides. It is at this level it divides. So a nerve can be blocked at multiple level, at this level also, at the level of ischial spine, and at the level of obturator internus muscle also. But we usually prefer to block nerve here because we have to cover the rectal branch also. If we do it distally, the rectal branch which divides higher up will be spared in those cases. So these are the innervations of the branches of the pudendal nerve. Dorsal penile nerve, this is perineal nerve area, and this is the area supplied by inferior rectal nerve. So perineal area and perineal pain, because originating from this area, can be covered with this nerve block. What are the major causes of pudendal nerve pain? It is sports and exercise, mostly bicycling and squat based exercises. Surgical injury, direct or indirect. In post-hips replacement patient, because of prolonged position, pudendal entrapment can happen. Gynecological surgeries, forceps deliveries. Pudendal nerve entrapment due to difficult labor, perineal trauma, compression, radiation injury, inflammation, cyst, mass compressing the nerve, and post-surgical chronic pain. In most of the cases, we have observed that it is between sacrotuberous and sacrospinous ligament, which is a very narrow space. It is at this place most of the time this nerve get entrapped and leads to different kind of pudendal neuralgia syndromes. How does these patient presents? Chronic pelvic pain, functional or psychological impact is always there because it is the area which is very troublesome for patient. There are neuropathic characters to this pain, like tingling, paresthesia, rectal and vaginal foreign body sensation. Patient can say that he is or she is having this foreign body irritating sensation all the time. Patient usually worsen during daytime because of the more activity during the daytime, and usually night pain is not because of pudendal neuralgia, it is a negative factor. Triggered by defecation and prolonged sitting. It can be unilateral or bilateral, and hence a complete pelvic examination by concerned specialist. So you guys as a surgeon, as a physician, can always make a good comprehensive pelvic examination and ensure that yes, patient is suffering from pudendal nerve related issues because of the area which is involved and all these clinical histories. What are the differential diagnosis? Myofascial pain because of pelvic floor dysfunction can also present in that area. Vulvodynia, chronic pain of vulva or at least 3 months in absence of other causes. And piriformis pain syndrome can also sometimes mimic this condition. Diagnosis can be done by clinical examination. There is one criteria also which is very detailed criteria, but I have not included in the presentation. Then nerve block, which was again something that you guys can always perform during examination also. You can always perform a diagnostic nerve block to ensure, to make a diagnosis that yes, it is because of the pudendal nerve related issues. And MRI is definitely required in the cases where ischiorectal fossa in presence of any warning symptoms. If sometimes patient present with pain also, pain only as a first presenting sign. And if you find out that there are warning signs like weight loss, like patient fits in the profile of some cancer and oncological related profile, so you can always, one should always advise MRI to make a diagnostic, complete diagnosis. How do we manage? We usually start with conservative management, classical anti-inflammatory and anti-neuropathic drugs. Then you give nerve blocks with steroids, diagnostic and therapeutic both. There are few neuromodulation technique also where we use pulsed radio frequency ablation to ensure a prolonged block to the nerve and prolonged pain-free period. and then pudendal nerve surgical decompression, which in cases of irretractable pain, despite all these measures, if it is not taken care of, so surgical decompression is always required. What are the indications? Acute indications, we all know, all of us are aware that there is second stage of labor, anorectal surgery, hemorrhoids, where you guys have been doing this for ages, like a typical landmark technique where you use a pudendal nerve block to ensure good perioperative analgesia. That has always been done. Chronic pain like pudendal neuralgia, proctalgia fugax, vaginismus, anorectal pain and genital pain, these are the indication where we go for something beyond diagnostic block. The diagnostic block is something that can be performed by surgeon also during the examination in OT and or in OPD also. It is a basic OPD procedure. But yes, chronic pain related complete therapeutic block is something that can be performed in operation theaters by us pain physicians. Now coming to ultrasound guided injection techniques, which can be done with transperineal approach in a lithotomy position and transgluteal approach in prone position. Lithotomy position is used in perioperative space, which is because it is comparatively easy to perform. This approach is mostly used for perioperative analgesia and regional anesthesia for perineal procedures. Here this is the probe position, and here we have also incorporated one video how does it look in transperineal scanning. Oops, sorry. This is one video. Sound nahi aa raha hai. So linear probe is used for this procedure. Position is lithotomy. So I will just explain what is visible. I will replay the video once again. Okay, I will be replaying it once again. I will explain what is happening here. So position is supine, the probe is linear, and we have put a probe at sacroischial tuberosity and then moving it medial towards ischial spine. It is at this level we can see that the sacrospinous and sacrotuberous ligament are visible. This is a spine, which is bony landmark, and in between these ligaments there is nerve. We will be demonstrating it on the volunteer also today, so you can very well appreciate how pudendal nerve has to be identified during lithotomy by surgeons only while you are operating on your patient. So definitive block will definitely help you to get better perioperative analgesia. The transgluteal approach that we as a pain physician perform is done in a prone position where we use curvilinear probe, and then we have to start our scanning from the most prominent landmark of the gluteal region, that is posterior superior iliac spine. Then we scan caudally and laterally to reach that level where we have to identify the nerve. How is this done? As you can really appreciate, we start from posterior superior spine. This is the highest most landmark on the posterior part of the buttock, and here you can really appreciate this bony landmark, which is posterior superior spine. Lateral to it and medial to it is sacrum, and then patient is placed in prone position. Curvilinear probe is used. We start scanning from posterior superior spine and then move transducer caudally and laterally. What is the next thing that we see? At the level of iliac crest, this is where we have at the level of iliac crest. So here you will find this kind of bony contour, which is suggestive of iliac crest, and above that there is gluteal group of muscles. We have to identify maximus, medius and minimus. These are the muscles. Then we slide down our probe middle or more caudally, and we come at the level of greater sciatic notch. At this level, this is how it looks like. At greater sciatic notch, we appreciate this notch. This is the ischial spine, the notch level, and then there is gluteus maximus level, and the next muscle that comes is piriformis. Our muscle of interest usually leaves below this piriformis, but we do not usually block at this level. And here we get sciatic nerve, and nerve is also pudendal nerve is difficult to visualize at this level. Then we come little bit more down, as I have mentioned here also, in the C part of this presentation. This is at the ischial spine level. How does it look at ischial spine? This is how it looks at the ischial spine. The straight border of ischial spine. Here we identify our both ligaments, sacrotuberous ligament and sacrospinous ligament, and we put color Doppler here to identify the pudendal artery, and in between this ligament here is where the nerve is. So we go in plain technique, we use a small long needle, spinal needle, and we try to hit this area with the help of the needle, and then our drug is deposited. Coming to a more lower level, this is one. How does it look like when we put a color Doppler? As you can appreciate, this is pudendal artery, and this is nerve, which is medial to the pudendal artery in most of the cases. These are the ligaments, sacrotuberous and sacrospinous ligament. So for successful block, we move the transducer slide medially to give more room to insert the needle from lateral. This is a personal preference. We usually try to insert the needle from lateral side, from this side, and then we go towards this side, avoiding the artery, and medial to the artery there is the nerve in between sacrotuberous and sacrospinal ligament. This is where we try to deposit our drug, and drug spread can also be visualized directly. What are the complications? There are complications related to bleeding, sciatic nerve block, which is also near the vicinity, it can happen. Local anesthetic systemic effect can happen. Infection, urinary and stool incontinence, because it is also controlling sphincter, so it can happen for temporary period. And temporarily it can increase pain also due to injection. These are the references for this presentation, and with this I will rest my case. Please.
Thank you, Dr. Thakur. You have covered both the topics very well in a brief manner, and right from the clinical anatomy to the clinical intervention part, which we can offer in chronic pain patients. One doubt which I have, or I would like to ask, is why your preference is blocking at the ischial spine level whenever you want to give a diagnostic block, rather than at the lesser sciatic notch level?
At the same, thank you. For this, there's one very logical explanation. We have to understand the division of the pudendal nerve. It gives 3 branches, as I have already mentioned. So let me just take the help of the diagram here. See, these are the branches. Inferior, the first branch which comes out is inferior anal branch or rectal branch. This branch usually comes at the level of above the level of ischial spine. So if you have to cover all 3 branches, ischial spine is the desired level. If we go below ischial spine at the level of lesser sciatic foramen, inferior anal nerve will be spared. So that area will not be covered. We will be able to block only perineal and dorsal nerve. Only 2 terminal nerves will be blocked. So, and that is why we prefer at the level of ischial spine. This can although can be done at obturator level also, but it is usually avoided to get complete coverage.
Any questions from audience?
Gravity also helps in getting the amount of local anesthetic spreading over that area.
Sir. Yes, sir.
I just would like to add a few points to your talk. It was excellent talk on the blocks. Many times you emphasized on ultrasound and the other modalities. Many a times, in many circumstances, we have to take intermodality utility. Like if a patient is average built, thin built, ultrasound probe in itself is sufficient. Many limitation comes when patient is obese or having a gaseous distended abdomen. There is no way, because ultrasound waves cannot cross the air. So this is the utmost limitation of ultrasound. Whenever we are doing any block, either it is bedside or in the OT. Secondly, if patient is too obese, we cannot take ultrasound in account on a sole basis. We can take help of fluoroscopy, because where our needle is heading towards, we need to keep a watch on that. Landmarks, you hit the vertebral body and just take it out and just inject. That is sufficient. But if there is conjunction of fluoroscopy, we can inject, along with the drug, we can inject some amount of contrast. So on fluoroscopy, we are having fair amount of idea where our contrast along with the medicine is going. Thirdly, whenever patient is obese but is stable, and we are not supposed to do a procedure bedside, and if CT scan facility is available, then we do take a posterior approach. We go parallel to the spine and inject the drug. Drug to be injected with the contrast material, what we use for CT scan, so that it gives area where the drug is. So these 3 points we have to keep in mind, that we have to believe on intermodality communications as well. Secondly, Dr. Bhaskar, in the first talk, he emphasized on how to toggle the probe, ultrasound transducers. So his probably third or fourth point was compression. So while we are having intestine, we have to keep the small intestine apart from the procedure area. What we do, we compress with the probe. That compression actually pushes the intestine either sideways or upwards. And up and down movement again clears up the area. Anatomy for anybody, for beginner or any expert, is the most important part. Doppler per se is of very much importance. Reason being, even accidentally, we don't want that our therapeutic agent is going inside to the vascular system. So Dr. Aman, what he pointed out during the Doppler, you just compress the probe, so you are aware of that we are heading towards vein or the artery, we are clear of. Secondly, anomalous vasculature is again a problem while doing the scan or while doing the procedure. So we need to take a detailed account of the inner anatomy, vascular anatomy, and then we can go ahead with the blocks. Any other question from?
Thank you, Dr. KK. And he has demonstrated very nicely how to block the pudendal now as well as hypogastric now. And now this is the time to felicitate Dr. KK Thakur. I will request Dr. Deependra, one of the youngest member of Academy of Critical Care Medicine, Bhopal. Please present a bouquet to Dr. KK Thakur, please. Thank you, Dr. Krishnakant. Now I will request Dr. Atul Saurabh, please come forward, present a memento to our chairpersons, Dr. Puneet as well as Dr. Deepen. Dr. Deepti, please come forward. Till the felicitation ceremony is going on, I will request Dr. Radhika Sharda. She has come all the way from Indore to Bhopal for her presentation, and she is going to speak about a very important topic for all of us, that is TAPP. That is fast focus abdominal sonography in trauma patients. So Dr. Radhika, please.
A very warm good morning to everyone present here. I'm Dr. Radhika Sharda, and I'm here to talk a little about FAST, Focus Assessment with Sonography in Trauma Patients. So to begin with, what all are its indications? The various trauma cases, patients with respiratory distress, tachycardia, hypertension, etc. So FAST is basically a rapid bedside scan to assess for 4 areas for free fluid: the perihepatic, the perisplenic, pericardiac, and the suprapubic. And when we extend these 4 quadrants to include the lung views and the IVC, it becomes the extended version of it, the extended FAST, eFAST. What kind of a probe do you use and why? The preferred probe is the curvilinear one, as you can assess the subxiphoid cardiac, abdomen, and thorax with it. Whereas the phased array probe is usually used by cardiologists for echos, is basically for the cardiac and the abdominal view, and the linear probe is preferred for the thorax. Do make sure to remember that the indicators are marked on the opposite ends of the curvilinear and the phased array probe, as it changes the orientation of the scan. Before we begin assessing for free fluid, here comes an important hint for all of us. Most of the anatomical structures in our body have rounded margins, as depicted by the pink in the diagram. And when free fluid tends to accumulate in between, it tends to have sharp margins as depicted by the black in the diagram. Now, you can assess any quadrant first and follow any order that you like. Some doctors follow a clockwise approach, some like to begin from the right upper quadrant. What is advisable is to begin scanning from the subxiphoid view first, to look for the beating heart and to look for any free fluid surrounding it. Then you may make your way towards the right upper quadrant, left upper quadrant, and then the suprapubic view, both in the sagittal and the transverse plane. Here comes our first quadrant to assess the pericardial region. As said earlier, you may use the curvilinear or the phased array probe. Place the probe in the subxiphoid location, identify the liver, and then sweep in for the heart. If in case the heart is not visible from the subxiphoid location, you can always go for the parasternal view with the indicator towards the right leg. Now that's the image that we are looking for. The beating heart with its two ventricles and its two atria, and we need to look carefully for any free fluid surrounding the heart. If you look carefully, you can appreciate the pericardial effusion in the second image. The first image is of a normal heart, whereas you can see the pericardial effusion in the second image. All right. Moving on to our next quadrant, the perihepatic, the right upper quadrant view. We need to place the probe along the 8th to the 11th rib spaces in the mid-axillary line, with the marker pointing towards the 12 o'clock position of the patient. And we need to look for the right kidney and liver and for any free fluid that is surrounding that space. That's the image that we hope to get: the liver, the kidney, the hepatorenal Morrison's pouch, and the diaphragm. Do remember that the free fluid tends to first accumulate along the paracolic gutter in a patient that has been supine. This paracolic gutter lies near the inferior tip of the liver and the inferior pole of the kidney. Here's a video of the perihepatic region. Try to visualize both the poles of the kidney, the complete liver, the right lobe, the diaphragmatic surface, and for any free fluid surrounding it. Again, this is our right upper quadrant, the liver, the right kidney, and in the second image you can appreciate the free fluid with some echoes present here. Free fluid highlighted by the yellow arrows in the image in the perihepatic region. All right, coming to our next view, the left upper quadrant, the perisplenic view. As you had placed the probe in the right upper quadrant, similarly, you need to place the probe in the left upper quadrant along the 8th to 11th rib spaces in the mid-axillary line. Now, visualizing the spleen can be a little tricky, so you may need to place your probe a little posteriorly for appropriate visualization of the spleen. That's the image that we are looking for: the spleen, the left kidney, the perisplenic area, the splenorenal space. Another key point to note here is that fluid first tends to appear in the perisplenic region. As there's the presence of splenorenal ligament, unless that ligament is ruptured, the free fluid won't accumulate in the splenorenal space. Here's a video of the left upper quadrant. You can appreciate the free fluid with echoes near the lower pole of the spleen. And if you look carefully, there's a relatively blacker hypoechoic area in the splenic parenchyma. This was a case of splenic injury in a patient of RTA. Yellow arrows indicating the free fluid surrounding the perisplenic area. Coming to our next quadrant, the suprapubic region. We need to identify the bladder, the prostate, or the uterus, and we need to look cranial to the bladder into the intraperitoneal cavity. You can appreciate the urinary bladder containing the free fluid, hence appearing anechoic. And we need to look for any free fluid cranial to the bladder into the intraperitoneal cavity and not at the top of the prostate. The probe has been kept in the transverse plane, and you can appreciate the urinary bladder, the prostate, and the rectum. Similarly, in females, the probe has been kept in the sagittal plane, and you can appreciate the bladder and the uterus. In case of females, do remember that fluid along the lower one-third of the uterus is usually physiological, whereas fluid along the middle and upper one-third of the uterus is pathological unless proven otherwise. Now, the right upper quadrant was sensitive for fluid accumulation in the supine position, whereas if the patient has been ambulatory or is upright, pelvis becomes the dependent part. So do make sure to evaluate the rectovesical pouch carefully in cases of males and the rectouterine pouch in cases of females. The arrows mark the free fluid in the pelvic region in case of male and in case of female. Here's a video of free fluid in the intraperitoneal cavity. And if you look carefully, you can appreciate the densely packed decos. The patient had a history of accident, and this was a case of hemoperitoneum. Now, even though the topic allotted to me was fast, I would like to mention a few words on the extended version of it. Again, it's absolutely the same concept. We are looking for any kind of free fluid in the thoracic space, and we need to look for pneumothorax. So for pneumothorax, we need to identify the pleural line. We need to look for the lung sliding. And if there's no lung sliding, then we need to evaluate for the lung point sign. We need to place the probe in the, ideally you should keep the probe along all the intercostal spaces on both the sides. But since practically that is not possible in all the patients, the probe is kept along the mid-clavicular line in the second intercostal space. And that's the image that we need to get. The shiny, shimmery line that we see here depicts the pleural line, and the bony rib is showing the shadowing. Again, we need to look for the pleural line, the shiny, shimmery pleural line. Now, once we identify it, we need to look for the lung sliding. Now, there may be lung sliding present and it may be absent. Once we identify the lung sliding, and if there's no lung sliding, we need to identify for the lung point. Lung point is basically the point of transition between the presence and absence of lung sliding. The absence of lung sliding is not confirmatory for the presence of pneumothorax. But if you identify this lung point, it is highly specific for the presence of pneumothorax. Here's a video. You can appreciate the lung sliding in the first half, whereas it is absent in the second half. So this is that transition point, which is the lung point. Now, usually you do not see the black anechoic area above the diaphragmatic surface because of the mirroring artifact caused by the liver or the spleen. But as it can be seen here in this particular image, this was a case of pleural effusion. Do make sure you adjust the gain for the fluid to appear anechoic. Lastly, do look for the IVC, the intrahepatic part that is coursing through the liver and entering the atrium. The probe is kept in the subxiphoid region, sagittally, and slightly tilted towards the right side. Towards the end, let's go through some pictures. The first one is an abdominal ultrasound showing massive amount of hemoperitoneum. As you can see, free fluid with echoes. Similarly, the echoes are depicted here in the second image. Here are some trauma cases involving splenic injury. A few days old splenic rupture with pleural effusion and collapse of the underlying lung segment. the heterogeneous appearing splenic parenchyma, which is hyperacute in the acute phase. Small splenic rupture with a non-vascularized hematoma. Again, splenic rupture involving the lower pole of the spleen. This was a massive splenic rupture with hemoperitoneum. Again, splenic rupture. This is a case of a completely shattered and a ruptured spleen with hemoperitoneum and some amount of pleural effusion that you can appreciate here. This is a patient with liver injury. There's the liver rupture with a subcapsular hematoma. 2 days later, the hematoma remains unchanged, and a month later, the hematoma has liquefied. Some cases of renal injury. You can see the renal laceration depicted by the yellow arrows here near the lower pole. A laceration of the lower pole. Perirenal hematoma here, and again a laceration of the lower pole of the kidney. Again, there's a hematoma with increased echogenicity and diminished vascularity. Now, although there is no absolute contraindication to fast scan, it should not delay the treatment of unstable patients. Further testing with CT scan is recommended if the patient is unstable and has a negative exam. Patients with high risk of suspicion for visceral injury should also go for CT scan. And to conclude with, the order that we looked in, the subxiphoid cardiac first, followed by the right upper quadrant, the left upper quadrant, and the pelvis, and at the end the thorax, you can use a single curvilinear probe by gradually decreasing the depth and decreasing the gain, and hence making the fast scan more fast and efficient and smooth. Thank you so much.
Thanks, Dr. Radhika.
Thank you so much.
It was very informative, and I guess fast scan is something really essential in ERs now for cases of trauma. Also, it should be something which all the surgeons need to be, especially in the periphery in our setup in our country like is. So hands-on fast scan and a quick approach should be a good start to a ER procedure. Thank you once again.
Thank you so much.
Any questions from audience?
Actually, my hospital do not have this CT and MRI nearby. So can we use it as a first-hand modality in the cases of trauma?
Definitely, sir. When patients come to us, we do tend to do the fast, but we actually try to obtain try to identify where the source of injury is also. I mean, if it is very evident while scanning, sometimes it might not be, but many times you can identify the splenic injury, liver injury while performing a fast scan itself.
Yeah. Thank you very much.
No, that's really difficult. That's better appreciated on CT scans.
Yes. Yeah. Fast scan, in fact, when a patient is coming from in a traumatic situation, we have to invariably do a e-fast, extended fast. The reason being, how patient has fallen down or where the site of trauma is, he might have got some, say, chest trauma as well. So we have to proceed with e-fast. Secondly, there is grading for all the stuff, say, superficial to how many percentage of, say, parenchyma got involved and whether there is any involvement of the vascular pedicle or not. So that decides the grading of trauma. What sir has recently emphasized on CT scan or MRI is not in his hospital. Sir, certainly this is the first line investigation whenever a patient is coming to triage or ER. And certainly it is very much informative in cases of trauma. Ultrasound is so damn sensitive that it can pick up 10 cc of fluid in the cavity. Invariably, whenever we are doing any ultrasound, we should not see any sort of fluid that is surrounding the viscera. Pelvis, yes, we may get in females sometimes. So it is very sensitive to get even minimum amount of fluid in the peritoneal cavity. So our first emphasis, if there is any fluid collection, whether it is minimum or it is a large one. Secondly, E-fast, what she has already emphasized on, we need to see the anterior chest. And spleen, yes, you have rightly said, it is very difficult because patient is not going to follow our commands. कि सांस अंदर खींचो और रोक लो, वो तो वैसे ही ventilator पे. So spleen is one aspect where we are in a limitation. But even if you are coming across minimum of the fluid in the chest cavity or the pleural cavity or in the left paracolic gutter, we should have a high degree of suspicion that spleen is having some involvement. So we have to settle the patient and then send him for CT scan. The only limitation, big limitation that comes in our way is the subcutaneous emphysema. Whenever there is any injury to the lungs or patient is having subcutaneous emphysema, all the ports, all the aspect of ultrasound get blocked. So invariably just settle the patient and send him for CT scan.
Definitely.
That is the key. Certainly, sir. Yes, sir. Yes, sir.
So thanks Dr. Radhika Sharda for her presentation on focused abdominal sonography in trauma patient. And now this is the time to felicitate Dr. Radhika Sharda. I will request Dr. Jitendra Jain, one of the senior physician of our city, to present a memento to Dr. Radhika Sharda. Thank you, Dr. Radhika, from coming all the way from Indore to Bhopal. Thanks, Dr. Jiten. And I will request Dr. Puneet as well as Dr. Jyoti, please come forward to take the, yeah. Yes, you can do that, Anna. For Dr. Puneet as well as for Dr. Jyoti. Yeah, yeah. Dr. Jyoti Jain is wife of Dr. Jiten Jain. Yes. And Dr. Puneet, you can take the flower pot. Beautiful flower. Yes. Now this is the time to conclude this session, and I will request for next session. It is going to cover by Dr. Deependra, and it is very important for all of us. Echo in emergency. Echo in emergency for all physicians as well as for surgeons. What to do, when to do, how to do. This is very important for all of us. And for this session, I will request Dr. Jitendra Jain, senior most physician of our city, as well as Dr. Shailesh Tudrawat, to chair the session. You can take the seat, sir. Yeah, you can take the mic, Dr. Jitendra, as well, Dr. Shailesh.
So now I request Dr. Deependra to proceed with his talk on echo for clinicians and emergency cases.
Thank you, sir. First, we are going to take a look on pretest.
time we had done this QR scanning. You need to do it once more for this pretest on cardiac echo.
ठीक है. Again activating your mind.
So please
ठीक है
scan
sir.
this QR code. You will be taken to a web page where the questions will appear and you need to tick your options and it will be reflected out here. We have 13 questions. So once you are done, we'll give 1 minute time for that.
A small introduction to Dr. Dipen. Dr. Dipen is a critical care specialist, anesthetist here at a young dynamic anesthetist and working under the supervision of Dr. Bhaskar at Bhopal Fracture Hospital. And he will be talking on echo for clinicians in emergency cases. That's a very important topic for clinicians because in cases of trauma and emergency, first thing which comes in mind is the cardiac emergency, then comes the vascular emergencies in the brain. So Dr. Dipen.
Thank you so much, sir. The quiz is going on.
Yes, please enroll yourself with the QR scanning. So there will be 13 question MCQ and those questions will reflect on your mobile once connected. You are given 20 seconds time for answering and whosoever does it correctly, then they need to do it fast as well to be on the top of the leaderboard. So we are 12 people, 13. So we'll start with the first question.
Okay, which type of probe is most commonly used in transthoracic echocardiography? It's a very basic question, you all know. The second question is? What are the indications of transthoracic echocardiography in ICU? Being a clinician, you all know what are the indications where we have to need of echocardiography in emergency situations. Third one is, what is the most commonly used parameter to assess left ventricular systolic function in echocardiography? क्वेश्चंस आर ऐसे डिज़ाइन किए हुए हैं कि जस्ट फॉर द सर्जन्स की बस हमको व्हाट द इमरजेंसी में प्राइमरी व्हाट Next one, which echocardiographic view is best for imaging the inferior vena cava? Next, what would be the inferior vena cava typically show a patient with hypovolemic shock? The next one is, which of the following is the most common echocardiac finding in hypovolemic shock? What do you think? Next one, which echocardiographic view is most commonly used to detect the pericardial effusion? As already we saw in fast examination. Next one is which echocardiographic finding is most specific for cardiac tamponade? This is a tricky question, but okay. 50% answers are correct. The next question is which echocardiographic view is most useful for visualizing right ventricular strain or having right ventricular hypertrophy, atrial hypertrophy? ठीक है. Next is which echocardiographic finding is most suggestive of acute pulmonary embolism? Very specific point to identify acute pulmonary embolism. चलिए, you all know McConnell sign. Next is what is the most important echocardiographic view for diagnosing aortic dissection? And next one is which location is aortic dissection most commonly observed on echocardiography? And last one is which echocardiographic finding most commonly associated with the septic shock? In septic shock, that is a type of distributive shock. And the winner is 12 out of 13, Dr. Subhangi Jain. Congratulations. ठीक है, तो I am starting my topic on echocardiography and just taking a few minutes. in during the pre-operative period or during the just post-operative periods. जैसे शारदा सर ने कहा कि बीच में कोई पेशेंट्स है, any collapse पेशेंट है, शॉक में पेशेंट हो रहा है बिकॉज ऑफ ट्रॉमा, हेमोरेजिक शॉक है, बिकॉज ऑफ पोस्ट ऑपरेटिव पेशेंट्स है, कोई सडन प्रोलॉन्ग सर्जरी है अगर चल रही कभी, एंड गॉट सडन डिस्निया और टेकिकार्डिया, है ना, दे यू सस्पेक्ट कि इट मे बी द पल्मोनरी एम्बोलिज्म, है ना. तो दिस सम बाय द डूइंग इकोकार्डियोग्राफी, है ना, you can assess where the patient is having which type of pathology, ideal hypovolemic shock or cardiac tamponade, pulmonary embolism or hypovolemia, है ना. So this is the some very limitations, है ना, having very most common causes for derangement of patient. So why we need for echocardiography? It is a non-invasive imaging modality. Its portability and safety allow for the rapid diagnosis of life-threatening conditions in critical care unit on routine day-to-day basis. तो पहले हमने इसमें क्वेश्चंस में भी देखा कि which type probe is used in echocardiography. So that is, we use a cardiac probe, also called phased array probe. So multiple piezoelectric elements arranged in a small footprint in a cardiac probe. Cardiac probe is a low frequency probe and it is having a wide field of vision. So there are mainly 5 views. नंबर 1, पैरा एक्सटर्नल लॉन्ग एक्सिस व्यू. सबसे पहले हमको सर्जन्स को ये पता होना चाहिए कि हमें क्या किस टाइप के व्यू है हमें, और क्या एग्जामिनेशन करने पे कौन सा व्यू मोस्ट सुटेबल है. तो सर्जन्स को क्या चाहिए, ज़्यादातर क्लिनिकल असेसमेंट में पता चल जाता है कि ये पेशेंट सेप्सिस का है, पेशेंट पल्मोनरी एम्बोलिज्म सस्पेक्ट हो सकता है, पेशेंट को ब्लड लॉस हुआ है या तो फ्लूइड डिफिशिट है, नहीं तो हाइपोवोल्यूमिया सस्पेक्ट हो सकता है. तो बेस्ड ऑन द क्लिनिकल हिस्ट्री, है ना, बेस्ड ऑन द पेशेंट टेकिंग एग्जामिनेशन, है ना, यू कैन टारगेट द पेशेंट कि विच व्यू इज बेटर. तो 5 व्यूज है मिली द पैरा एक्सटर्नल लॉन्ग एक्सिस व्यू, पैरा एक्सटर्नल शॉर्ट एक्सिस व्यू, एपाइकल 4 चेंबर व्यू, सब कॉस्टल व्यू आल्सो कॉल्ड सब जिफाइड व्यू, एंड द सुप्रा एक्सटर्नल व्यू. तो सर्जन्स के लिए सबसे इम्पॉर्टेंट है ये 5 व्यू, और 5 व्यू में हमें क्या विजुलाइज होगा, विच स्ट्रक्चर्स ऑफ हार्ट इज सीन इन दीज व्यूज. तो दैट इज़ वेरी इंपॉर्टेंट. अगर ये आइडेंटिफाई करना आ गया है आपको, तो दैट इज़ वेरी गुड टू आइडेंटिफाई अर्लियर पैथोलॉजी. तो आप इमेज में देखेंगे सबसे पहले जो इमेज है दैट इज पैरा एक्सटर्नल लॉन्ग एक्सिस व्यू. 5 व्यूज मैंने बताए. पैरा एक्सटर्नल लॉन्ग एक्सिस व्यू में ट्रांसड्यूसर प्लेस्ड इन द पैरा एक्सटर्नल रीजन ऑन द लेफ्ट साइड इन द थर्ड, मोस्टली 3rd to 5th intercostal space. पेशेंट ओबीज है, वो डेक्स्ट्रोकार्डिया इट में शिफ्ट, बट मोस्टली इट इज ऑन द 3rd to 5th intercostal space on the left paraexternal region. तो आप इमेज में भी देख सकते हैं इसमें द प्रोब पोजीशन किधर है, टुवर्ड्स द राइट शोल्डर. लेफ्ट paraexternal region, probe orientation marker towards the right shoulder. So that is a paraexternal long axis view. Second है paraexternal short axis view. Paraexternal long axis view में जहाँ आपने probe position किया है, you can rotate it on 90 degree, just on the 90 degree towards the left shoulder, as you see in the image, towards the left shoulder in the 90 degree from the paraexternal long axis view. This is called paraexternal short axis view. अब आप दोनों की इमेजेस में देखिए. paraexternal long axis में पॉइंटर दें बेटा. तो इसमें आपको आरवी इसमें लिखा हुआ दिख रहा है, दैट इज राइट वेंट्रिकल दिखेगा और लेफ्ट वेंट्रिकल दिखेगा लॉन्ग एक्सिस में. टुवर्ड द राइट शोल्डर की तरफ है मार्कर, तो इसमें नीचे की ओर लेफ्ट वेंट्रिकल, दैट इज राइट वेंट्रिकल, दैट इज लेफ्ट वेंट्रिकल, लेफ्ट एट्रियम, दिस इज ए माइट्रल वाल्व इधर, दिस इज यहाँ एओर्टिक वाल्व, एंड दिस इज अ राइट वेंट्रिकल. एंड पैराएक्सटर्नल शॉक वेसिस में जो लेफ्ट वेंट्रिकल की कैविटी, ये पूरा ऑल वॉल्स, दिस इज अ लेफ्ट वेंट्रिकल, इधर आपको ये राइट वेंट्रिकल मिलेगा. तो दीज में ये डिफरेंस है कि यू कैन फर्स्ट आइडेंटिफाई द चेम्बर्स इन द लॉन्ग एक्सिस एंड इन द शॉर्ट एक्सिस व्यू में मेनली द लेफ्ट वेंट्रिकुलर walls and left ventricular cavity seen on the left short axis. Next, the subcostal view and the apical. Subcostal also called subgyphoid view. Between the subcostal margins के ऊपर probe रखना है ecopome and the direction towards the heart. Apex का heart इसमें ये that is रखा. Subcostal view towards the left costal margin or towards the left, that is subcostal view. Patient lying in the supine position. Parasternal and in apical view, subcostal view में आपको जो स्ट्रक्चर्स दिखेंगे that is इसमें आपको फास्ट एग्जामिनेशन में यहाँ पेरिकार्डियल इफ्यूजन हमने देखा था पहले. तो that is a left ventricle, that is a left atrium, राइट वेंट्रिकल एंड द राइट एट्रियम. जैसे बताया था भास्कर सर ने इनिशियल लोबोलॉजी में मार्कर टुवर्ड्स किधर रखना है, ऑन द लेफ्ट. तो इधर का जो स्ट्रक्चर्स है ऑन द इमेज दैट इज लेफ्ट साइड इज लेफ्ट वेंट्रिकल, राइट साइड इज राइट वेंट्रिकल. यानी आपकी मशीन पे तो इधर लेफ्ट में होगा बट इट इज ऑन द राइट, लेफ्ट एट्रियम राइट एट्रियम. एंड इन द एपाइकल 4 चेम्बर व्यू पेशेंट लेफ्ट लेटरल डिबिक्यूटस पोजीशन पे रहेगा. थोड़ा सा लेफ्ट लेटरल पोजीशन को पेशेंट को करना है. एंड ट्रांसड्यूसर इज प्लेस्ड इन द 4th, 5th to 6th intercostal space on the left side near the apex and marker towards the left flank. तो आपको 4 chambers व्यू में लेफ्ट वेंट्रिकल, लेफ्ट एट्रियम ऑन द सेम, थोड़ा टिल्टेड इमेज ऐसा सबकॉस्टल में दिखेगा. एंड इसमें फॉर सर्जन्स क्विक असेसमेंट के लिए आप दैट इज लेफ्ट एट्रियम स्ट्रक्चर्स आर द सेम, राइट वेंट्रिकल, राइट एट्रियम एंड बिटवीन द लेफ्ट वेंट्रिकल लेफ्ट दैट इज ए mitral wall and between the right atrium and right ventricle you see a tricuspid valve. तो फर्स्ट इसमें सबसे सर्जन्स को इमेज आइडेंटिफिकेशन आना चाहिए कि हमें विंडोज कौन सी चूज करनी है, किस विंडो में हार्ट चेम्बर्स आइडेंटिफिकेशन कौन कौन से हो रहे हैं इसमें. वेयर इज द लेफ्ट वेंट्रिकल, राइट वेंट्रिकल, लेफ्ट एट्रियम एंड वेयर इज द राइट एट्रियम एंड व्हाट आर द पोजीशन ऑफ द पेशेंट. तो इन apical view, left lateral decubitus position, also in parasternal long axis, short axis में you can also do in supine position, but better visualization also in left lateral decubitus position. And in subcostal view, patient is supine position with leg is flexed होने चाहिए, so you can better. And it is something is very difficult for the surgeons कि इसमें supraesternal view है, but आपको ये you can emergency अगर you can do it, then you can go do for the supraesternal view. So इसमें mainly that is the supraesternal view इसमें the pointer towards the left ear रखना है in the supraesternal notch, probably placed on the supraesternal notch. Then you can see अभी workstation में देखेंगे that is the ascending aorta, arch of aorta and the descending aorta. In case of any dissection or you can say any dissection flap, you can identify aortic dissection quickly based on your experience. So what are the indications? I already discussed in the quiz what are the indications for doing the echo. So based on the surgeon, there are many indications, but the grossly we focused on फर्स्ट कि अगर पेशेंट आईसीयू में आया है, हमारे यहाँ कोई सर्जिकल पेशेंट्स है क्योंकि सर्जन्स की वर्कशॉप है कोलैबोरेशन में, तो सबसे पहले इतना आइडेंटिफाई होना चाहिए कि अगर पेशेंट है तो एक नॉर्मल फंक्शन कैसा है हार्ट का, इतना हमें मालूम चल जाए है ना कि पेशेंट हाइपोवॉल्यूमिक तो नहीं है, कार्डियक चैम्बर्स ठीक है, हार्ट की कॉन्ट्रैक्टिलिटीज ठीक है, बट यू कैन आइडेंटिफाई जस्ट 2 to 3 things. And if patient having a hypotension, your patient is on shock, then you can identify the cause of the hypotension or cause of the shock. You can also assess clinically, trauma का patient है, fluid loss हुआ है, fluid deficit है, long term surgery admission है patient का, fluid any kind, you can see कि hypovolemic patient, cardiac patient है, known history of MI है, dilated चेम्बर्स हैं पहले से, हाइपरटेंसिव पेशेंट है, पेरिकार्डियल इफ्यूजन, तो यू कैन की पेशेंट कार्डियोजेनिक शॉक पेशेंट को हो सकता है. तो बेस्ड ऑन योर क्लिनिशियन, बेस्ड ऑन योर एक्सपीरियंस, यू कैन असेस क्लिनिकली कि पेशेंट शॉक में क्यों जाए, एंड यू कैन प्रूव इट बाय डूइंग द इकोकार्डियोग्राफी इन ए क्विक. तो to identify the hypotension and shock, like cardiogenic shock, hypovolemic shock, obstructive shock, and this we are not going in detail in these type of shock, but we are focusing on the echocardiography. तो फर्स्ट हमें नॉर्मल असेसमेंट करना है फंक्शन का कि कैसे हम करें. एक सर्जन्स क्या कर सकता है, अगर कोई पेशेंट आता है उसके पास, कोई पेशेंट डिटोरेट हो रहा है, पेशेंट हीमोडायनेमिकली अनस्टेबल हो रहा है, तो व्हाट कैन डू क्विकली. So first you assess actually first offline you can assess grossly what is the ejection fraction, what is the contractility of the left ventricle, कैसा है लेफ्ट की contractility कैसा है, ठीक है. तो but you can quickly, I'm not going to write with this systolic function or valvular insufficiency, regurgitation है, lesion है, stenosis है, but you can identify what is the contractility of the left ventricle in a quick manner. तो आप इसमें देखेंगे दैट इज अ इमेज. तो फर्स्ट कॉन्ट्रेक्टिलिटी के लिए यू कैन गो द पैरास्टर्नल लॉन्ग एक्सिस व्यू और इन एपाइकल 4 चेम्बर व्यू. तो एपाइकल 4 चेम्बर में आपको मेन यू फोकस ऑन द लेफ्ट वेंट्रिकल. तो दैट इज अ 4 चेम्बर व्यू. यू ऑल आइडेंटिफाई दिस इज अ लेफ्ट वेंट्रिकल, लेफ्ट एट्रियम, राइट वेंट्रिकल एंड राइट एट्रियम. लेफ्ट वेंट्रिकल में आई एम गोइंग टू प्ले वीडियो कि आप जैसे, और दिस इज अ पैरास्टर्नल शॉर्ट एक्सिस व्यू में ये देखेंगे. इसकी आप वॉल्स के कॉन्ट्रेक्टिलिटी देखिए, दैट इज अ सेप्टल वॉल, बेस्ड ऑन योर एक्सपीरियंस. मैंने इसमें किसी मेजरमेंट्स नहीं लिया है, इसमें सिर्फ ऑन द विजुअल, बीइंग ऑन योर विजुअल असेसमेंट यू कैन गेस व्हाट इज द ejection fraction, you can get it usually. इसमें देखिए that is a all wall contacting 4 chamber view, anterior wall, inferior. So this is a, फिर से again these wall are contractility is good. पहले हम नॉर्मल वर्कशॉप में भी सीखेंगे व्हाट इज द नॉर्मल, देन यू कैन आइडेंटिफाई व्हाट इज द एबनॉर्मल, व्हाट इज द मिनिमम रिड्यूस्ड रिजेक्शन फ्रैक्शन. वेरी इट इज अ शॉर्ट एक्सिस व्यू. शॉर्ट एक्सिस व्यू में ये कैविटी ऑब्लिटरेशन बिल्कुल हो रहा है, गुड. दिस इज अ यू कैन, आपको सिर्फ इस पे फोकस करना है ऑन द लेफ्ट वेंट्रिकुलर वॉल. इसमें मेन इंपॉर्टेंट है सारी वॉल प्रॉपर्ली कॉन्ट्रैक्टिंग है, कोई एकाइनेटिक नहीं है. अगर किसी वॉल में एकाइनेजिया है, मूवमेंट्स बिल्कुल उस पर आपको मूवमेंट्स नहीं दिखेगा उस वॉल पे, डिस्काइनेजिया. नेक्स्ट टू आइडेंटिफाई द हाइपोटेंशन इन शॉक में फर्स्ट इज कार्डियोजेनिक हाइपोटेंशन. कार्डियक हाइपोजेनिक हाइपोटेंशन में ओनली assessment of the left ventricular function by the eyeballing or visual assessment. There are many methods to assess left ventricular function like Simpson method, etc. But for quick assessment, for surgeon, you can visualize by eyeballing method. So let's see in the next slide. First you see the normal ejection fraction. आप वीडियो में देखेंगे in all chambers में. दिस इज अ पैरास्टर्नल, मैंने बताया था ये लेफ्ट वेंट्रिकल, राइट वेंट्रिकल, एओर्टिक वाल्व भी दिखता है जिसमें, माइट्रल वाल्व भी दिख रहा है. दैट इज पैरास्टर्नल लॉन्ग एक्सिस व्यू. इसकी इसमें आप लेफ्ट वेंट्रिकल की कॉन्ट्रैक्टिलिटी यू कैन असेस विजुअली. दिस इज अ 4 चेम्बर, यू कैन असेस. दिस इज अ पैरास्टर्नल आल्सो लॉन्ग एक्सिस व्यू. दिस इज पैरास्टर्नल शॉर्ट एक्सिस. अब नेक्स्ट स्लाइड में है कि एकदम सीवियरली रिड्यूस्ड इजेक्शन फ्रैक्शन. हैव यू सीन एनी डिफरेंस इन बिटवीन टू वीडियोस? अगेन आई एम प्लेइंग जस्ट कॉन्ट्रैक्टिंग, ऐसा है कि जैसे सिर्फ वेरी लेस मूवमेंट. शॉर्ट एक्सिस व्यू, लॉन्ग एक्सिस, 4 चेम्बर व्यू. and this is a normal functioning heart. अब इसको कंपेयर करेंगे नेक्स्ट स्लाइड में. ये शॉर्ट एक्सिस व्यू में दिस इज ए नॉर्मल फंक्शन assessment. Sorry. $55 to 70%, 40 to 50%, थोड़ा इससे लेस कॉन्टेक्टिविटी, वो थोड़ा कम कॉन्टेक्टिविटी 30 to आप 20 से 25 इकोकार्डियोग्राफी करेंगे इन ऑल व्यूज, यू कैन डेफिनेटली असेस द इजेक्शन फ्रैक्शन अप्रॉक्सीमेट 5-10 का अंतर हो सकता है based on your experience. It is a good contact fraction 40 to 50, 30 to 35%, and is very lesser contactly, that is about 20%. And in next video, this is a normal in the right long parasternal long axis view है इसमें 4 chamber 40 to 45, 40 to 40. You can see long axis view 30 to 40 थोड़ा सा कम, parasternal long axis view even lesser and more lesser, that is 20 to 20. So you can by eyeballing or by visualization you assessment the left ventricular function in case of cardiogenic shock. आपको लगेगा कि 100% severely reduced है, it may be cardiogenic shock हो सकता है, unless otherwise कोई septic patient है, septic shock है, septic cardiomyopathy हुआ है, then also in that condition the ejection fraction, left ventricular fraction is reduced. Second one is hypovolemic shock. Hypovolemia, different causes है, you all know. So there are two non-specific clues which is the most important to assess hypovolemic shock. The first is collapsed IVC, inferior vena cava. Normal diameter is 1.2 to 2.1. इसमें visual assessment करेंगे, workshop में we can measure. And second is the collapsibility of left ventricular walls at the end of the systole, so-called kissing walls. So these two parameters are most important for quick assessment of the hypovolemic shock. Let's see. First you see the normal IVC. तो IVC focus करने के लिए which view is most important is subcostal या subgified view. उसमें आप देखेंगे IVC is collapsible about 50%. IVC के लिए this is a IVC, this is a right atrium draining IVC into left atrium, and this vein is hepatic vein. तो आपको जब subcostal view पे आप probe रखेंगे, you can identify the contractile left atrium and this hepatic vein to identify the IVC. So these two important structures. And in case of collapsed IVC, you may find, आप ये देखिए, left ventricle, that is hepatic vein draining to the IVC, and IVC is collapsible, nearly 80 to 90%. This is a collapsible during inspiration. Inspiratory collapse mainly हमको देख रहा है, during inspiration, collapsibility of IVC. Third view में you can compare. There is a normal IVC, minimally collapsing or maybe fluid overload, and this is brief collapse, intermediate. और इसमें आप ये देखेंगे, इसमें पूरा IVC पूरा collapse, both walls are approximating each other. So for hypovolemia, only two structures. First, focused on the IVC and contractility of the left ventricular wall. Both walls are, that is a kissing walls. जैसे आप इसमें ये देखिए, this is a short axis view. शॉर्ट एक्सिस में कैविटी का आप देखें पूरा अबाउट कंप्लीट ऑब्लिटरेशन ऑफ द लेफ्ट कैविटी. जैसे हम पहले देखते थे इजेक्शन फ्रैक्शन 50 to 60% में एकदम कंप्लीट ऑब्लिटरेशन नहीं होता, दैट इज नॉर्मल कॉर्टेक्टरी हार्ट, बट हियर यू कैन सी complete obliteration of the left ventricular, and these are the papillary muscles, these are ye papillary, kissing papillaries you can also say. So hyperdynamic left ventricle, four chamber view, short axis or long axis view mein, and there is a collapsed IVC. These two main features in the hypovolemic shock. Next is obstructive shock. ऑब्स्ट्रक्टिव शॉक में मेनली इमरजेंसी में दो कॉजेज हैं. एक तो पेरिकार्डियल टेम्पोनॉड, जैसे फास्ट में पेरिकार्डियल हमने इफ्यूजन देखा माइल्ड, है ना. दिस इज मैसिव मॉडरेट टू मैसिव कार्डियल इफ्यूजन इनके. तो इसमें देयर आर 4 मेजर फाइंडिंग्स. फर्स्ट मैसिव पेरिकार्डियल इफ्यूजन, द प्लेथोरिक IVC, दिस इज IVC कोलैप्सिबिलिटी इज लेस देन 50%, and diastolic collapse of the right atrium and the right ventricle, and there is swinging heart. Swinging heart एक तैरता हुआ heart दिखाई देगा in case of cardiac tamponade में. तो this is a mild effusion है, this is not a tamponade but is mild cardiac effusion. जैसे आप देखें this is a ventricular wall, this is a pericardial effusion. You can see here the descending aorta. तो पेरिकार्डियल इफ्यूजन में क्या था, ऐसा है जैसे आपने प्लूरल इफ्यूजन भी बताया, ठीक है ना. तो लंग्स में पेरिकार्डियम से लेके यहाँ इफ्यूजन दिख सकता है, बट इफ इफ्यूजन दिस शैडो हाइपोइकिक इज नॉट एक्सटेंडिंग बियॉन्ड द इंफीरियर डिसेंडिंग एओर्टा, इट इज अ पेरिकार्डियल इफ्यूजन. बियॉन्ड है मैसिव है तो इट मे बी प्लूरल इफ्यूजन विद पेरिकार्डियल. And this is plethoric. It is nearly non-collapsible. And this is IVC, hepatic, left atrium, right atrium, and this is a IVC. So distended IVC, non-collapsing IVC with massive pericardial effusion, with swinging heart and diastolic collapse of right atrium and right ventricle during the diastole. दिस इज अ वीडियो में देखें. ये कौन सा व्यू कोई बता सकता है? एनीवन? सबकॉस्टल है ना, पहले जिसमें 4 चेंबर में थोड़ा टिल्टेड इसमें देंगे. तो दैट इज अ लेफ्ट एट्रियम, LA, लेफ्ट वेंट्रिकल, लेफ्ट एट्रियम, राइट वेंट्रिकल एंड राइट एट्रियम. तो देयर इज, आप देखेंगे इस कोलैप्सिबिलिटी है ड्यूरिंग द सिस्टोल, देयर इज ए कोलैप्स ऑफ द LA and LV, and there is massive pericardial. If आपने पोव रखा सबकॉस्टल, आपको पहली बार में ही ये इमेज विजुलाइज हो जाएगी और आप ये मान लेंगे दिस इज ए मैसिव कार्डिया. आपको कार्डियोलॉजिस्ट को अर्जेंट में कॉल करना है ना, इफ पेशेंट इज हीमोडायनामिक स्टेबल, आप इसका टैपिंग के लिए. तो दिस इज अ टाइप ऑफ ऑब्स्ट्रक्टिव शॉक. नेक्स्ट वन इज पल्मोनरी एम्बोलिज्म, वेरी कॉमन. तो इसके लिए मोस्ट कॉमन व्यू फॉर आइडेंटिफाई द पल्मोनरी एम्बोलिज्म, दिस इज अ क्लू है एक, 100% नहीं, बट यू कैन आइडेंटिफाई एम्बोलिज्म. देयर इज अ डायलेटेड राइट एट्रियम एंड राइट वेंट्रिकल एंड हाइपोकाइनेसिया ऑफ द राइट फ्री वेंट्रिकल वॉल इन 4 चेंबर व्यू. तो इसके लिए इंपॉर्टेंट आपको 4 चेंबर व्यू है. देयर आर 4 मेन फोकस करना है. देयर इज डायलेटेशन ऑफ राइट एट्रियम एंड राइट वेंट्रिकल. कहाँ दिखेगा वो? 4 चेंबर व्यू में, ठीक है ना. एंड hypokinesia of the right ventricular wall with apical is contracted, that is called McConnell signs. Also tricuspid regurgitation मिलेगा and PA pressure जरूरी नहीं है बहुत intensivist, but you can see the dilatation of RA and RV with McConnell sign. तो इसमें आप देखेंगे इस वीडियो में, दिस इज अ 4 चेंबर व्यू. ये क्या है? राइट, ये लेफ्ट LV, लेफ्ट वेंट्रिकल, दिस इज अ राइट वेंट्रिकल. तो राइट वेंट्रिकल देयर इज अ फ्री वॉल, हाइपोकाइनेसिस, दिस इज नॉट कॉन्ट्रैक्टिंग गुड एज लेफ्ट वेंट्रिकल. यू कैन कंपेयर बोथ साइड, ठीक है ना, एंड सी द चेंबर साइज, ठीक है ना. तो देयर इज सम dilated. Ideally, this is a 1:1 ratio. For normally, आप कर सकते, but it is dilated more than 1. You can there is some dilatation. By visual assessment, you can say if grossly dilated, you can identify. So dilatation of the right ventricle and the right atrium with ये देखिए ये apical wall is moving. ये दिख रहा है यहाँ पास कुछ? Apex is slightly moving, but this is a hypokinetic. This wall is hypokinetic. So that is called McConnell sign. So this sign helps you to identify the clue about the pulmonary embolism. So there is tricuspid regurgitation, the sign that is septum is pushed towards the left ventricle because of the dilated RV. So these are the some clues. The dilatation of the RV, 1:1, more than 1:1, that is RV dilatation you can identify. The aortic dissection seen in the supraesternal region, I can demonstrate you on the workshop. And the distributives are most common is sepsis. You can identify sepsis by the lab report or clinically. And you go part, उसमें भी same है. Because of the peripheral vasodilation, leaking of fluid in the third space, there is a hypovolemia. So then again there is आपको same findings मिलेगी. There is a collapsed IVC and the hyperdynamic left ventricle. So you can see, फिर से revise, that is a collapsed IVC and hyperdynamic. This is a hyperdynamic LV. Complete obliteration of the cavity, LV cavity. So these two signs also seen in the septic shock. Septic cardiomyopathy, involvement of the cardiac involvement, then you, in case of sepsis, there may be a cardiogenic shock. Thank you so much.
Thank you, Dr. Deependra. Time is running fast. It's a very basic sort of echocardiography which he has tried to demonstrate for the people who are in OT or in surgeon in the surgery preview, and it does help a lot preliminary level. So quite an informative talk. The house is open for the discussion. If any question is there, we will take it fast. Okay, thank you so much.
And thank you, Dr. Deependra, for very elaborative presentation regarding the echocardiography in emergency. Thank you, both the chairperson. We'd like to felicitate both the chairperson as well as the speaker. Dr. Deependra, please come forward. I will request Dr. Jyotijan, please come forward to present a memento to Dr. Deependra. Yes. Jyoti. Thank you, Dr. Deependra. Thank you. And I will request Dr. Kamlesh Verma. He is one of the honor of this Bhopal Fracture Hospital as well as Multispeciality Hospital. And please present a memento as well as bouquet to our both the chairperson, Dr. Shailesh Dunawat. He is one of the leading radiologists of Madhya Pradesh. He is in the Society of PCPNDT Act. To just say a few words about the PCPNDT Act, for today's workshop, we are following all the rules and regulation of PCPNDT Act. Means we have taken the permission of Government of Madhya Pradesh. We have deposited the entire amount for training purpose. Thank you, Dr. Shailesh sir and Dr. Jitendra Jan. Thank you, Dr. Jitendra. Yes. Thank you. Thank you all the chairperson, Dr. Verma, as well as the speaker. And it's my privilege to say that today with us, Dr. Sunil Malik. He is president of All India Institute of Medical Science, Bhopal. And Bhopal AIMS comes after Delhi AIMS. So he is our today guest of honor, and we'll like to welcome Dr. Sunil Malik. I will request Dr. Sunil Malik, please come forward, because he has to do so many things. I will request Dr. Santosh Bhas as well as Dr. Bharti Malik. Please come forward. Please welcome Dr. Sunil Malik. ये जाती है. Dr. Bharti, please. Dr. Sunil Malik is doing a lot of work for improvement in All India Institute of Medical Sciences, and under his leadership we are going to conduct instructional course 2nd, 3rd, 4th April, first week of April in Bhopal in AIMS, and after that we are going to have fellowship examination. This is called Fellowship Examination of Association of Colorectal Surgeons of India. It's a very prestigious examination, and Bhopal Surgical Society as well as AIMS, they got the opportunity to conduct this examination. And I will request Dr. Sunil Malik, please come forward, because I want to, all the delegates are here? Yes. So we'll like to give certain mementos as well as certificate to all the delegates, because we are going to conduct this session after this presentation, and because he has to attend so many scientific events today, so we'll call one by one all the delegates. Yes, you can come forward. Yeah. Dr. Shruti, please. She is here. And all the delegates, those who have come outside Madhya Pradesh, they can come forward one by one. Yeah, you can come, please, sir. Dr. Ajinkya, Dr. Shruti, Dr. Mohammad Nadeem, Dr. Lokesh, Dr. Chandrasekhar. Sunil, Dr. Sunil, please. Yeah, yes. All the delegates. Today in this scientific event, we are giving a very prestigious book written by Dr. S.K. Nigam to all our delegates free of cost. Yeah, sir, you can come forward. Dr. Anju, Dr. Vinita, Dr. Archana. I think Dr. Archana is there. Yeah. Anybody else? Yeah, Dr. Kavishwar, you can cover. Dr. Kavishwar is one of the senior most surgeons of Bhopal. Anybody left? Yeah, you can. Dr. Rakesh, please. Dr. Sarthak, you can also come forward. You can collect your memento as well as this prestigious book on proctology. So, before proceeding for further clinical presentation, I will request Dr. Sunil Malik, President, AIMS Bhopal, to say a few words to all our delegate chairpersons as well as organizing team. Dr. Sunil Malik, please.
Thank you, Dr. Rajiv. A very good afternoon to you all. I extend my greetings to the Academy of Critical Care Medicine Bhopal, Bhopal Surgical Society, all the distinguished panelists and participants for this hands-on workshop on USG procedure for surgeons and orthopedicians. It is indeed very heartening to note the vibrancy, the enthusiasm with which such academic events are held. Indeed, they go a long way in learning from one another and from sharing our experiences. Undoubtedly, every patient is different. Every patient whom we see teaches us something. We have to set, reset, and keep honing our skills every single day. The pursuit of learning is lifelong, and it is indeed enjoyable. At the All India Institute of Medical Sciences, Bhopal, our endeavor is always to promote, to advocate, and to, I repeat, promote all sorts of academic pursuit. We have a very vibrant administration. We have a very fine Executive Director, Professor Ajay Singh. We have wonderful faculty. Probably we have one of the best faculties in the country at AIMS Bhopal. And we are always, the AIMS Bhopal is always open to every sort of academic activity. Now, I repeat, the pursuit of learning is lifelong and it is indeed enjoyable. I extend my best wishes to this workshop, the goal of which and the goal of all similar academic pursuits is only one, that is to help and to do our best for a fellow human being who is in pain and who is in suffering. I thank the organizers, especially Dr. Rajiv Sharda, who is one of the finest surgeons I've known, for having invited me. My best wishes to you today and always, to all of you. Thank you. Jai Hind, Jai Bharat.
Thanks, Dr. Sunil Malik, for coming all the way from AIMS Bhopal to our center for this scientific event. And before proceeding for lunch, we'd like to take one more presentation by Dr. Amit Singh. He is going to present his talk on ultrasonography in CPR, very important topic for all of us. Yeah, he's to chair this session, I would like to invite Dr. Atul Saurabh. And Dr. Atul Saurabh is one of the senior most geriatric physician. He is taking care of all the geriatric patients of our city, Dr. Atul Saurabh, as well as Dr. Jiten Jain. Once again, where is Dr. Jiten? You can come. No issue. Yes. And Dr. Amit Singh. He is one of the senior most critical care expert, intensivist in our city. Amit is.
Good afternoon, everyone. So, I would like to thank the team for inviting me for this lecture. And I know that you all are hungry, so I'll finish this in 8 minutes. Because most of the work is done by Dr. Radhika and Dr. Dipen. So my work is very easy. So I'm just giving the insight key. When Dr. K.K. Thakur gave me this topic, so I thought, what will I present in this? What new is this? So when I learned about that, so I never did ultrasound during CPR. So this is also new for me, and maybe I will take this into my practice. So Basically, it is termed as sonography in hypotension and cardiac arrest in the emergency department, SHOCED. It is termed by the resuscitation, which is a general, so they did a gave a terminology to this topic. So what is the objective of using echo or ultrasound? The objective is, the first is, can we optimize the resuscitation effort with the use of the ultrasound? And the second, to identify the cause which is leading to the cardiac arrest. So, we have to keep in mind that it should not hamper effective chest compression and ventilation. There is a lot of debate that using the ultrasound can hamper the quality of chest compression. So we all know that ACLS tells us that what is high quality CPR. High quality CPR is chest compression at the rate of 100 to 120 per minute, depth of chest compression at least 5 centimeter, allow adequate chest recoil, minimum interruption, and proper hand placement. And what else we can do with the help? We also take care of the airway during the CPR, and we try to identify the causes while during the CPR. What is the cause? What is leading to the cardiac arrest? So how ultrasound helps in this? So 2010 American Society and Echocardiography team and American College of Emergency Physician, and 2015 European Resuscitation Council guidelines recommends cardiac arrest ultrasound primarily for non-shockable arrest. In the shockable rhythm, we have to shock. We have to give shock. We have to defibrillate the patient. The first is to confirm rhythm, and second is identify the pseudo pulseless electrical activity. What is this? Sometimes what we have in the ACLS, we see that there is a sinus rhythm, but there is a absence of pulse. What happens when you put ultrasound? You can see the cardiac activity. So this is pseudo PEA. And then finally, to identify the reversible causes. What modality we can use? Transesophageal or transthoracic. Transesophageal, the availability is less. Transthoracic is easily available. But the better visualization of the cardiac chambers, cardiac contractility can be easily done by the transesophageal. What is the side effect? There can be airway trauma, there can be esophageal injury and gastric injury can happen with the transesophageal echocardiography, because it is the crash-like situation and we are doing very fast, not in organized manner, so there can be complications also. So, pulselessness. The first thing that what we do in ultrasound, we do CPR for 2 minutes, then check the pulse. CPR for 2 minutes, then check the pulse. So, identify the pulse by the ultrasound can be useful or not. Is it the waste of time? So there is a lot of debate on this. So 2 papers were published. One is 2014 and one is 2023. The first paper was published in Resuscitation. They did a point of care ultrasound used in patient with cardiac arrest. Can it associated with the prolonged cardiopulmonary resuscitation? So they showed that there was a prolong of the time, and the pulse is checked within 5 to 10 seconds, and it is taking more time because they are taking time to visualize and to make a window, and it is causing more time. But later on, what they did, they are doing the compressions and they simultaneously find the echo window by the subjaphoid view, and so echocardiography pre-pause imaging and identify the acoustic window during CPR reduces CPR pause time during ACLS. So they found that it can be useful and it is less time consuming, although further research is required. So first thing is the rhythm confirmation. We can identify rhythm during the echo. We can put the we can make the subjaphoid window that already told by Dr. Dipen. So what happens? Maybe you will have ECG rhythm of asystole, but when you put echo probe, you can find the fine fibrillation, so this becomes a shockable rhythm and it can be reverted. That's the first advantage. Second, you can see asystole on the ECG, then again you can find the contractions. So this can be severe hypovolemia and or any type of cardiogenic shock, severe shock, which is identified as on the ECG rhythm as asystole, but the organized cardiac rhythm is available. So maybe resuscitations, inotropic agent, adrenaline infusion, dopamine infusion or dobutamine infusion can help. Then pseudo-PEA. You are having no pulse, normal rhythm and you are not having any pulse, you are telling it PEA, but it is actually C2PA. When you put ultrasound or echo, you will find the contractility of the heart. So this is the rhythm confirmation. This helps in the further management. If it is a shockable rhythm, then outcome will be far better than the non-shockable rhythm. This is the video of this is normal contracted heart. In between you can see that it is fibrillating. And again the shock is given, then again refibrillated. This is the basically you can achieve the subgyphoid window and you identify the fibrillation and immediately shock the patient, rather than waiting for 2 minutes. So it is basically preventing, it is ultimately make the outcome better. Then second is ultrasound guided chest compression. You do chest compression, in the ultrasound guided, you put the probe. What happens, you cannot make the other short axis window, long axis window, peristernal, long axis and short axis, but you can easily make the subgyphoid window. You put the probe in the subcostal view and do the chest compression and see how your chest compression is helpful for the LV contraction. How is LV is compressed. Sometimes what happens your compressions are hampering the outflow of the left ventricle. So you can guide your compressions by ultrasound. What ACRS says, you put your hand on sternum in between the upper 2/3 and lower 1/3, and but most of the person, most qualified and skilled person can do the wrong compressions. So these can be guided by ultrasound. So they societies which I mentioned previously, they recommend 3 parts. The one is the core part, which is the compulsion during the CPR, and supplemental and additional part can be done if you are suspecting. Suppose I am on echo, I am suspecting pulmonary, I can see the for DVT. Suppose I am doing the trauma scan, I am finding the I can also see that there is a hemothorax or hemoperitoneum. So these are 3 parts. So now echocardiographic view, already discussed in detail by Dr. Dipen. The one is the para-external long axis. We put the our echocardiographic probe in left 3rd to 5th intercostal space, 3 to 5 centimeter from the sternum, and the pointer towards the right shoulder. And then we turn it towards left on after making the window. When we turn towards the left shoulder, then it becomes the parasternal short axis. So that is the view we achieve on echo. We can see LA, LV and right ventricle and aorta. And in short axis we see left ventricle and right ventricle. And in this window you can identify the RWM, regional wall abnormality, very easily in the parasternal short axis view. Then again the 4-chamber view, we put the probe in the apex of the heart, usually around the nipple in the 5th intercostal space, and the pointer is towards the left shoulder. We achieve this 4-chamber view. You can see right ventricle, left ventricle, right atrium, LA. What can we see in this? We can identify the chambers, chamber size. We can see the regional wall motion abnormality. Then again the most important in CPR is subxiphoid or subcostal view. We can see RA, left atrium, left ventricle, right ventricle, and this is also to find most important view to find the immediate correctable cause, which is cardiac tamponade. That is video Dr. Dipen has shown. So these are the identification of the reversible causes. So these are the 5H and 5T of the ACLS guideline, which is hypovolemia, hypoxemia, hydrogen and metabolic acidosis, and hypokalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, and acute myocardial infarction, and acute pulmonary embolism. So what only these can be ruled out with the use of the ultrasounds. So I am taking one by one. So one is pericardial effusion or tamponade. What we see in this view, this is we achieve the subgyphoid view. We can see the pericardial effusion over the right ventricle, and there is a diastolic collapse of the right ventricle, which is the pathognomy of the cardiac tamponade. Even in the condition of the cardiac arrest, if there is a very large pericarditis, you can easily drain out by the ultrasound guidance, and it is immediately the cause is reversed and patient may have a survival benefit. Then second is pulmonary embolism. So pulmonary embolism, we do the 4-chamber view by 4-chamber view of the on the echo. What can we see? Right ventricular enlargement, right ventricular dysfunction, right ventricular thrombus can be seen, and McConnell sign, which have been discussed, which is the basically all whole of the wall of the right ventricle is hypokinetic except the sparing the apex. That is McConnell sign. And RV to LV ratio. Usually RV is slightly lesser diameter than the left ventricle, but in this case the right ventricle will enlarge and left ventricle it may collapse towards the left ventricle and also hamper the left ventricular contractility. This is the echo. Then you can see the size of the left ventricle is 5.31 centimeter and right ventricle is 5.39 centimeter. It is enlarged. You can see the difference between the chambers, left ventricle and right ventricle. This is a hyperechoic that thrombus is seen in the right ventricle, and you can see the whole of the right ventricular wall is hypokinetic except the apex. That is the McConnell sign. Now again, which this is a treatable cause of cardiac arrest is tension pneumothorax. So Dr. Radhika has been discussed these findings. So we have 3 signs. The one is the absence of lung sliding. She showed that there is shimmering and there is lung sliding present. If there is a lung sliding is absent, then we will focus on the lung point sign, and then we can put the M mode on that, and we can have this barcode sign. I will explain this. So this is what we do. We put a linear probe on the 2nd or 3rd intercostal space, pointers toward the right side. Sorry, pointer toward the patient's head. So what we cover, upper rib and lower rib, and we can see on ultrasound. The image is coming. What we see, there are 2 ribs. Acoustic shadows are present, and in between the pleura is seen. And this phenomena is known as shimmering, and the lung sliding is present. There is a pleural line. You can also appreciate the B line, which is from the pleural line towards it. So what happens when pneumothorax occurs, this slidings and shimmering becomes absent, and this B lines also becomes absent. And this is lung point. You can see one part of the lung pleura is sliding, but other is stagnant. So this is lung point. So we move the probe around and we can find this lung point, and this is the pathognomy of the pneumothorax. When we put M mode on this, so what happens when we put M mode? So in normal lung, we see the seashore appearance. Achha, okay. So, anyways, so this is seashore sign. We can see the waves and sand, and in between that is line is between them. That is pleural line. And when there is a pneumothorax, we see the barcode sign. There will be no seashore appearance. It is looking like the barcode. So that can be achieved by the M mode. So this is basically this is also pathognomy of the pneumothorax. And if you find pneumothorax, immediately treat the cause, and cardiac arrest can be reversed. Then again there is a LV assessment of the LV function, but LV function can be reduced post cardiac arrest without the acute myocardial infarction. So ideally, when you achieve the ROSC, return of spontaneous circulation, you should get an ECG done. If you are having ST elevation LMI, neurological impairment is not there, so you can directly go for the angiography. But on the basis of the echo, suppose you found an RWMA or reduced LV function, you cannot go for coronary angiography because it can be post cardiac arrest LV dysfunction because of the ischemia, perfusion injury, and maybe because of the chest compressions. What else? What else we can do? We can assess the hypovolemia, IVC, collapsibility and distensibility already discussed by Dr. Ibn. We can assess the DVT. If we are suspecting pulmonary embolism, immediately do the compression ultrasound of the legs, veins, deep veins, and then you can have, you find the DVT. And it also helps in the cannulation. This is the totally separate topic. Sometimes we do eCPR, ECMO. We put ECMO during the CPR till we reverse the cause. So immediate cannulation we can guide with the help of the ultrasound. Second, we can also find the position of the endotracheal tube by the help of the ultrasound. These are the other things we can use the ultrasound with the ultrasound. So now is the last slide. Is point of care ultrasound a reliable predictor of outcome during atraumatic non-shockable cardiac arrest? This is a systemic review. What it says, cardiac activity on POCUS was associated with improves odds of returns of spontaneous circulations and in non-traumatic non-shockable cardiac arrest. So they are basically this study is for non-shockable cardiac. Shockable cardiac arrest means you directly shock the patient and outcome is in research it is better. But it is useful in non-shockable cardiac arrest. So you can change the outcome by using the ultrasound in non-shockable cardiac arrest. Take-home message, ultrasound can help in identifying in rhythm and return of spontaneous circulation. It is an effective tool to identify the cause of the cardiac arrest. Ultrasound guided chest compression may increase the chances of survival. Thank you so much. Any questions?
Thank you, Dr. Amit. We are eagerly waiting for the lunch. And before that, we would like to have one or two questions if anyone is anyone have any queries regarding this.
I think this is very new topic for all of us,
Yes.
USG and CPR procedure.
Yes.
Because we know at that time, if we are doing CPR and we have to assess the cardiac status by doing the ultrasonography. Very interesting. It was very new topic for me also.
Actually.
So thank you,
Thank
Dr.
you, Dr.
Amit,
Amit,
for presenting this issue in our forum, and we are thankful to Dr. Atul Saurabh. I will like to present a memento to Dr. Amit Singh, because we are getting late and there is so much enthusiasm for all the delegates for this workshop, and very important point is that we are going to conduct online training program as well as hands-on training program for all the delegates, those who have come from different part of the other states. Yes. Yes, Dr. Santosh, please. Make it fast. Atul Saurabh, please. Now I will request, meanwhile the felicitation procedure is going on, I will request Dr. Sumit Prati. He is going to cover the last part of our CME, but the very important part is still left, which we are going to start after our lunch session, and that is PCPNDT Act. And to chair the session, I will request Dr. Shailesh Runawat. He is one of the member of working committee of Madhya Pradesh government for PCPNDT Act. Meanwhile, I will like to share this information that today we are about 50 surgeons, intensivists and radiologists here in this conference hall, and today this program has been watched by about 350 surgeons across the country through YouTube analysis. Now, Dr. Sumit Upreti regarding the PCPNDT Act.
Good afternoon, everybody. Now I am very, already we are too late, so I am skipping so many of my slide on the PCPNDT Act inside. First of all, what is PCPNDT Act? The Preconception and Prenatal Diagnostic Technique is a prohibition of the Sex Selection Act, which is made in 1994, followed by amendment. The term preconception has been added in 2003. There are so many definitions in this act. I think it's better to skip so many definitions and just concentrate over the important topics over this PCPNDT Act. It is basically an act to provide the prohibition of sex selection before or after conception, and for the regulation of the prenatal diagnostic technique for the purpose of detecting abnormalities, for the prevention and then misuse for the sex determination leading to a female feticide. The importance behind this Search Act came because the medical fraternity has made it possible and easy to diagnose the sex of the fetus, particularly female feticide. It has been increasing, so this act comes into the function under the PNDT Act 1994. What is the objective is of this particular act? To prohibit the sex selection before or after conception, to regulate the prenatal diagnostic technique for detecting genetic or metabolic disorder or chromosomal abnormality or congenital malformation or sex-linked disorder, and to prevent misuse of such technique for the purpose of sex determination. There are so many provisions of the Act. First is the prohibition of misuse of PNDT for sex determination, prohibition of advertisement of PNDT for sex determination. There are certain authorities who provide permission and regulation of PNDT for specific purpose only by the registered institution, and if there is punishment for the violation of such act. There are so many definitions. Appropriate authorities formed by the central government. Similarly, the appropriate authority functions as to grant, suspend or cancel the registration of genetic counseling center, to investigate the complaint, to create public awareness, or to take action or recommendation by the advisory committee. It can also summon any person whom is formed regarding the violation of the act. Advisory committee has been formed. I am not going to detail of formation of advisory committee. Similarly, there is central supervisory board. Similarly, there is state supervisory board. And the what is genetic counseling center? It means any institute, hospital or nursing home or any place which provide the genetic counseling to the patient. And what is genetic clinic? The clinic, institute, hospital or nursing home or any place which is used for conducting the prenatal diagnostic procedures. Such genetic clinic includes any sort of vehicle where ultrasound machine or any other equipment is used for detection of sex during pregnancy or selection of sex before the conception. Genetic laboratories are the place where facilities are provided for conducting the analysis or test of sample received from genetic clinic for prenatal diagnostic test. It includes a place where ultrasound machine, any imaging machine, including CT or MRI or other equipment is used for the detection of sex during pregnancy or sex selection or selection of sex before the conception. What is the prenatal diagnostic procedure? Any sort of diagnostic procedure which is helpful in the chromosomal analysis or any sort of the fetal malformation just for the purpose of the prenatal determination of the sex. There are so many prenatal diagnostic tests, ultrasonography and tests for analysis of amniotic fluid, chorionic villus sampling or any tissue or fluid of the pregnant woman or conception conducted to detect the genetic disorder, metabolic or chromosomal or congenital or hemoglobinopathy sex-linked disease. Who is the sonologist or imaging specialist? A person who possesses any of the degree of from the medical qualification registered under the Indian Medical Council or who has a post-graduation qualification in ultrasound or imaging technique or in radiology. What is sex selection? Again, any sort of procedure which increases the probability that embryo will be a particular sex is called sex selection. What are the various regulation of genetic counseling center, laboratories and clinics? No genetic counseling center or laboratory or clinic can do unless the center has been registered, can conduct, associate or help in conducting activities relating to the prenatal diagnostic technique. No genetic counseling center can employ or take service of any person who does not possess particular qualification, and no medical genetist, gynecologist, pediatrician, doctor or any other person can conduct the prenatal diagnostic at place that is not registered under the PCPNDT. There is also some prohibition of sale of ultrasound machine to the person, clinic and the lab that has not registered under this act. That means that you have to first see before selling any machine whether that particular place is registered under PNDT or not. There are certain indications of the prenatal diagnostic technique. I am skipping all these things. Important thing is when can PNDT be conducted? Any of the following condition, if the pregnant woman is about 35 years, that is high risk pregnancy, or any pregnant woman who has undergone 2 or more spontaneous abortion of fetal loss, pregnant woman exposed to potentially teratogenic agents, pregnant or her spouse has a family history of mental retardation or physical deformity, any other specific condition which is specified by the Central Supervisory Board, reasons for conducting such tests to be recorded in the writing. What are the points to note down? It is mandatory that the person conducting ultrasonography of pregnant woman keep the complete record in the clinic, not in the home. No person will conduct the prenatal diagnostic procedures unless he has explained all the known side effects and after effect of the procedure to the pregnant woman, obtain her written consent to undergo such procedure in the language which she understands, and copy of her consent is given to the pregnant woman. Any person conducting ultrasound image scanning on pregnant woman will have to give a declaration on each report that he or she has not detected, not disclosed the sex of fetus to anybody in any word, sign, or any other manner. The pregnant woman, before undergoing ultrasonography or image scanning, must declare that she does not want to know the sex of her fetus. How does one genetic counseling center get the proper registration? There are so many formalities over this. There Form A, first he has to apply, and with application, all the formalities has been done. I'm skipping this topic also. The important part of this topic, the unit as a whole, including the place, equipment, machine, and doctor using the machine has to be registered with the appropriate authority. Not only the center, but everything, machine, any equipment, and doctors are registered under PCPNDT. This is important point. And one center has to display the original certificate in the waiting or the sonography room. So many centers are just using the photocopy and applying it there on the display area. It is wrong. And this certificate of PNDT is non-transferable or cannot change the ownership, management, or ceasing to function. If you don't want to continue with the center, just surrender your certificate and new owner will apply afresh. Points to important points. If a unit adds a new machine, is it to be registered again? No. Additional registration fees is to be given, but the owner should inform the appropriate authority within 30 days of getting such machine, and relevant changes should be made in the certificate of the registration provided by the PCPNDT. An ultrasound machine cannot be used in a vehicle not registered as a vehicle under the PNDT Act. If a USG machine is in a genetic center but is pegged and not in use, does it require registration? Yes, it also requires the registration before selling it. But the company has to inform and get proper registration certificate for the delivery of the machine, whether it is used or not to be used. An application of renewal should be made in duplicate form A to appropriate authority 30 days before the expiry of the date of registration. Don't wait for so many days to apply afresh, otherwise your registration will be considered nil. What is the prohibition of the advertisement? You cannot show any sort of advertisement indicating that your genetic counseling center clinic is going to further sex determination. There are so many punishments under this law. There are a number of punishments. I am not going to detail all the punishment. An offense under this law is cognizable offense, means a police officer can arrest the offender without any warrant. It is non-bailable warrant, and this is non-compoundable, means parties cannot do outside court settlement under this scheme. So everyone should be very cautious about using the PNDT Act and using the ultrasound machines. But what about the maintenance of the record? This record should be kept safe for the period of 2 years. However, if there is any legal proceeding undergoing in the court, then the center has to keep the record as long as the proceedings is going on or as long as the court should ask to do so. All the records to be shown at the time of inspection. At the reasonable time, appropriate authority can search and seize the record if it has found any reasonable suspicion, and no objection can be given by the owner. What are the minimal requirements for a genetic counseling center? A sonologist or imaging specialist, a radiologist, or a registered medical practitioner having a postgraduate degree or diploma, or at least 6-month training in ultrasound. 6-month training is now mandatory. Without the 6-month training, no one can use the ultrasound.
And what about the sales of the machine? Yes, all the companies have to follow the PNDT Act rule, and none is allowed to sell or distribute or allow the use of machine unless the center is registered. Any change of intimation in the employee, place or equipment should be made to the appropriate authorities 7 days before and within a period of 30 days of such change. Otherwise, appropriate authority will take strict action against this. The code of conduct to be observed by the person in ultrasound clinic: not conduct or associate or help in carrying out the detection of sex of fetus in any manner, not conduct any technique at place other than those place registered. It means that you cannot use your ultrasound machine if in a hospital. It should be in particular place. You cannot move your machine until if you have permission for that. And display his or her name and designation prominently on the dress worn by him or her. This is also under the amendment of the law, and his or her name and designation in full under the signature is mandatory with his registration number nowadays. There are so many forms. The form A is for the application or to make it fresh application for genetic counseling clinic registration under PNDT. Form B, if is the original certificate provided by the PNDT authority. And Form C is form for a rejection of application by the PNDT authority. Form D is the genetic clinic counseling center to maintenance of the whole record. There are so many columns in the form. All is available in the book. And Form E is the form of maintenance of record by genetic laboratories. And Form F, everybody knows about the Form S, is the declaration, is the form, maintenance of form in case of a ultrasound in obstetric, in pregnant female by genetic ultrasound, genetic clinic or ultrasound clinic or imaging center. So Form F is to be accompanied by the identity proof for a pregnant female having her address. It is not mandatory. There are so many questioning about that. So nowadays, if we are going to online submission of the form in future, then we have to, it is mandatory that we have to keep Aadhaar card and other address and mobile number of the patient. Mobile number is mandatory in Form F also. If it is unavailable during emergency, it should be noted and mentioned in the report to the district authority that this patient has come under emergency and we are not able to collect the old for identity proof of the patient. This is again the form of consent, Form G. Form H is the application again to apply for permanent maintenance of permanent record of application. There are certain amendments under this act. The first act, the reconception term has been added in the PNDT Act, making it PCPNDT Act. Not only prohibit the determination and disclosure of the sex, also ban the advertisement for the such facility. All the new technologies of sex determination, including new chromosomal separation technique, has come under this law. The act has also been mandated the prominent display of signboard that clearly indicates the detection of relevant of the sex or the fetus is illegal in two languages, in the local language as well as in English. And ultrasound scanning machine has to be registered, and the manufacturers are required to furnish information about the clinic and practitioner from. This is not very important. There is in 2014 6-month compulsory training or 3 hours of the training for the resident medical practitioner, the fundamentals in abdomen pelvic ultrasound in the recognized institute, not from everywhere, with the 1:1 student teacher ratio, and syllabus is as prescribed and logbook to be maintained. They will be assessed by the examination, provided that you will get the PNDT certificate only. Another amendment of the code of conduct in 2016, there's nothing great. That's all about the PCPNDT Insight in very brief. You can go through the PCPNDT, small books are coming, and the Gazette notification of India for the amendment. Thank you, everybody.
Thanks, Dr. Sumit, for sharing the details regarding the PCPNDT Act. And once again, I will request that today in the workshop, we are following all the rules and regulation of PCPNDT Act. And today, after the lunch break, we are going to conduct hands-on training program. And a few words from Dr. Shailesh Runawat, if you want to say something about the PCPNDT Act. Shailesh sir, please come forward.
He has covered almost all the important point of the PCPNDT Act. A few more points I would like to add. Especially 6-month training is not sufficient. Now they are conducting exams. Only after clearing that exam, anyone can get the permission of doing ultrasound. And 10 major important amendments which recently implemented by the National Board. Any postgraduate doctor can do ultrasound after taking permission from the appropriate authority.
That's a good thing. That is very
No renewal unless the old machine is allowed scrapping by the appropriate authority. Intimation period for informing about old machine is 7 days. Fetal reduction not included in the invasive list. Form G is being, this is for the radiologist only. All attachment of all radiologists, this is very important for nursing homes and clinics. All attachment of all radiologists across India to be submitted in the application form. CT scan and MRI is formally included in the certificate, so all teleradiologists affiliation may have to be intimated. New registration required if the manager, if the owner is something, some different person and machine has been registered in the name of a manager, then new registration has to be taken if the manager is changed. A new entity of procedures, equipments that do not have potential for prenatal or preconception detection of sex is being created. And genetic clinic and ultrasound clinic are being defined in the rules without parallel amendment in the Act. So, as far as nursing home and practitioner is concerned, first take the permission if you are doing PG or if you are a postgraduate or a practicing surgeon, anesthetist, anybody who is practicing ultrasound along with their profession, please inform the appropriate authority and take the permission. Because any equipment which can detect the sex, capability of detecting sex, should be registered and person should be registered. So place, person and equipment, that has to be registered, all the three things, not one. That is very important. Having machine that doesn't give message that anybody can handle that. So person has to be registered and place has to be registered.
Thank you, Sheikh. Dr. Lunawat sir, for sharing the newer amendment in the PCPNDT Act. I think this is the time for proceed for the lunch, and we'll take a short break about 40 minutes, and then after we'll come back for our hands-on training. And before that, we'll like to present honor of this hospital, Dr. Kamlesh Sharma, and I will request Dr. Shekhar sir, please come forward, present a memento to Dr. Kamlesh Sharma sir, please. Those who are watching our entire event on YouTube, I will request them, even they can take the lunch also, because all of us are hungry today. So thank you everyone for being with us. And okay. So we'll take a short break. Thank you very much.
There's no pericardial effusion.
You have to look for it over here, right?
Near the surrounding, near the periphery of the heart. So it's all clear. All right. This was the first area. Achha. Haan. Then we'll go to the right upper quadrant. This is the liver. Let me decrease the gain a little. I've kept the probe along 8th, 11th rib, and the marker is towards the 12 o'clock position, towards the patient's head. This is the right kidney that you can visualize here. This is the right kidney. This is the upper, so this is the marker. You can see the marker is here. So that's been oriented there. So this is the upper pole, the lower pole of the kidney. Yeah, this hypoechoic area that you can see, it's gaseous abdomen, so it's not that way. This is the upper pole, this is the lower pole of the kidney, and that's the liver. This is the diaphragm that's coming. Now, because of mirroring artifact, since there's no pleural effusion, you can't really see, I'm going a little above the diaphragm, I can't really see any anechoic clear free fluid over here. So there's no pleural effusion. This this whitish part, that's the diaphragmatic space, and this whole is liver. That's the
Cases of diaphragmatic abscess, where can we see it?
yeah, subdiaphragmatic. You mean below the diaphragm?
Yeah.
Yeah. So it might be here. Yeah. Then he'll go to the left upper quadrant similarly. That's the left kidney, this whole left kidney, and that's the spleen. Similarly, the marker has been placed towards the patient's head. That's the spleen. And again, there's no pleural effusion, there's no free fluid in the perisplenic area. It's all clear. The whitish, the hyperechoic part, and my probe is slightly angulated up towards the head. Okay. Then I'm going to in the suprapubic region. The bladder is minimally filled. Yeah, towards me, towards the right of the patient. And I've placed the probe transversely. The bladder is minimally filled. It contains fluid, so it's black, anechoic. This is the prostate that you can see. Right now, my probe is in the transverse plane. I'll put it sagittally now. Bladder and prostate. Again, there's no free fluid in the intraperitoneal cavity. We have to look for any kind of fluid top to the cranial to the bladder. All right, there's no free fluid here.
How was the orientation of the probe again? Okay.
Yeah, now it's transverse with the marker towards me, patient's right. And now I'm keeping the probe sagittally, marker again towards the 12 o'clock position. Yeah, head of the patient.
And you have to look between the bladder and...
No, we are looking into the intraperitoneal cavity.
Okay.
So you've got to look cranial to the bladder.
Yeah. If there is fluid, it's blackened.
Exactly. The way it's appearing in the bladder, because there's urine, it's free fluid, right? It's appearing black. Similarly, if any free fluid in the intraperitoneal cavity, it would appear in the similar.
How much quantity can the ultrasound detect?
Yeah, it can. Even minimal of fluid, it can be detectable. And trace interbowel free fluid is many a times physiological. It is commonly observed. And then let's look at the IVC. Again, I'm keeping the marker towards the patient's head in the subxiphoid region sagittally.
Okay.
भैया थोड़ी गहरी सांस लेना. Yeah. So you see the IVC. Even I can Okay, it's because a little of the gas. I can keep the probe with the marker towards me. If I keep it this way, and I can see the hepatic veins entering into the IVC. So this way also you can identify the IVC. Yeah, the intrahepatic part. The probe slightly tilted towards the right. Because if you may, okay, in patient may it's not really that visible. If the probe is in the sagittal plane and if I tilt it towards the left, you will see the aorta. Again, this is the IVC. I've kept it in the right upper quadrant, and you can appreciate the hepatic veins here also. This is the IVC. Can you appreciate it? Yeah, no, that's not. That's aorta. That is IVC. Okay. For the lung, for the thoracic part, I would like to use the linear probe. What do I need to do? Okay, E-fast. Okay, and how do I need to add on to the virtual convex. Yeah. I'm just increasing. Again, the marker towards me. That's the marker. It's towards me. In the mid, nah, it's fine. That's the shimmery pleural line. Yeah. And you can see its movement. You can appreciate the lung sliding. My probe is in the mid-clavicular, along the mid-clavicular line. Yeah. Again, let's keep it on the other side and appreciate the movement.
So it would be below the white shimmery line, and then it will indicate pleural.
No, for pleural effusion, we were keeping the probes at the right upper quadrant and left upper quadrant, and we could see it above the diaphragm. Here we are looking for pneumothorax. If the lung sliding is absent, it could be suggestive of pneumothorax. Yeah, let me put on the M mode. MM. How do I put the marker on this?
So this is, if you want to put it here.
So that's the seashore sign. If there's pneumothorax, there would be stratosphere, yeah, or barcode. Any more questions? Yeah, sure. Again, right upper quadrant. The marker is towards me, right upper quadrant. You can appreciate the diaphragmatic surface. Right now, you can't see any black, the way bladder is. Can you appreciate the bladder? Completely black. If there's that kind of blackness above the diaphragmatic surface, that's indicative of fluid. Right now, if you look carefully, you're just seeing the mirror image of the liver. Can you appreciate the veins here? That's the mirroring artifact that is produced by the liver or the spleen for that matter. Because there's no free fluid. If there's free fluid, you won't see this mirroring artifact. You can take the probe a little upwards. You should see it near this side. Okay. Both near the costophrenic angle. There is no free fluid. Similarly, in the left upper quadrant. There's no fluid. Would you like to try? The marker towards your side. It's jelly there.
सबसे अच्छा इसमें चुरा लिया है मैंने पर्पल कलर घुस रहा है ना
Go a little down. You might increase the depth a little so that you can see the other end of the liver. Try to visualize the right kidney.
ये संतोष सब चाहो तो एक कोने में ही रखे रहने दो
No, Sajay, yeah.
ये बहुत important है यार
If the patient is stable, you may ask the patient to turn a little laterally if the gas is obstructing the view.
दोनों ही लेके जाने वाला है लेकिन एक रख लेंगे दोनों ही रख लेते हैं दोनों रख लेते हैं कारपेंटर वाला पैसा दे देंगे
These are retroperitoneal, no? So you've got two.
ऐसा हो रहा था पहले जैसा नहीं था देखो बेंड हो रहा है तो कुछ करके चिपकाओ सही से
Would anyone else like to try and find the kidney? Yeah, that's the kidney. Where's your probe marker? Yeah.
एल्बो पर इधर आओ ये एक हाथ में और एक हाथ में इसका मैनेजमेंट वाला ऐसे
पंडित जी वगैरह को बुला लो पंडित जी बुला लो सबको बुला लो आजा केके आजा
तुम्हारे साथ
जो भी जसवंत देखो ये सब काम हो जाएंगे ये को बुला लो और कौन कौन को भी सब लोग बुला लो चलो ये तो ठीक है बुके ये रख दो आ जाओ आप क्यों हां बुला लो
Yeah.
एक एक आदमी खुद से कर रहा है यही तो करने वाला है तुम्हारे देख पहले इनको में भी शॉर्ट करेंगे
चालू हो गया
चलिए किसको देना ये तो तुम्हारा गमला उमला ले लिया फोटो तो खिंचा लो इसको
Yeah, you can appreciate the collapsibility also. You can ask the patient to breathe in for the respiratory movements. Deep breath, yeah, you can appreciate the collapsibility. Look for the suprapubic region too. मैं वापस मैं बताऊँ
और ये सब हमारी जितनी भी फ्रैक्चर हॉस्पिटल की सब में होना चाहिए जो भी है सब पे फोटो जाना चाहिए
हाँ जी। हाँ, पूरा पेरिस्प्लीन, पेरीरीनल। थोड़ी डेप्थ कम कर लीजिए आप। थोड़ा डेप्थ कम कर लीजिए। या जूम इन अ लिटिल। या Yeah, you can appreciate even a small splenecule is there. Yeah. उसके ऊपर स्प्लीन भी है, थोड़ा सा एंगुलेट कीजिए प्रोब, स्प्लीनिक का ही पार्ट आ रहा है वो। खोलिए उसको पूरा, एंगल रोटेट करिए आपके प्रोब को थोड़ा। Yeah. Eventually, once you start doing it, खुद ही आने लगता है कि how to tilt the probe. Yeah. Yep. आपका मार्कर किधर है? Yeah.
Towards me or up? Towards the head of the patient?
It depends. Right now you're keeping the probe in the transverse plane, so the marker should be
And if it is in
sagittal towards the 12 o'clock. अदरवाइज आप मार्कर रखेंगे तो आप लेफ्ट स्क्रीन पे राइट जाएगा, वो खुद समझ या थोड़ा नीचे चाहिए और प्रेस करिए। नहीं, that's not the bladder.
फूल और बुके 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 का बुके एक बुके फोटोग्राफ के लिए छोड़ दो। तितली उड़ी, तितली उड़ी। चलो तीनों एक एक ले लेंगे, ये एक एक करके फोटोग्राफ। पहले एक तुम दो सादा से।
Now the bladder came.
इधर लेंगे बैक,
थोड़ा सा सेंटर में लाने का ट्राई।
हाँ वही ना, लास्ट के लिए रखा था।
Yeah, that's the marker.
दीप्ति ने बोला कि मुझे नहीं दिया प्रेजेंटेशन, अभी लो ये क्वेश्चन बताओ। अभी लो सर। नहीं ठीक है। सर ये रख लीजिए, आपका थैली कहाँ है? मेरा मैंने रख लिया अपना थैली। अच्छा हाँ, थैली थैली मेरे ये इधर से ले लीजिए। हाँ सर, एक फोटो ग्रुप फोटो या हाँ मैनेजमेंट टीम की ग्रुप फोटो हो जाए यार, सिर्फ मैनेजमेंट टीम की आ जाओ, ठीक है। हाँ ACCMB की और ये फोटो अपन है ना बाहर करेंगे। करेंगे
बाहर अभी पहले यहाँ की तो ले लो
अरे गमला ले लूँगा मैं एक्स्ट्रा
गमले एक्स्ट्रा
गमले बचेंगे बचेंगे कुछ अपन एक ले जाएंगे बचेंगे गमले पानी दूंगा इंडोर प्लांट है ना सर सब थोड़ा पानी तो लेगा मतलब थोड़ा दूध चाहिए एकदम इंडोर कोई नहीं
बाहर ही रख देना ना
एक दिन क्या यहीं रहने दो फिर बाद में अपन लोग डिसाइड करें क्या करना है कल तक के लिए प्रोटेक्ट 24 घंटे में 16 घंटे आ रहे हैं कल तक के लिए सब प्रोटेक्ट करना है
तुम लोगों को मैं बताता हूँ तरीका ये ऐसे बैठो तुम दोनों ऐसे बैठो
Won't need a lot of jelly now. काफी jelly लग चुका है.
हम लोग थोड़ा उस तरफ चलते हैं पीछे का
नहीं कोई दिक्कत नहीं ये दोनों आएंगे
दोनों ठीक है
सर बीच में आएंगे
Press लिखो. Now, yeah. The upper one, yeah. यूजुअली वहीं से देखते हैं कई बार गैशियस एब्डोमेन के कारण वहाँ से डिफिकल्टी होती है नहीं गो थोड़ा posteriorly yeah kidney is retroperitoneal no so you've got to yeah
तो अगर मेजर करना है तो यहाँ पे इमेज फ्रीज करके फिर कैलिपर
yeah exactly yes ऊपर spleen नीचे you can appreciate the kidney yeah though I think you're keeping the eye was above okay yeah थोड़ा नीचे
below his belt
थोड़ा प्रेस करो don't be afraid थोड़ा प्रेस करो go a little below his belt yeah the bladder is yeah exactly yeah 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 that one is preferential you can even use this probe yeah you can you might have to decrease the depth a little but zoom in zoom ज़्यादा zoom हो गया
That's it?
yeah can you appreciate the pleura moving yes in both the planes. Which region do you wish to scan first? The subxiphoid? Yeah, the marker towards you. Liver aya, yeah, the heart's coming. Give it a minute. थोड़ा gaseous भी है ना. You might have to adjust your probe a little.
Okay.
Slightly tilted, right? Yeah, the heart. थोड़ा नीचे मिड एक्सिलरी लाइन, या थोड़ा जूम इन कर लीजिए डेप्थ से. या या What do you want to see right now?
तुमने प्रोब मार्कर इधर ऊपर किया हुआ है.
The liver, that's the liver पूरा, हाँ. और किडनी वहाँ नीचे आ रही है, वो किडनी आ रही है.
लीवर पे चली गई और ऊपर है ना.
क्यों वॉलंटियर कहाँ गया? सार्थक देखना है.
ये फूड देखना है, मॉरिसन्स पाउच पे फूड देखना है. इधर प्लूरल इफ्यूजन होगा वो दिख जाएगा. दो चीजें बस इधर राइट में.
ये शाइनी
डायफ्राम चिप का लीवर के जस्ट नीचे है ना, ऐसे ही है ना. डायफ्राम और इधर लंग्स के बीच में अगर स्पेस इफ्यूजन रहेगा तो ब्लैक सेट हो जाएगा. कितने बचे हैं? आपको हो गया?
ये वायर निकाल दो.
आप करते जाओ.
अरे वो एक मिनट आ जाएगा. चलते चालू कर दिए तो एक मिनट में हो जाएगा.
बेल्ट के थोड़ा नीचे तक जाना. ब्लैडर इज नॉट दैट फिल. या हाँ जी. आइडेंटिफाई द प्रोस्टेट. या ब्लैडर के जस्ट नीचे. ये ब्लैडर, ये प्रोस्टेट आ रहा है इधर.
Those who are interested to see the live this thing, they can go for there. Transperineal ultrasound.
सब कष्ट तो
या पूरा इधर आसपास पेरिफेरी में. ऊपर लिवर आ रहा है.
मैं निकाल दूं?
हेलो 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 हेलो.
एक मिनट.
ये माइक थोड़ा उतार दो. तुम इधर आओ ना, उधर से कैसे दिखाओगे यार? इसमें थोड़ा दिखाना, स्क्रीन पे दिखाना मेरे भाई.
सर ये तो जा रहा है.
अच्छा ये जा रहा है. बस हाँ बस ठीक है.
नहीं, पेशेंट को भी थोड़ा फोकस दिखाना.
ये तो अपन वो बस
पेंट पूरा अलग कर ले बेटा, रिमूव कर ले पूरा. पेंट अंडर भी दोनों रिमूव कर लो. लेटरिन के रास्ते के ऊपर रख के जांच करेंगे, अंदर नहीं डालेंगे कुछ भी, है ना.
डू द लाइव स्ट्रीमिंग. ये भी अलग वो है ना कि कैसे कर पाओगे आप. सर्जरी में तो ठीक है, सामने आ गया, ये कर लिया, सबने देख लिया.
हाँ पूरा अलग कर लो. अंदर के फैन दोनों अंदर के अलग कर लो.
ऊपर कर ले, ढक ले बेटा उसको, ढक ले बस. ऊपर ढक, जैसे अपन सोनोग्राफी करते हैं सारे डॉक्टर लोग आके चिंता मत कर.
नहीं ये अलग कर ले, मोड़ना पड़ेगा. मैं बता रहा हूँ कैसे लेटना है आपको. दोनों पैर को ऊपर रख के लेटना है. आपका चेहरा नहीं आएगा, फेस कवर कर लो. आइडेंटिटी नहीं आएगी आपकी, भी पहचान नहीं आएगा आपका. कोई आपका ना किसी को नहीं पता चलेगा. फेस को नहीं सीधा लेटो, नहीं सीधा लेटो. मैं बता रहा हूँ ऐसे. ये ऐसे कवर कर लो, है ना. दोनों घुटनों को छाती से लगाना है आपको. ऐसे नहीं, सर को ऐसे, ऐसे सर को यूँ पकड़ रखो हाथ से, ऐसे उठा के रखो. अंदर कुछ नहीं डालूंगा. ढीला छोड़ो, ढीला छोड़ो. ऐसा पैर फैला लो. ठीक है.
आएगा थोड़ी देर से आएगा।
ज़्यादा देर तो नहीं हो गया?
ज़्यादा देर हो गया
लाइट
मेरे
तो
ख्याल
जल रही है
से।
सर।
लाइट जल रही है तो
ऑन किया कि नहीं किया?
लेकिन आ जाता है सर। वेट वेट करो 1 मिनट वेट।
मुझे टाइम लगता नहीं है वैसे।
मशीन चालू होने तक तब तक आप सीधा
हाँ, नीचे कर लो बेटा, सीधा कर लो।
कवर कर दीजिए।
उसको लगाया उसको तो नहीं है?
एक बार बंद करके फिर से चालू कर दीजिए। हाँ बंद करिए। छोड़ छोड़ छोड़। नहीं पावर ऑफ कर दीजिए।
भाई वो गर्दन तिरछे हो गई, उसको हटा।
बंद हो गया?
नहीं नहीं, मुझे लगता है HDMI पोर्ट लगाया उसकी वजह से चला गया।
किसके?
HDMI पोर्ट लगाया ना उसमें पहले। क्लिक तो किया, हाँ चालू हो रहा है, अब हो रहा है चालू। एक बार चालू हो जाए तो फिर भरे लगाना।
तुम सुबह जाओगे ना, एक तो अपनी प्रोब भी ले जाना साथ में।
नहीं ये नहीं का प्रोब, ये कंपनी वाली है।
और दूसरा जो फिट ले जाना।
हाँ ठीक है, वो रखा है, मिल गया। आप कैमरा, हाँ कैमरा का थोड़ा जगह दे दो, लाइव रहेगा।
कल कौन आया था परसों? नेक्स्ट वाले ने दिया है करने, उन्होंने बोला है ऐसे कभी भी नहीं देखा हमने ऑनलाइन, वो रुका ही नहीं, कहीं भी उनको वो नहीं हुआ। अब तो इतना अच्छा हुआ सर। ये कल परसों किसी ने प्रोग्राम किया था ना सर, ये बदल के ले गया।
अब साइड डाउन कर लो।
ये स्लाइड सेंटर ये अप्लाई तो है।
This is transvaginal probe, and this is the convex probe, and this is the linear probe. What I am doing, I am
डिस्टार्टेड तो आगे होता है, उसमें आगे नहीं है। बोल तो उससे चालू करे तो तुम्हें चालू करना, जैसे तुम्हें बोलना।
So-
उससे चालू हो गया क्या? वहाँ पे एक बार चेक कर लो, फिर चालू कर लो, फिर बार-बार रिपीट नहीं होगा।
उसमें क्या मैंने पेन चला
देखो बंद नहीं होना चाहिए।
नहीं उसको चला के ही दिया उसके सामने
लग गया?
ताकि चेंज नहीं सर, उसको बोल दीजिएगा सर, आएगा तो बोल दीजिएगा।
उसको बुला लेते हैं।
मैं तो इसी में से दिखा दूंगा वीडियो के साथ। चला गया? नहीं आ गया, आ गया।
आगे क्या देखना, एक मिनट ये केबल देख लेंगे, एक मिनट
आ गया।
सुमित एक मिनट देखो, उन्हीं बताओ।
नहीं पैनल सर मॉनिटर आ गया है।
हेलो आया?
नहीं है?
आ गया? ठीक है, डन डन है। सर माइक में बोलिए।
हेलो, ऑडियो am I audible?
यस ऑडिबल भी है, बोलो सुन भी रहे, तो आवाज भी आ रही है।
अब नहीं लगा। अब
Right. Start. Am I audible?
यस सर, आवाज भी आ रही है।
Okay. Now first these are the three transducers: transvaginal probe, this is convex probe, and this is the linear probe. We just apply the copious amount of ultrasound jelly over the probe, and now I am covering my probe with simple hand gloves and making it folding like this, so that it should not move much. Tying a knot, small knot here. So this is the patient, volunteer patient. First we are giving in the lithotomy position. ये हाथ पकड़ना भैया, दोनों हाथ को ऐसे, दोनों घुटनों को नीचे रखो, and we are, this is the pubic symphysis. I am applying the again applying the jelly over here, and just simply keeping my probe over the symphysis pubis. I am just now doing the transverse scan. I am putting my probe here. This you can see the symphysis pubis here. This orientation, we have to check the orientation of my probe. This is the probe orientation. I am checking my probe orientation first. Okay. Like this. This is the corresponding. If you keep your finger here, you can see the impression over the ultrasound images. It corresponds to the ultrasound marker which has been given here. I am placing my probe here, the probe at this point. So whatever I am examining is towards the side of my probe. This is okay. Now I am keeping my transducer over symphysis pubis, and gradually I am sweeping my probe posteriorly, and here you can see the gain bada. I have increased my gain because I am not able to see my structure. So I increase the gain. Now you can see here, iska marker bata na, arrow. Here you can see the internal anal sphincter. Inside is the normal anal mucosa. This is the intersphincteric space, and this is the external anal sphincter. Now what I am doing, I am just swiping my transducer posteriorly, and I am covering the whole length of anal canal. I am just swiping my transducer posteriorly. I am not going towards the anal opening. I am just swiping my transducer in the anterior posterior direction. You can see the anal canal very well. It is very well demonstrated on this thing. This is the intersphincteric space. This is the internal anal sphincter, anal verge. This is the external anal sphincter. Just swipe it posteriorly, and till the end you find the end part of the anal canal. The whole length of anal canal has been covered in the transverse scan. This is the whole about the transverse anatomy. Now I am just rotating my transducer 90 degree, and I am now in the sagittal plane. Now I am in the sagittal plane. Okay. This is the sagittal plane. Now I am focusing my transducer posteriorly so that I can see the anal canal. This is the anal canal. You can see the anal canal, external anal sphincter, internal anal sphincter, external sphincter, intersphincteric space in between. Here this is the intersphincteric space, and now I am swiping my transducer from the right to left and again left to right. This is in the sagittal plane, and third plane is in the coronal plane. I just removed my transducer from the particular place. I am just keeping at the level of anal verge. अंदर नहीं डालेंगे, हल्का सा रखिएगा, ठीक है? See, this is in the anal verge. This is coronal plane. This is the whole length of the anal canal from here up to here. This is the internal anal sphincter. This is the intersphincteric space. This is external anal sphincter in the coronal plane. See, whole length of the anal canal is seen. No, supralevator इधर नहीं आएगा, because our transducer is here. This is the entry point. This is the anal verge, and this is the superior aspect. This is the superior aspect. Towards our transducer is inferior part, and above this is the superior aspect. So this is the area of the topmost end of the anal canal. Here you can see this is the fibers of the supralevator muscle, levator ani. It is going up. In the oblique plane, what we'll do, we just found out where the exactly fistula is, and just do the different direction. In the different direction, we analyze as a whole. Okay. So this is all about the normal scanning technique of this. This I had done with the transvaginal probe. Another is that high frequency probe or the linear.
So, Dr. Sumit, you have demonstrated 4 ways to do this. First is axial view or transverse view. So for that we have to keep this transducer. Preferably if you are having the vaginal probe, because it will give you a short print.
Yes,
so you can understand better the sphincteric complex. To assess the sphincteric complex, one has to place the probe over the pubic symphysis, focusing on the urinary bladder, so you can assess the sphincter complex. And we have to rotate it in the form of anterior posterior divergence. That is called that procedure Dr. Santosh Bhaskar was telling us.
Right, rocking movement.
And side to side
rocking
is called tilting. For that, Jyoti, after that you rotated the entire probe 90 degree, so that will give you the sagittal view, sagittal or long axis view. So in long axis view, you can assess the extent of the fistula tract.
Yeah, right.
After that, third, you come to the at the opening of the anal word, where you place the probe, and it was in the anterior posterior direction. So that was the coronal view. So coronal view say we can get the anterior posterior.
Yes.
Anterior posterior assessment of the anal
Anal
canal.
canal.
And oblique view. Sometimes you
So
require
earlier
oblique view.
oblique, depend upon the track of the fistula. We have to follow the fistula track. So now I am using the high frequency transducer for superficial stress. I will show how it looks like. This is the normal high frequency footprint. ऊपर उठाना भी है, फिर से ऐसे रखना भी. Not for pudendal block. I'm just showing the anal canal. Pudendal I will also demonstrate. Here again we have to adjust the gain. See, I'm not saying anything now. Increasing the gain. Again my footprint is opposite, so that I'm changing my direction of probe. This is the marker. I'm applying my finger here. You can see over the screen. Just towards this marker and this marker should coincide with each other. This is on the ultrasound, not on echo. Echo is a little opposite.
Basically, this is the right side. And
Yeah.
echo, it is on the opposite
Opposite side.
For other visceral examination.
Now you can see this is the anal canal. This is the anal canal, and
But
in
here the picture is not very good. Huh?
it will not come good, sir, because here you can see, now you can see the axial anatomy of the anal. See, because it's a thin built patient, even I am using the high frequency probe, I am still getting the very good quality image. You can see it here. This is an axial anatomy. You can see the image quality. This external sphincter you are not able to see in the previous probe. This.
Focusing should be towards the urinary bladder.
No, start with towards the anal canal. It is focusing towards the anal canal posteriorly, because anal canal is lying posterior to symphysis pubis. Anterior symphysis urinary bladder.
Now your movement will
Yeah,
be
like this. Anterior posterior, like this.
Anterior posterior.
Anterior posterior direction.
So this is your anterior posterior.
Anterior posterior direction. This is the posterior most direction towards the anal canal. And now if you're swiping, you're cutting whole of the anal canal. This is the whole of the anal canal. Yeah, you can see the external sphincter very well in the using high frequency probe. Intersphincteric space and it's the intersphincter, the whole anatomy. Now again at 90 degree, if I'm going to a 90 degree rotation, you will find the sagittal image of the scan. Here I will not able to, even after full gain compensation, I am not able to focus it. Now I will alter the frequency by using penetration mode. You should know about this thing. Now this is the sagittal plane. You can see whole length of anal canal. Everyone should appreciate it. This is the whole of the anal canal. This is the sagittal plane. I am swiping my transducer from right to left and again left to right. Okay. That is the coronal plane. It's so difficult. Okay, now. Yeah. This is the coronal plane. Just applying our transducer coronal to the
You have
body
placed
plane.
your ultrasound probe over the
Anal verge.
Now you will do the anterior posterior movement.
Swipe, yeah, like this.
This is the anterior
Coronal
posterior
plane.
movement to see the images in coronal view.
Coronal view. Right, sir.
The center of the probe is in the center of the anal.
Verge. Anal verge. Okay. Pointer importance is only that his ultrasound pointer and this image pointer should coincide with each other. How will you confirm it? Just applying a finger here and see where your finger imprints are coming. You can see here. Abhi kuch nahi dikha. This is kuch nahi hai. It will blind. Once I am placing my finger is coinciding with this. Now I will what I will do? I will do like this. See, this is the marker here. This is the marker here. This is the marker in the image. You just see this marker should coincide with each other, so that the orientation of your probe will be proper, right, left, or left, right. Whatever is coming on this side in the patient towards the right hand side of the patient, and whatever I am seeing on the opposite side towards the left hand of the patient, on 9 o'clock or 3 o'clock position. Okay, fine.
Now about the pudendal now.
About the pudendal now, yeah. This is is a penetration view. Here is the penetration with around the 4 megahertz. Because if I put in 12 megahertz, you will not find anything because it is very superficial. Okay. Now then the pudendal now, you first have to see the ischial tuberosity. You should palpate ischial tuberosity. This is the ischial tuberosity. You just keep your transducer parallel to the ischial tuberosity. This is the ischial tuberosity. This convex thing is the ischial tuberosity, and this above thing is this thing is the sacrotuberous ligament. Okay, and in between is there this is the pudendal now. You can see the bright effect. Hyperechoic thing is the pudendal now. Okay.
हाँ हाँ ये
sagittal plane बताना है.
in the same
इसी प्रोसेस बताना है.
क्या बताना
sagittal plane.
हाँ फिर से
Same
एक बार
process.
इसके बाद डॉक्टर के ठाकुर will demonstrate how to visualize the hypogastric.
Just keep your probe here at the level anterior to the anal canal. Just focus is just angle your probe posteriorly. Don't keep it straight. Whatever you wanted to see, focus toward that side. You want to see anal canal, you have to tilt your probe posteriorly. See, now I have tilted my probe posteriorly. Now you can see the anal canal, sagittal view. This is the anal canal. You can see the air echoes. This hyper thing, air echoes, and these are the air echoes. Okay, these are the anal wall. This is the internal anal sphincter. This is the external anal sphincter. This is the intersphincteric space. Okay. ठीक है भाई, थोड़ा relax करो थोड़ा सा, है ना? ठीक है? Even without giving this position, we can examine the patient.
If you start doing practice, 5-7 scan कर लोगे, then you'll come
Yes,
to know.
you need to practice and focus your hand, because in such position it is not easy like abdominal ultrasound. You have to handle it very. This thing the patients will not be in discomfort, and you have to practice a lot for the transperineal ultrasound. It's not easy. You just putting on abdominal ultrasound doing like this, because in such position you have to scan fast, because patient can hold for maximum 5-7 minutes, not more than that.
Hypogastric.
And I think we should all clap for volunteer.
Yes,
Really very
thank you.
thankful.
Thank you, Bhaiya.
Take the mic. Dr. K.
Yes.
Take the mic. And Dr. K. Thakur is going to demonstrate. Right now you have seen how to localize the pudendal nerve. Now following the ischial tuberosity, ischial sprite, and then both the ligaments, and between these two ligaments, pudendal nerve is there. Hypoechoic shadow is pudendal. Now he is going to demonstrate the hypogastric.
So in our discussion today, we have probe change करना रहेगा. कहाँ से होगा? Sir. Okay, transition. You always confirm if you have a confusion which either I have selected right probe or not, you can always confirm with the footprint also. Curvilinear footprint is here, curvilinear probe I have selected. And then there is this marker, you can always confirm marker, it is on this left side. So this is this side of the probe, okay, this marker, okay. Yes, this is on the right side, okay. Now, as we have already discussed in the lecture, that for superior hypogastric plexus block, patient has to be in supine position. And preferably head low, because bowel comes in between. Anatomical landmark which I have explained is umbilicus, which is at the level of L2, L3, and then there is pubic symphysis. So we start our scanning from level of umbilicus, as you can appreciate here, and then we slide down, down, down. There is bladder. So above this is where we have to scan. थोड़ा सा मैं depth बढ़ा लेता हूँ. Depth बढ़ाइए. Second, let me just scan. थोड़ा सा obese patient, that one limitation is in the obese patient, but yes, here we can appreciate.
Now you are trying to localize the vertical.
Yes.
First of all, in hypogastric now, try to localize the, because in all this now conduction study, we have to follow the bony landmark.
Bony landmark. So this is L5 vertebra. अब Doppler color डाल दीजिए. थोड़ा सा बड़ा बस बहुत yes. Can you appreciate both iliac vessels here?
Yes. No.
Okay, very simple to acquire the image, and then what we do is we go in plane. From this side we give some local, and then we insert our needle, so that our needle is inserted from this plane, and we can see the needle track going there and hitting the vertebra, and then we withdraw a little, and then inject our.
So, at how much distance from the vertebra body? Suppose you have touched the needle.
1 to 2 mm, sir. 1 to 2 mm. It is up. The plexus is on body only. सर
तो पेरियोस्टियम में ना जाए इसलिए
इसलिए थोड़ा सा विड्रॉ करना है, यस, एंड अवॉइड करना है वेस्कुलर, एंड मोर टुवर्ड्स द लेफ्ट साइड,
अराउंड ये रीजन पे आ जाएगा ना।
हाँ यहाँ पे, यस यस।
So this is on the right side and same procedure has to be repeated on the left side.
नहीं सर, प्लेक
Ultrasound anterior approach. One needle is enough because we are depositing the drug
अच्छा।
on the anterior aspect.
वो इसमें स्प्रेड करेगी।
It will spread spontaneously.
Increasing the volume will cover both.
So how much anesthetic?
For diagnostic block, as we have mentioned, 10 to 15 ml or 0.25% bupivacaine. It will give you the immediate response on table only. You can ask patient कि आपको कितना आराम लग गया, and they will tell you that I have got 50-60% relief. Diagnostic block is successful. Now for definitive block, you can refer to pain physician for further management. So as a surgeon, you can always, like pelvic pain है, समझ में नहीं आ रहा, बहुत दिन से परेशान है patient, and you are suspecting some of these kind of pathologies. So you can always do this block and then find out whether this is the cause of the pain.
And what pain management physician they do for?
हेलो 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 हेलो।
बंद क्यों हो गया था ऑटोमेटिक? तेल तो नहीं गए थे इसके? वो बंद करके चालू किया तो हुआ है। मगर ये देखिए जा रही है बैटरी चेंज। बंद होगा ना तो फिर नाटक होगा। दूसरा वाला बना दिया लास्ट वाला।
हेलो चेक चेक हेलो हेलो चेक।
हेवन में एक जगह और चलना है निकाल में तो चलेंगे ना अगर तो निपटा दे पहले। चलो 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 चालू है बोलो चालू हाँ बोलो 1 मिनट।
हेलो हेलो चेक चेक।
यूट्यूब का
नहीं अभी बंद कर।
हेलो
बोले जिनका हो गया बोले इधर आ जाओ। स्टार्ट करना तो बताना है ना लाइव में। तो यहाँ से आना चाहिए इधर से बस।
बढ़िया मेरी कल
हो गया सर, दे देना। ले लिया क्या ले लिया? हो जाएगा 500 एकड़ सर, टेंशन नहीं हो जाएगा। स्टेबल भी है बट कार्डियक में है, आपको असेस करना है कि कार्डियक फंक्शन कैसा है, फ्लो स्टेटस कैसा है, ठीक है ना। तो एक असेसमेंट के लिए है ना, आपको आईवीसी देखना है, एक कॉन्ट्रैक्ट टीएलवी कॉन्ट्रैक्शंस कैसे हैं, एलवी फंक्शन कैसा है, तो एक ग्रॉस असेसमेंट एक सर्जन कर सकता है। तो सबसे पहले इसके लिए मैंने बताया था आपको बेसिकली 5 विंडोज़ देखनी है, बेसिकली सुपर स्टैंडर्ड नहीं भी देखें तो 4 एटलीस्ट। इसमें सबसे इम्पोर्टेंट पैरा स्टैंडर्ड लॉन्ग एक्सिस, parasternal short axis, then subcostal and apical focal chamber view, and then suprasternal कर सकते हैं। तो थर्ड टू लेफ्ट पैरास्टर्नल, ठीक है। तो निप्पल किस लेवल पे रहता है, जल्दी यहाँ पे अंदाज याद रखने में है ना। हाँ 4th 5th में, ठीक है ना। तो इधर 5th 6th इंटरकॉस्टल स्पेस के लगभग आप ऐसा करेंगे। मार्कर का किधर है, टूवर्ड्स द, दिस इज द लेफ्ट राइट शोल्डर। टूवर्ड्स कहाँ रहेगा, टूवर्ड्स द राइट शोल्डर। आप देखा 4th, ये 5th 6th इंटर, आपको जरूरी नहीं कि आप थोड़ा सा स्लाइडिंग कर सकते हैं, है ना। तो स्लाइड करके आप इसमें आप यू कैन क्रिएट अ गुड विंडो। आपको कैसे पता चलेगा कि इसमें लॉन्ग एक्सिस है, आपको ये सबसे मेन इंपॉर्टेंट इसमें क्या है, दिस इज अ लेफ्ट वेंट्रिकल, दिस इज अ लेफ्ट एट्रियम, इसके बीच ये दिस इज अ माइट्रल वॉल, ठीक है। नहीं राइट नहीं, लेफ्ट 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 लेफ्ट, हाँ। पैरास्टर्नल लॉन्ग एक्सिस में ये मार्कर इधर क्या है इसमें, जैसे देखेंगे पेशेंट के ये इधर ये राइट है। ये सबसे इंपॉर्टेंट क्या है, मार्क आइडेंटिफाई, ये किधर है, ये राइट। तो मार्कर क्या है इसमें, ये है, तो इसका मतलब ये कौन सा है, राइट है। समझ गया ना। तो मार्कर से आइडेंटिफाई, अगर मैं इसको उल्टा कर दूंगा तो उल्टा विंडो बनेगी, तो इधर हो जाएगा, इधर हो जाएगा, लेफ्ट इधर हो जाएगा, राइट। बट अपन जो हाँ आ जाएंगे, ठीक है। तो दिस इज अ मार्कर, इधर हमारे किधर साइड है, राइट साइड, राइट शोल्डर की तरफ। तो ये हो गया राइट, तो ये हो गया राइट वेंट्रिकल, लेफ्ट वेंट्रिकल, लेफ्ट एट्रियम, और ये इधर राइट वेंट्रिकल के इधर ये, तो ये एओर्टा दिखेगा। हाँ
कार्डियक प्रॉब्लम
उल्टा, हाँ नहीं कार्डियक में सब में ऐसे ही बनेगा, उल्टा नहीं बनेगा। मार्कर से आइडेंटिफिकेशन करेंगे इसका, ठीक है। अब मार्कर किधर पर, बट नॉर्मली जो मार्कर है हमको राइट शोल्डर की तरफ रखना है, तो हमको जो विंडो मिलेगी दैट इज मिलेगी इधर ये लेफ्ट वेंट्रिकल की, लेफ्ट वेंट्रिकल, लेफ्ट एट्रियम, और दिस इज अ एओर्टिक वाल्व। ये एओर्टिक एओर्टा है, एओर्टा असेंडिंग एओर्टा है ना, हम बस थोड़ा सा असेंडिंग एओर्टा का पार्ट देख पाएंगे बस, दैट इज एओर्टिक आउटलेट। ठीक है, तो ये बना लिया आप। तो दिस इज अ लॉन्ग, दिस इज अ पैरा एक्सटर्नल लॉन्ग एक्सिस व्यू। कॉन्ट्रैक्टिलिटी देखना है आपको, कैसा लग रहा है आपको बताइए, वेंट्रिकल ठीक है ना।
तो इसमें कैसे
विजुअल असेसमेंट,
मतलब कितना कॉन्ट्रैक्टिलिटी
वो आपको आता है उसके विजुअल आई बॉलिंग असेसमेंट। जैसे आप बहुत सारे देख लेंगे, व्हाट इज़ नॉर्मल, व्हाट इज़ एबनॉर्मल 22, तो उसके बीच का कैसा है 30 40 40 to 50 है ना, या से अदरवाइज एक सिम्पसन्स मेथड है, फिर 4 चैम्बर में एरिया, तो वो उसमें आप सर्जन्स के एक्सपर्टाइज होना पड़ेगा उसके लिए। ठीक है, देखिए ये है कि आप एक बेसिक यू हैव रफ आइडिया है ना टू वेलुएट द इजेक्शन फ्रैक्शन। तो अभी आपको लग रहा है ये लगभग ये हाँ जरा सा नहीं कर रहा है, ये देखो पूरा वॉल देखिए ना इसकी, ये अंदर इंडोमेट अंदर दिख रहा है इसमें, ये इंडोकार्डियम वाला है ना। क्वांटिटी देखो एक पॉजमेट ऐसा है भाई, ये लगभग ये 50 to 60% 60% अराउंड आ रहा है, 50 क्वांटिटी इज गुड। आपको विंडो पूरी बनानी है अच्छे से, ये दिख रहा है। इसको घुमाएंगे किधर, देखिए
शॉर्ट एक्सिस
टुवर्ड्स द लेफ्ट शोल्डर। आपको सीधे इसे इसमें दिखे लेफ्ट वेंट्रिकल वॉल,
ये लेफ्ट वेंट्रिकल,
ठीक है। हाँ, ये लेटरल वॉल होती है, इंटीरियर वॉल होती है, इन्फीरियर होती है, बेशल होता है, ठीक है ना। तो मतलब आपको मतलब वो डिटेलिंग है, इस नहीं क्या इन्फीरियर वॉल है माई इंटीरियर, डिपेंडिंग ऑन द विच एरिया इज इन्वॉल्व। बट आपको असेसमेंट करना है कॉन्ट्रैक्टिलिटी, आपको क्या लग रहा है हैविंग गुड कॉन्ट्रैक्शन।
ये क्या है सर,
ये मैट्रल, हाँ हाँ नहीं, ये है एट द लेवल ऑफ मैट्रल वॉल। ये अब डिटेल में नहीं जा रही है, इसमें फिर 3 विंडो है, शॉर्ट एक्सिस एट द लेवल ऑफ मैट्रल वॉल, ठीक है, एट द पेपलरी लेवल पे है, एओर्टिक लेवल पे है ना। तो बट ये पेपलरी लेवल पे जो दिख रहे हैं, दीज आर 2 पेपलरी मसल्स हैं, जिसमें से बाइकस्पिड वॉल है ना, ऑडी टेंडन से अटैच रहता है, ठीक है ना। अब आप कॉन्ट्रैक्टिलिटी देखिए बस, कैसा है ये हैविंग गुड कॉन्ट्रैक्ट, कितना लग रहा है आपको, मोर देन 60% अराउंड। जब आप देख लेंगे ना, आप कम से कम आप जाके कम एटलीस्ट आपको 20 to 30 पेशेंट्स करने हैं, और रिड्यूस्ड इजेक्शन फ्रैक्शन वाले भी देखने हैं शॉक के लिए। तो दिस इज अ शॉर्ट एक्सिस व्यू, ठीक। सब कोस्टल व्यू में
इजेक्शन फ्रैक्शन कौन से व्यू में, लॉन्ग एक्सिस शॉर्ट एक्सिस?
इजेक्शन फ्रैक्शन मतलब लॉन्ग एक्सिस व्यू में, शॉर्ट एक्सिस व्यू में भी दोनों में आइडेंटिफाई पर, और एपाइकल 4 चैम्बर में भी। मोस्ट कॉमन देखना है तो सबसे पहले बस सीधी एसी से असेसमेंट, पेरिस्टेनल लॉन्ग एक्सिस से आपको एक असेसमेंट लग जाएगा, और कन्फर्मेटरी होना है और बेटर तो देन शॉर्ट एक्सिस एंड पैराकोस्टल में पॉइंटर टुवर्ड्स द हार्ट और लेफ्ट हाइपोकॉन्ड्रियल रीजन की तरफ, ठीक है, सिंपल है, टुवर्ड द हार्ट एंड लेफ्ट।
फास्ट के लिए जैसे पहले रखते हैं,
हाँ बस वही है। तो बट दिस इज ए बेटर प्रोब, उसमें क्या करते थे अपन, कॉन्वेक्स से प्रोब से किया था उसमें, है ना। तो उसमें एक रफ आइडिया उसमें, बट और बेटर विजुअलाइजेशन करना, ठीक है ना। दिस इज ए कार्डियक प्रोब बिकॉज इट इज ए लो फ्रिक्वेंसी प्रोब है, ठीक है। तो इसमें क्या स्ट्रक्चर्स बताएंगे, दिस इज ए वेरी गुड, लेफ्ट एट्रियम वेंट्रिकल राइट एट्रियम, डायलेटेशन है तो दिख जाएगा इसमें, बेटर 4 चैम्बर में दिखेगा, बट इससे आप हाँ हाँ बिल्कुल 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 जल्दी बार आ रहा है। हाँ हाँ, इसी में थोड़ा सा आप एंगल टिल्ट करें इधर, तो ये दिस इज ये दिखा आपको, ये क्या है राइट एट्रियम, ये ड्रेन कर रही है, ये क्या है ये हेपेटिक। तो इससे आप कंफर्म हो जाएंगे, ठीक है ना, कि एट्रियम ये हेपेटिक वेन ड्रेनिंग टू द आईवीसी, तो इसका मतलब आईवीसी, ठीक है। तो आप एंगल देखिए किधर है इसका, टुवर्ड्स द हार्ट, थोड़ा सा मैनिपुलेट कर सकते हैं बाय थोड़ा सा रोटेशन, स्लाइडिंग, कंप्रेशन, है ना इसमें। तो और मेजर करने के लिए थोड़ा सा फ्लेक्सिबिलिटी है, फ्रीज करेंगे आप, ठीक है। ठीक है, फ्रीज किया। अब स्लाइड भी कर सकते हैं, बेटर कहाँ दिख रहा है, ठीक है ना, ये वाला है ना, इधर ही बेटर है। हिपैटिक वेन जहाँ ड्रेन है उसके लगभग 1 सेंटीमीटर बाहर की तरफ। हाँ नहीं नहीं, ऑटो आईवीसी नहीं करिए, हटाइए उसको, विंडो गड़बड़ हो गया, ठीक है, फिर से दो। चलिए, मैं तो अभी इको विंडो पे था, आईवीसी पे आ गया, आपने बीच में बोला, ठीक है, खैर कोई बात नहीं। जेली दीजिए, कितने लोग हैं वहाँ? ठीक है ना, ठीक है, ग्राफाइड है ये, यहाँ ड्रेन करिए, इससे थोड़ा सा 1 सेंटीमीटर राउंड, जहाँ आपको मैक्सिमम डायमीटर है ना, मैक्सिमम मिनिमम डायमीटर ले सकते हैं, मैक्सिमम कैलिपर, नहीं डायरेक्ट मेजर है ना, यहाँ हैंड क्लिक किया, ये डाउन ये किया, लगभग 1.2 सेंटीमीटर या कितना होता है, 1.2 to 2.1 सेंटीमीटर, 12 mm से लेके 21 mm कम है। या तो आप इंस्पिरेटरी कोलैप्स देते हैं, इंस्पिरेटरी कोलैप्स से पूरा कोलैप्स हो रहा है, अगर फिर अगेन फ्रीज हटा देंगे, फिर से विंडो है, इसमें पूरा 100 कोलैप्स नहीं है, ठीक है। इसमें जैसा कि वीडियो में मैंने दिखाया था, उसमें पूरा कोलैप्स कर, ठीक है। तो ये हो गया इन्फीरियर वेना फॉर हाइपोवॉल्यूमिक शॉक के लिए ये, और ठीक है। तो एक विंडो, 3 विंडो हो गए। तो सुपरास्टेंडल पॉइंटर टुवर्ड्स द लेफ्ट ईयर एट द सुपरास्टेंडल नॉच, ताकि रफ आइडिया लगेगा आपको। बस इतना ही है इसमें, बस ये असेंडिंग एओर्टा, आर्च ऑफ एओर्टा, दिस इज ये डिसेंडिंग एओर्टा। इसमें से आपको ये लेफ्ट कॉमन कैरोटिड, लेफ्ट सबक्लेवियन, इधर है ब्रेकियोसेफेली, ठीक है ना। बट हाँ, एओर्टिक डिसेक्शन होगा तो कोई डिसेक्टिंग ये है ना, हाँ, तो ये डिसेक्शन फ्लैप रहेगा, ब्लड इन बिटवीन द इंटीमा आपको देखेगा, है ना। तो आप वो वीडियोस और देख सकते हैं, बहुत ही रेयर कम पेशेंट एओर्टिक डिसेक्शन का देखने का, ये सब दिख रहा है। दिस इज अ गुड विंडो, है ना। लेफ्ट कॉमन कैरोटिड, लेफ्ट कॉमन कैरोटिड, लेफ्ट सबक्लेवियन, असेंडिंग एओर्टा, आर्च ऑफ एओर्टा, डिसेंडिंग एओर्टा, ओके। तो दिस इज द सेक्शन। तो आपको व्यूज इंपॉर्टेंट है, स्ट्रक्चर्स इंपॉर्टेंट है, ठीक है। और आप क्या देख लिया, आईवीसी देख लिया, ठीक है। हाँ, पॉइंटेड टुवर्ड्स द हार्ट रखना, हाँ ऊपर। फिर थोड़ा सा आप
ये आईवीसी
टिल्ट, हाँ आईवीसी के लिए टिल्ट कर सकते हैं। ये देखिए, हाँ अब मेरा एंगल किधर देखिए,
ऊपर की
टुवर्ड हार्ट, लेफ्ट एट्रियम की तरफ। अब आप इमेजिन करें हार्ट कैसा होगा, इधर होगा एलवी, होगा इधर, होगा एलए इधर, होगा आरवी इधर, होगा आर। तो टुवर्ड्स आपको कहाँ किधर एक तरफ पे करना, आरए की तरफ, ठीक है ना। अब इमेजिन दिशा, ये बहुत अच्छा दिख रहा है इंस्पिरेशन में।
लेकिन सर इतना ज़्यादा डायलेटेड है नहीं आईवीसी।
नहीं डायलेटेड नहीं, फ्लूइड ओवरलोड डायलेटेड मिले, कोलैप्सिबल मिले, कोलैप्सिबल भी नहीं कि पूरे इंस्पिरेशन में पूरा कोलैप्स कर रही हो, ठीक है। मोर देन 50% है, लेकिन एकदम से दो, ठीक है। दैट इज आप मिलते ही कार्डियोजेनिक के लिए एलवी फंक्शंस हो गया, ऑब्स्ट्रक्टिव के लिए आपको इसमें फ्यूजन दिख जाए, सारा हार्ट है, पेरिकार्डियल फ्यूजन देखने के लिए सबकोस्टल व्यू विंडो, लीवर इधर, ठीक है ना। ये पूरा आपको फ्लूइड पूरा दिखाई देगा इसमें। तो ये नॉर्मल, तो आप नॉर्मल देखेंगे तब आपको अब नॉर्मल समझ में आएगा, ठीक है। ये हो सकता है, कुछ है नहीं, लीवर आ रहा है इंटैक्ट है। ये फ्यूजन में और पूरा ये दोनों सेपरेट करेंगे, इधर ये फ्यूजन, ये पूरा फ्लूइड, ये पूरा पोर्शन क्या दिखेगा, पूरा ब्लैक, बिकॉज ऑफ ब्लैक। ये तो पेरिकार्डियल फ्यूजन के सबकोस्टल विंडो इज गुड फॉर आइडेंटिफिकेशन, इजेक्शन फ्रैक्शन, क्विक असेसमेंट, इजेक्शन फ्रैक्शन, लॉन्ग एक्से एंड अब फाइनल है दैट इज शॉर्ट, क्या है एपाइकल, एपाइकल में मतलब 4th to 5th इंटरकॉस्टल स्पेस, एंगल टुवर्ड द लेफ्ट हाइपोकॉन्ड्रियम, ठीक है। इसके लिए बेस्ट पोजीशन फॉर द पैरास्टर्नल शॉर्ट लॉन्ग एक्सीजन एंड एपाइकल इज लेफ्ट लेटरल डिविकोटल। ये है, हाथ एक ऊपर करेंगे थोड़ा सा, ये पूरा टिल्ट नहीं करना, ये हाथ ऐसे ऊपर कर, ठीक है। एपाइकल 4 चैम्बर, ठीक है, दिख गया। देखिए एपेक्स देखेंगे तो टुवर्ड द लेफ्ट हाइपोकॉन्ड्रियल लेफ्ट साइड है एपेक्स, ठीक है ना। लगभग निप्पल के नीचे लगभग 5th इंटरकॉस्टल स्पेस के अराउंड है, ठीक है ना मार्कर। दिस इज द LV LA RV RA डायलेटेड। देखिए अभी 1:1 रेशियो लगभग लग रहा है। तो पल्मोनरी एम्बोलिज्म में क्या बताया था, जैसे डायलेटेशन है इसका डायमीटर, जैसे आप
कितनी देर में डायलेट हो जाता है? एम्बोलिज्म सपोज अभी हम सस्पेक्ट कर रहे हैं, तो कितनी देर में डायलेट हो जाता है?
नहीं, एक्यूटली डायलेटेशन मिलेगा। हाँ, एक्यूट डायलेटेशन, हाँ, क्रोनिक डायलेटेशन मिलेगा इन केस आप क्रोनिक पल्मोनरी हाइपरटेंशन है ना। तो लेकिन इसमें एक्यूटली है तो क्रोनिक पल्मोनरी हाइपरटेंशन लेस देन 60 रहेगा। तो ये मैकेनस है, इसमें इसकी हाइपोकाइनेजी, ये वॉल की हाइपोकाइनेजी अभी गुड कॉन्ट्रेक्टाइल है, मैकेनस है। और एपाइकल इज गुड कॉन्ट्रेक्शन मिलेगा, दैट इज मैकेनल साइन जो बताया था पल्मोनरी एम्बोलिज्म में। एंड डायलेटेशन ऑफ साइज देखिए ऐसा होगा, आरवी का साइज थोड़ा सा ऐसा होगा, डायलेटेड RA एंड RV इसमें मिल सकते हैं, ठीक है। क्लिनिकल्स मिलते बिल्कुल से, ये सब देखे हुए हैं।
दे देते हैं, ठीक हो जाते हैं।
नहीं, क्लेक्सेन देना है, फिर मैकेनिकल प्रोसीजर्स कुछ करने हैं, थ्राम्बेक्टोमी करनी है, डिपेंडिंग ऑन द मेन ट्रंक में है। हीमोडायनामिकल अगर अनस्टेबल हो गया पेशेंट तो यू हैव द आपको ब्रांच वेसल्स में है पेशेंट, हीमोडायनामिक स्टेबल है, BP फॉर हाइपोटेंशन नहीं है, तो यू कैन गो फॉर एंटीकोगुलेशन ट्रीटमेंट। तो डिपेंड ऑन द पेशेंट साइट ऑफ थ्रॉम्बस, ठीक है। तो इससे असेसमेंट भी देखिए, इधर LV का भी इसमें भी कर सकते हैं ना, इंजेक्शन फ्रैक्शन का। टेम्पोनार्ड देखना हो इसमें इफ्यूजन, यहाँ भी पूरा फ्रूट ब्लैक आपको दिखेगा, ठीक है। इसमें अभी इफ्यूजन नहीं है तो दिस इज नॉर्मल हार्ट। इसमें भी अलग रहते हैं, जैसे ये 5 चैम्बर भी हो गया रोटी में, तो 5 चैम्बर 2 चैम्बर, ठीक है, तो डिपेंड। अभी आपको बस बेसिकली कंसंट्रेट ऑन द 4 चैम्बर। चलिए आप पहले सारे व्यू, ठीक है। इसमें लेफ्ट लेटरल में ही आपको लॉन्ग एक्सिस, शॉर्ट एक्सिस, एपाइकल 4 चैम्बर एंड सबकॉस्टल। इसके बाद एपाइकल पहले लॉन्ग एक्सिस क्या करिए, पहले लॉन्ग एक्सिस बनाए। आपको बस एओर्टिक वाल्व और माइट्रल दोनों विंडो ऐसे बनना चाहिए, है ना, जहाँ RA LV LA दोनों वॉल्व्स दिखे हैं, दैट इज ए क्वांटिटी। आप दिख रहे हैं, ठीक है ना। हाँ, थोड़ा सा एंगल आप रोटेट करेंगे तो फॉल्स भी बताएगा, डिपेंड ऑन पोजीशन, है ना। जैसे एकदम से आपने एंगल विंडो सही नहीं बना, हाँ माइट्रल है, हाँ थोड़ा सा विंडो पर, बट ठीक है, फॉर लर्निंग इट इज गुड विंडो, है ना। जैसे ये टिल्ट हो गया ना तो फॉल्स इजेक्शन है ये।
अभी तो कम हो गए, 18 है।
मोशन है, वेल ब्लर मोशन,
कलर लाइट कलर,
हाँ ठीक है। आप कॉन्टेक्ट की, ठीक है, अबाउट 60 अराउंड।
हाँ सब
शॉर्ट एक्सिस उसी को बस रखे ना, हटाने उसी को 90 डिग्री रोटेट करना है ना, ठीक है। हाँ गुड वेरी गुड, ठीक है ना। एट द इट इज शॉर्ट एक्सिस। आप एक अंदाजा जब करेंगे, डेली प्रैक्टिस करेंगे जाके, सबकॉस्टल पॉइंटर लेफ्ट थोड़ा सा नीचे टिल्ट करनी, ठीक है। नहीं थोड़ा कंप्रेस नहीं करिए ज़्यादा, हल्का सा कंप्रेस, ठीक है। थोड़ा नीचे टुवर्ड द हार्ट, आप इमेजिन करें हार्ट किधर होगा, ठीक है। थोड़ा सा विंडो थोड़ा नीचे, LV, LA, RV, RA. You can see it, pleural effusion. ठीक है, हाँ, ये इसमें IVC लेफ्ट बताया ना, टुवर्ड्स द हार्ट। हाँ, लीवर को देखिए, LA को देखिए, यहाँ से निकल हेपेटिक ये इसको देखते हैं ना, सारा एक बहुत बढ़िया, वेरी गुड। चलिए थोड़ा सा, हाँ, ऑप्टिमाइज करिए, थोड़ा सा टिल्ट नीचे की ओर रहता है, पेशेंट नहीं हो रहा है ना, तो थोड़ा सा हेड डाउन थोड़ा सा कर सकते हैं। मेरा मोमेंट तो दे दो। हाँ, सिंगल लेकिन टुवर्ड्स द है वो ठीक है, थोड़ा सा
एक फूल नहीं ला पाए मेरे लिए, अच्छा वाला ये सब ये नहीं आएगा, तो इधर आइए।
ये एओर्टा है ना, इससे कंफ्यूज नहीं होना है ना, थोड़ा सा एक मिनट।
सर इन दोनों में से कौन सा अच्छा लग रहा है?
हाँ,
दोनों एक ही है।
इस पे फोकस करें, कॉन्ट्रैक्ट हार्ट कॉन्ट्रैक्शन दिख रहा है ना, इसको भी, इसका मतलब ये लेफ्ट एट्रियम है, यहाँ से ये हेपेटिक मेम्ब्रेन दिखाई दे रही है, किधर दिख रहा है मतलब
यस
और नीचे हाँ, फोकस करिए थोड़ा सा। आएगा थोड़ा सा प्रैक्टिस है, कर कर देगा, सीधा नहीं, सीधे इधर नीचे की तरफ पॉइंटर पूरा ये। अब थोड़ा सा साइड कर सकते हैं, थोड़ा सा रोटेट कर सकते हैं।
इसमें डाल देगा ना, उसमें डाल देगा।
हाँ, ठीक है, इतना भी मिल गया ना कभी अगर, तो तुरंत फेज थोड़ा सा और का इसको लाइए।
तुम्हारे लिए फोटो लो ना अलग से। ऐसे कर लूँगा तो ये इसके साथ मोमेंटो के साथ
आ जाएगा, प्रैक्टिस से आएगा ना थोड़ा सा।
सीधी का भी ले लीजिए, सीधी का भी ले लीजिए। नाम कहाँ पे है? उल्टा नाम ये हो गया। हाँ बस, तो इधर आइएगा।
ठीक है,
बस और इधर आइएगा, और इधर आइए।
तो नेक्स्ट अभी कौन आएगा? ये है ना, अब देखिए उसमें कैसा रखा है। अब थोड़ा सा चलिए नेक्स्ट। इस सीधे आपने फोर्थ चैम्बर उधर पहले लॉन्ग आप थे आना अभी तक। हाँ चलिए, इधर पॉइंटर टुवर्ड द लेफ्ट शोल्डर, 5th 6th इंटरकॉस्टल इस पे।
अरे ये
हाँ, वो तो देख क्लिनिकल, वो मैं अभी क्लिनिकली उसमें जा ही नहीं रहा, ठीक है ना, बहुत सारे कॉजेज, हाइपोटेंशन, कोलेस्ट्रॉल। हाँ तो देख सकते हैं डायलेटर, उसमें तो ये डायलेटेड है, तो मतलब थोड़ा सा फुल ओवरलोड में है, CCF में पेशेंट है। हाँ बहुत ठीक है, थोड़ा सा और क्लियर इमेज करें, ठीक है, बना रहे हैं ना मेटल वॉल। शॉर्ट एक्सिस करें, इसी को 90 डिग्री टुवर्ड द लेफ्ट शोल्डर से, प्रोब उठाना नहीं है, थोड़ा सा स्लाइड कर सकते हैं। हाँ, 90 डिग्री रोटेट करिए टुवर्ड द लेफ्ट शोल्डर, लेफ्ट शोल्डर, और करिए। हाँ, ये जो विंडो बन रही है भी, और बस है ना, दैट इज अ शॉर्ट एक्सिस व्यू, ठीक है ना, बहुत बढ़िया। कॉन्ट्रेक्टिलिटी गुड, ठीक है। अब सब कोस्टल है तो सब जिफर्ड। हाँ, ये एंग इधर नहीं, टुवर्ड द लेफ्ट, ऐसे फ्लैट थोड़ा सा फ्लैट जाना है, ये दिख रहा है, लेफ्ट मैंने बनाइए, LA, LV, RA, RV, पेरिकार्डियल इफ्यूजन देख सकते हैं, है ना, कार्डियक टेम्पोनल इधर, ठीक है। IVC, हाँ इसमें IVC के लिए हाँ इधर नहीं, यही रहेगा, सब कोस्टल विंडो इज गुड फॉर IVC टुवर्ड्स द हार्ट। अभी आपने देखा ना मुझे और ने किया डॉक्टर साहब ने। यहाँ दिख रहा है ना कॉन्ट्रेक्टली, आप समझिए इधर कहीं है ना यहाँ, हाँ तो ये फोकस है उसमें बनाइए, ज़्यादा इधर नहीं लाना है, हाँ बस बस इतना, थोड़ा सा नीचे और नीचे साइड कर लीजिए, थोड़ा सा नीचे देखिए, नहीं नहीं ये देखिए ना, ये आएगी इधर इधर, कोशिश करिए, ये एओर्टा हो गया, एओर्टा उधर नहीं, उधर नहीं, अभी इधर से यहाँ से आके बनेगा, यहाँ कहीं बनेगा नहीं, आप वो बिल्कुल ठीक है, ज़्यादा नहीं देना, सिंपल रखना है बस, ये देखा ना, है ना, ये ठीक है ना, थोड़ा और क्लियर करेंगे, आएगा प्रैक्टिस आएगा फिर धीरे धीरे आपको, ठीक है ना। हाँ मेजर के लिए मैंने बताया, अगर आपको एग्जैक्ट मेजर करना है तो बस एकदम हाइपो वॉल्यूम है, शॉक में है कंडीशन, तो एकदम से पूरा 100% 90% पूरा कोलैप्स होगी ड्यूरिंग द इंस्पिरेशन। तुम तो चलो सारी विंडोज बनाओ, लेफ्ट लेटरल पोजीशन पे थोड़ा सा करके, लेफ्ट डिबिक्यूटस थोड़ा सा एडर होना है, बहुत बढ़िया, वेरी गुड, दिखे ठीक है, नहीं ज़्यादा गेम बस कम रखिए थोड़ा सा, हाँ ठीक है, विंडो थोड़ा सा टीजीसी में जाएंगे ना, टीजीसी लॉन्ग एक्सेस, थोड़ा सा विंडो थोड़ा सा भी, हाँ गुड, ठीक है ना, लॉन्ग एक्सेस 90 डिग्री रोटेट, क्वांटिटी देख लिया तुमने, गुड, 90 डिग्री रोटेट करिए, बस 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 ना लगभग है ना, ठीक है, थोड़ा सा स्लाइड इधर करिए, हाँ तो वो टीजीसी है ना, आपको जहाँ इधर कम लग रहा है उसको आप उधर गेन, ठीक है, 4 चेम्बर, हाँ देखिए ये है ना, ठीक है, लॉन्ग एक्सिस, शॉर्ट एक्सिस, 4 चेम्बर करिए, 4 चेम्बर, हाँ ठीक है वो वॉल दिख जाएगा, ठीक है ना, 4 चेम्बर के लिए क्या है पहले, नहीं ये तो सब कॉस्टर, ठीक है, सब कॉस्टर बना लो, हाँ लेफ्ट, हाँ लॉन्ग एक्सिस में भी करेंगे है ना, बेटर के लिए, हाँ सब कॉस्टल में, हाँ इधर लेफ्ट हाइपोकॉन्ड्रियम की तरफ, 5-6 इंटरकॉस्टल स्पेस पे लगभग है ना, हाँ ठीक है अभी आ जाए, ठीक, एरिया नहीं, टीजीसी वो हो गया, नहीं करो, ये तुम ये इधर पाके, ये ऐसा प्रोब उधर रहेगा ना, लेफ्ट देखो, तो ये एपेक्स पे रखो लगभग 8 किधर, 4 निपल 5-6 इंटरकॉस्ट, और थोड़ा सा बनाओ इमेज, हाँ गुड ये आप देखो इधर, ठीक है ना, लगभग थोड़ा सा